put the patient on close observation, because leukoplakia might change into speckled leukoplakia. That's why we have to have biopsies every now, or let's say on a yearly basis at least, in cases of leukoplakia. In erythroplakia, it is a different story, because 91 of these cases of erythroplakia, they show severe epithelial dysplasia or carcinoma in situ, or even invasive carcinoma at the time of diagnosis. And it might be by itself actually a presentation of squamous cell carcinoma. Speckled leukoplakia, speckled, that is when the lesion is a combination of white and red patches, is the most common presentation of, is one of the common presentations of oral cancer, and it carries in general a higher, the highest potential for malignancy in all kinds of leukoplakias. Chronic hyperplastic candidosis, as I said, it is a pre-malignant condition. Usually it may be speckled or a red patch. Also, patients tend to have underlying hematinic deficiency or even HIV. Verrucous carcinoma is a superficial exovitic presentation of squamous cell carcinoma, mainly in elderly heavy smoker patients, but it has a very good prognosis with simple excision. This is the most common presentation of oral cancer, which is the fungating ulcer, as you see it on the lateral side of the tongue. This is a case of maxillary cancer, which is presenting as a swelling, and the bony invasion led to this substantial bony expansion, or that massive increase in the size of the maxilla. Maxillary cancers usually are removed or resected via Weber-Ferguson resection, as you see here. Unfortunately, as I said, most of the cases are late presentation, and in this case, the tumor was invading the orbital contents as well, so that's why we had to remove the floor of the orbit. Floor of the mouth is a very common presentation, and here you can appreciate the difference in the early presentation and late presentation, which involve now the alveolar ridge, the lower jaw, on top of the floor of the mouth as well. The lower lip, which is the most common site for oral cancer, is usually it's a simple surgery. Even when it involves 2/3 of the lip, it still can be closed primarily. And even in cases which entails subtotal removal of the lower lip, still good closure can be achieved, and good outcome we can reach to. Here, this case is I'm presenting it just to show you the meaning of late presentation. This is supposed to be a retromolar squamous cell carcinoma, but as you see on the MRI, it is involving the mucosa, the whole cheek, and clinically, as you see here, it jumped from the lower jaw, from the mandible to the upper jaw. That's why we had to do partial maxillectomy for him. This is the inner block resection and reconstruction. The tongue, the second most common after the lip, which involves sometimes hemiglossectomy, subtotal glossectomy, and sometimes even total glossectomy. Still, in hemiglossectomy cases, they heal nicely, and the patient can regain all the functions of speech and swallowing back in a few months' time. Children also present to us, unfortunately, and the presentation of oral cancer might be associated with the parapharyngeal involvement. And that was actually a case actually I've done with Dr. Ma'moon. If Ma'moon is still with us, he provided a great contribution, because the tumor was encasing the common carotid artery. This entity of the parapharyngeal tumors, which might present orally with an oral bulge or extraorally, it entails a long list of differential diagnoses ranging from schwannomas to pleomorphic adenomas to lymphomas. So that's why we have to start with biopsies. And once the tumor is resectable or the surgery is the treatment of choice, we have to go for surgery. Still, we are lucky in our region because we have very good blood supply, so wounds heal, and in many cases we end up with a very good outcome, despite the let's say the destructive or the extensive type of surgery we go through, unfortunately. Talking about late presentation, this is actually a very late presentation, but unfortunately, this presentation might be the first presentation to our clinics. Patients present to us with this condition. So, as I said, I would like to talk a little bit about early presentation or early detection of oral cancer. I would like to say that it is a good investment because it is easy to diagnose and simple to examine. We don't need to do, let's say, colonoscopy for colon cancer or mammogram, a costly procedure. It is something that is based on the awareness of both patients and practitioners by just being vigilant and aware of any change in the oral cavity that requires biopsy or follow-up, and not to ignore it or treat it as if it is just a simple infection and keep giving patients antibiotics for ages, and then they present to us after a few months with this kind of clinical picture. So my focus, or our focus, should be based on dental practitioners, general practitioners, dermatologists, and ENT surgeons, because most of these late presentations usually come from referred by those medical disciplines. As I mentioned, the last thing I would like to focus on the importance of the neck management in oral cancer, because ignoring the neck in oral cancer is considered, in my opinion, is failure of treatment. In oral cancer, we are basically concerned in levels 1 to 3, that is supraomohyoid neck dissection. We go down to level 4 in certain cases when we are facing positive necks, or in cases of tongue cancer in particular. This is an example of neck dissection we perform. That's level 1A, 1B, and levels 2 and 3. That's upper jugular and middle jugular. The neck dissection was first described by Kocher, who described it in the year 1880. And he was awarded a Nobel Prize in 1909 for his work in thyroid and neck surgery. He was the first ever surgeon to be awarded Nobel Prize. Hope not the last. Or could be the last. So, as per the American Society of Clinical Oncology clinical practice guidelines, for patients with oral cancer who present with clinically negative neck, N0 neck, 10 to 40% of the cases, they end up with occult nodal mets. So 1/3 of the cases, it has positive node in N0 necks. As such, the management of the neck is a critical component of high quality oncologic care of these patients. So the trend now is to treat the neck prophylactically in N0 necks, because 1/3 of the cases, they turn up to be positive. So we do the 2/3 for the sake of the 1/3. To talk in a more specific pattern, as described again by the ASCO, for all cases T2 to T4 with N0 necks, they should be offered ipsilateral elective neck dissection, supraomohyoid neck dissection. For patients, we talked about 2T to T4. For T1 N0 neck, they also should be offered ipsilateral neck, supraomohyoid neck dissection. Alternatively, for this peculiar group, that's T1N0, for selected highly reliable patients with T1N0. Close surveillance may be offered by the surgeon in conjunction with a specialized neck ultrasound surveillance technique, so that to monitor the patients in case of any change in the neck that requires neck dissection. So it's just the T1N0 who can escape our formula from neck dissection. For patients with the N0 neck, the ipsilateral neck dissection should involve levels 1, 2, and 3. And also to say that this is adequate surgery or adequate dissection, it should include at least 18 lymph nodes. So that so as to give an idea about a true idea about the true nature of the neck for those patients. An ipsilateral therapeutic selective neck dissection should be offered, of course, for the clinically positive nodes. For those patients who are N positive, the surgery for the neck should involve levels 1, 2, 3, and 4. And again, also the adequate dissection is called adequate when it involves 18 lymph nodes. For patients with N positive contralateral neck, a contralateral neck dissection should be performed as well. Also, a contralateral neck dissection should be performed for contralateral neck when we are dealing with cases of oral tongue and floor crossing or approaching the midline. So the ipsilateral neck is definite for all in positive necks, but we might, or it is advisable to go for the contralateral side as well in cases of the oral tongue or floor of the mouth, which is approaching the midline. So to finalize, the objectives of cancer surgery should entail complete excision, to remove adequate margin as well, and to remove, when necessary, all potential channels of likely mets in the lymphatics or nerves, and to promote rapid healing by restoring function. The causes of failure mostly is due to local recurrence, that's persistent primary disease, distant mets into 10 to 30%, and secondary primaries into 10%. So to take home message, if you allow me, please, we have to focus on early diagnosis. We have to consider neck management as an essential part in the management of oral cancer. And we have to consider the multidisciplinary approach to reach for a proper or good standard of care for our patients. Thank you very much. Thank you.
Thank you, Dr. Median, for the informative presentation. Let me ask you a question, please. Dr. Ma'moon and Dr. Median, do you see the role of oncovascular surgery in complex advanced disease, like in angiosarcoma? Dr. Ma'moon, can you answer?
Sure. Well, first, great talk, Median, and thank you for reminding me of that case. I remember it very well. And
Shukran, Ma'moon.
little girl have done very well. Angiosarcomas are quite challenging when it comes to therapy, because they're not usually limited to a single vessel, and they're usually sort of permeate the whole vascular structure they present to. And amazingly enough, they frequently present with embolization rather than effects on the local tumor. The prognosis is with angiosarcomas specifically is not that good, I'm afraid, especially that they usually happen in elderly age group. And whatever you do, you're ending up doing sort of palliative intervention. Does aggressive surgery have a role? Only to relieve complications, rather than a therapeutic role, because they can present with bleeding, erosion, embolization, etc. and you do have a job to control, and they typically present very late. We use in the old days, whenever we do an embolectomy of a thrombus, we send it for histology or sort of study to get if it's sort of the source of it is an angiosarcoma. But these days are gone by because the pickup rate is extremely minuscule and it's not worth the effort. They're extremely rare.
Thank you, Dr. Mamoun. Dr. Suha has a question. Dr. Suha, go ahead.
Thank you for the presentations, Dr. Mamoun and Dr. Midian. Actually, this is an advanced talk. Okay, so this is an advanced talk, but it is, I don't know if both of you were in the meeting session and the panel and the discussion where we started talking about involving cancer or care in Jordan and all the subspecialties. Sorry. The question is, how can we incorporate these subspecialties in the public sector?
Mamoun first.
Thank you, man. You're so kind. I think there's a great need for the subspecialties to be involved with this. And like Median said, this is a multifaceted, multidisciplinary exercise wherever the place is. In the public sector, I hear and I hope this succeeds, that be it Al Bashir Hospital, are doing a great job with the new sort of surgical specialties place or venue. Both Median and I worked in the Royal Medical Services, and most of this work we've done there, and we could do because of the setup of the public sector. It's more difficult to do in the private sector, but the need for it is massive because these patients are demanding, it's costly business, it's multidisciplinary, and the care does not stop with the surgery. It's a sort of an ongoing thing that other modalities are involved with.
Thank you, Dr. Aswa. Actually, I've been during the panel discussion, and I wanted to participate in it, but I couldn't have the chance because everybody was interested to participate. I totally agree with you that Jordan is a small country, and the different medical institutes in Jordan, they should collaborate together. And I don't think we can go anywhere if each sector set his rules and acts as if it is the only sector in Jordan. So a collaboration between us is a very, very important thing, first of all. Secondly, what I would like to emphasize on is when someone mentioned the role of the Minister of Health, I think it is not the responsibility, it is not a political responsibility by the ministers. The burden actually lies on the shoulders of the medical societies, the specialty societies, and the different medical sectors like the university hospitals, the KHCC, the KHMC, and the Ministry of Health to set their rules and to set their guidelines based on international guidelines to end up with Jordanian kind of guidelines so that it will monitor and govern our practices. For example, actually, as Mamoun said, we are both and will be always very proud as we used to be part of the King Hussein Medical Center, the Royal Medical Services. But to be honest, my experience at KHCC now is quite different. For example, when I say that I cannot take a patient to have a biopsy in the operating theater without an MDC decision, this is something we have to emphasize and we have to integrate in all of our medical institutes, because that will lead to the essence of working in a multidisciplinary fashion. We all know that sometimes surgeons, they act independently or individually without any collaboration or with medical oncologists, and vice versa, the same happens. So I think the medical specialty could the I don't know ممكن النقابة the dental medical unions or the جمعيات الأورام وجمعيات الجراحة المتعددة اللي لها علاقة بالأورال كانسر أو بالكانسر sorry in general should dictate guidelines so that we don't end up with any kind of malpractices, because I think the floor is open for malpractices because we do not have guidelines.
Well, yeah, I agree. And, but regarding the role of Ministry of Health, I think the consensus in the morning was that we need the umbrella of the Ministry of Health when we talk about at least malignancy and cancer. Maybe with the other things, it's not the same. Again, I will stress the fact that we have to do this as physicians. I guess one of the speakers in the morning, he indicated that Jamiyat and the associations are not doing their, or are not interested in doing a collaborative work. And I think this is the problem, because if you can see, even before the area of the corona, each society would do its own conference, its own speakers, and they don't even care if the other multidisciplinary that are related to their conference are attending or not. And that's like basically a very simple thing to talk about. So when you come about to talk about clinical care, things become really different. So anyhow, I'm not sure if, Dr. Apreen, if there are any other questions, I think we will end the session. So
thank you, Dr. Midian.
شكرا دكتور.
All the best.
Thanks. نسكر السيشن، ما بدنا نغلقه بشوي، صار في جلتش، ما بعرفش كيف معقول نخليها ساعة مفتوحة. What do you advise?
Yes, and we'll be back at 3.
We'll be back at 3. Okay. Thank you. Thank you. Thank you.
يعطيكم العافية جميعا.
أهلا دانا. Dana, you're muted.
It seems إنه في technical problem. يعطيكم العافية جميعا.
أهلا وسهلا.
إنه في technical problem. Some people are not able to log in. So we will use the same way. Unfortunately, we will close this room and Dr. Suha will reopen it again so everybody can join us. في مجموعة كبيرة are not able to join. I think دكتور محمود سرحان كمان أنت كنت من المجموعة اللي were not able to join.
هلا I am on. ما بعرف إذا الجميع موجود.
بس في مجموعة منيحة. فدكتورة سهى will end the meeting and we will ask you to rejoin again. I'm sorry for that.
The same link, utilizing the same
link, yes.
Okay,
same
great.
Okay, let me write that down.
مساء الخير مهندس دانا. It's the same link اللي على الزوم ولا على الريجستريشن لأنه we are given as speakers as the Zoom link.
The same Zoom link, yes.
شكرا.
Okay.
الله يعطيكم العافية. I think we need to log out all of us الموجودين هون. في معنا الدكتور محمود، دكتور حازم، دكتور عايدة، دكتور مازن.
مساء الخير.
مساء النور.
دانا انت موجوده؟
Yes, Dr. Sehat. أنا موجودة. Thank you so much.
I really apologize. ما بعرف ليش عم يصير لنا هاي technical problems مع انه كانت الامور ماشيه. بس اعطونا couple of minutes احنا we're solving it out. Okay. But it has to do with the recordings.
Sure.
Shall we start the session?
Yeah, sure.
Okay.
تحبوا نبلش؟
Yes, please do.
So while we're sorting out all issues, let me check if we have all our speakers. Dr. Mohammed Oude, are you there? He was with us a while ago. دكتور عمر النمري موجود؟
نعم.
أهلا دكتور.
This is Dana. May I suggest if you want to, I will try to connect with Dr. Mohammed Oude. I don't know. Can't see his name. And you
But
can.
He was there in the previous link. He was there. هلا, would you like to start?
Because of the time, because it's already 8 minutes past 3.
Okay, I will start مع الدكتور النمري until Dr. Oude joins us. Okay. Welcome after a long break. This session is the strategy in cancer care, and we will be starting مع Dr. عمر النمري, and he will be talking about towards strategy implementation in cancer care in Jordan. Let me first introduce our well-accomplished speaker. Dr. Omar Al-Nimri is the head of the Cancer Prevention and Control Department at the Ministry of Health. He's the director, PI, of the Jordan Cancer Registry, the National Registry, and at the Ministry of Health envoy and member of the Technical Committee in the Council of Arab Ministries of Health Arab League. He's also a member of Izmir Hub Advisory Committee, Cancer Registration, the member of Euromed Cancer Project, and he's also the executive board member in the Cancer Society in Jordan. He holds a master's degree. He currently from the University of Jordan, and he's a board member of community medicine and Arab board member of medical specialization, and he holds diplomas in cancer prevention and cancer etiology from University of Michigan, in addition to many other degrees that he holds. Dr. Ode just joined us. We will be starting with Dr. Omar Al-Nimri, and then we'll go back to you. Dr. Omar, please, the screen is yours. Dr. Omar, I cannot hear you or see you. Are you there? Maybe we've lost. So I guess maybe Dr. Ode, we will be starting with you after all. Looks like you were meant to start. Okay. Until Dr. Omar joins us, I will introduce Dr. Mohammed Ode. Okay.
Thank you. شكرا.
سوري مهندسة دانا لو سمحتي بس ممكن بس لو تحكي again أنا I have to stress the fact إنه إحنا هلا على اليوتيوب لايف كمان. أنا آسفة إني أقاطع بس عشان اللي ما بيزبط معاه زوم إحنا كل everything is on YouTube live إذا بتحبوا تفتحوا على صفحة تموز أكاديمي على اليوتيوب. أوكي.
Yes, please share it بالجروبs. share it بالجروبs لأن الناس اللي هون.
Share it also as well. بس أنا just want to indicate لهذا الشغلة. أوكي.
لا بس الناس اللي هون they're already with us. I think the people who can't be with us, it's really helpful to be on YouTube as well. Dr. Ode, it's a pleasure to have you, Dr. Ode. So, Dr. Ode is a professor of Cancer Care Informatics, and he's the co-director of Cancer Care Informatics at King Hussein Cancer Center. He's the head of the Software Engineering Research Group from 2012 till 2020, and he's joining us from Bristol, UK, from the University of West of England. He has a PhD in software engineering from Bath University, and he's a very distinguished scholar with many publications and books along the way. He's very distinguished, and I will not waste the time in introducing him. I know he has a lot to share with us. The floor is yours, Dr. Ode, Professor Ode.
Shukran. Thank you so much. That's very appreciated for the kind invitation, and it's an honor for me to be with the Sehat Watan initiative today, and especially for the annual day for the Day of Cancer. Many thanks indeed for the invitation, and many thanks indeed as well for the introduction. Thank you, Ms. Dana, and also for all the colleagues who have been really very hardly working on the arrangements for the day. First of all, I would like really to start by sharing really my slides with you, and I hope that you will be able to see them shortly, inshallah. So my really aim today is just to hopefully pave the way for thought-provoking for the role of cancer care informatics and empowering the journey of the cancer patient. This is really very important, I would say, to start with. The second really aim for me is as well to develop as much as possible networking with colleagues who are really interested in really working in a multidisciplinary team to use or utilize informatics to empower the role of the cancer patient journey and cancer care institutions as well. So I welcome really any really collaboration. I've got my emails as well there on the slide. You can see it now at the bottom of the slide. Many thanks indeed. Just I'm really a little worried about the time that I may not be able to cover, but all what I want to say, but I'm just trying to really to pass a message here as much as we can, inshallah. So to start with, I will be running really in full screen mode, hopefully that it will allow me now to do it. Okay, so it's not allowing me to do it in full screen mode, so I'm trying really to do it in full screen mode. Yes, now it's working. I hope so. You can see it. Okay, so we'll move first. I would like always to start with the Bismillah ar-Rahman ar-Rahim. Walhamdulillah wa salatu ala Rasulullah. And just to remind ourselves that سنريهم آياتنا في الآفاق وفي أنفسهم حتى يتبين لهم أنه الحق. It's just to remind ourselves that whatever really we do, we have really to observe and learn that really what we have in terms of knowledge is just really just tiny of dots of things that we still really don't know a lot about. Thank you. So the agenda is about actually first is the cancer care and the patient journey, and then I would like to go into really my sort of philosophical really conceptualization about really the waves of cancer care informatics, and I really have divided them into two waves of cancer care informatics. And here to start with, as you can see that all we are as a multidisciplinary team, we aim to work together for really the sake of really as you can see here, is really looking after the patient. Okay, so the patient is actually is the center. Okay, is the center of our interest here is actually the patient. Okay, and hopefully that we will try as much as we can today to learn and see what we really mean by first of all the difference between oncology. I'm sure you know this, and you teach me that, all of you, the difference between oncology and cancer care. So just as a quick definition of oncology, which I picked from the National Cancer Institute, which is actually related to NIH in the US, which is referring to it as a branch of medicine that specializes in the diagnosis and treatment of cancer. And it includes the medical oncology, where really the reference goes to chemotherapy, hormone therapy, and other drugs. But at the same time, of course, it goes into radiation oncology, surgical oncology, etc. So here we are talking about really the oncology as as really is for the diagnosis and treatment of cancer, but we haven't really talked about really the whole really life cycle of cancer care, which includes here not only just the aspects of the diagnostic and treatment, but as well the other aspects to do with the different levels of counseling, the strategic levels of cancer care for the cancer care organization, the families, the financial support, the social support, all these types of really supporting activities that should be really included as there. So when we define cancer care, I really had the honor to really put this definition in 2015 by the end of it, which is when I was visiting we were working on actually the first workshop in cancer care informatics in King Hussein Cancer Center, that magnificent really center in Jordan and in the region as well, and in the whole world. It's the definition I put forward is about comprehensive care for the cancer patient as a whole. So including all their needs, not just actually the medical and physical ones. And this is using the many really services of different professionals that really they work together. Okay, so if I may start here, just because of I'm very conscious of the shortness of time, that we are really here, we are in this world here, at this level here, we are actually in the world of cancer care. And these are my colleagues that we really work with in cancer care informatics, including our precious director, Dr. Asim Mansour, and Dr. Abdul Ghani, and Dr. Iyad, and Dr. Suha, and the rest as well of the team that we have from University of Jordan, Dr. as well, Nancy, and the rest. And these are actually our as well MSc Cancer Care Informatics actually associates. So let's say these are actually on my left-hand side, or your left-hand side is the cancer care world, and on the right-hand side is the digital world. So we're trying really to bridge the gap between these two worlds in one direction, and bridge the gap actually in as well in the other direction. So it is not really a straightforward thing, because we need to make sure that we preserve the independence, the autonomy of the cancer care world, and at the same time for the guys who are working really, whether these are humans or non-humans working at the systems level. So you can see that how we want really to pass the message and as well backwards. And at the same time, we would like to be working really in really a sort of a bi-directional way. But at the same time, we preserve our autonomy here and we preserve as well our autonomy there. Okay, so this is really very important really to have as a perception to start with before I go into my topic in detail. And really now is what is meant really by cancer care informatics is just simply empowering the process of cancer care using informatics to have that empowerment. And this is really a holistic really empowerment, and with all the concerned stakeholders, including the patient as a stakeholder, the nurses, the pharmacists, the physicians, the surgeons, the different really levels of stakeholders, wherever they are really in the process of cancer care, they will have to be really involved. So in other words, as you can see in this really diagram, I've added actually you can see the digital hand. So you've got really the human hand and as well the digital hands, they are actually working together. This is what we call really the socio-technical really system. And the socio-technical system where you have really those informatics really services or functionalities that can be provided by the information really systems or information technology tooling that will be hand to hand with the human hand as well at different levels. Even the patient as well, having an app and having really a follow-up, he or she, they are considered as socio-technical really systems. So that the patient is, when they have the information systems support, the app that they use, they are called socio-technical systems. Okay, so here we come to the classical really, which I have really modified this, and I included my own really sort thoughts, which I'm very happy to receive as well. This is feedback on it, which I'll be talking about it later on in a forthcoming really publication. And here is the classical view of really the cancer patient journey is to do with cancer screening, cancer diagnosis, and then cancer treatment. Okay, this is the classical view. And as you can see from really this actually adapted diagram, is to do with the cancer experience really journey. And you can see the phases that the cancer patient really goes through. Okay, starting with the diagnosis, moving to treatment, moving to what we call active treatment, and then just even before the end to do with the recurrence. But at the same time, look at really the different functionalities that is really needed, that are needed really there, including as well all the counseling and the social support that is needed. And please forgive me because I'm going a bit fast because I want to cover as much as I can in this actually very short really duration. Okay, so as you can see, my colleagues, you can see very well here that, and these two really boxes that you have on the left-hand side, you can see many things that are related to the patient. The cancer patient is unique. And every cancer patient is unique in the journey of the cancer. So the cancer patient is unique compared actually to the diabetic patient, to maybe cardiovascular patient, to any really sort of really illness. And cancer patient is actually unique, and every cancer patient as well is unique. And every cancer institution, hospital, center is as well unique. And when it is placed in some particular really context within particular cultures, regions, then and as well accreditation levels, etc., becomes as well its own really uniqueness with its own matrix and KPIs, key performance indicators. Okay, so that is really very important to take as a perception because we're looking at the holistic review to cancer care, and also the dynamic nature of cancer management. The cancer management is really very uniquely very dynamic compared maybe to other illnesses and compared really to what to develop to the patient during his or her really journey, and the variability and agility of the diagnostic options that are really available as well. So this is not really an easy thing really as well to perceive in terms of the variability and the agility of the diagnostic options, and also the variability and agility of treatment as well options. On the other side, in the other box, you'll see that you've got the variability of the serving systems. And here you can, of the served systems. And you can see me here actually putting the patient as a served system, the nurse as a served system, the physician, the pharmacist as a served system, the palliative care specialist as a served system, financial counselor, the surgeons. These are all served systems. So we need to look at these as actually these systems to be served, okay? Who are actually those serving systems in that context of this actually systems working together? These are actually the cancer care information systems, that are around, not only just only the patient really information systems or the electronic medical records or the health records systems. No, not much more that to do with really strategic as well systems, pharmacy systems, nursing systems, financial counseling, palliative care systems. All of that they need to be working together. And also we have the variability of laws and regulations, and also we have as well the agility of the cancer care processes. As we said, that the cancer care processes, they are dynamic, they keep changing, and the environment really around as well directs actually those really changes. So let me just go straight away into the first wave of really cancer care informatics, and this is purely really my categorization. This is my classification based on really those years of working in the field, and I've been very honored to have really started working with King Hussein Cancer Center in research since 2003, and this is really very honorable to me, and many thanks indeed for them as well. So the first wave really goes mainly, I classify it as doing diagnostic imaging.
We only have 1 minute.
Only? I haven't
Yes.
done. I learned it's 20 minutes. Okay.
Yeah, but I cut 3 minutes from each speaker, unfortunately.
Okay. All right. Okay. So we have these actually first informatics wave into cancer care to do from diagnostic to even using AI and precision and personalized medicine. These are actually not new. And I don't want to, because now I've been really cut in terms of the time. So just to do with mammography, I'm just walking through, and as well moving from the systems to really the solutions at the end that you can see with imaging, and using as well process architectures for the organizations and how we improve the processes with manual and really less manual really tasks and information really entities. You can see that. And also looking at the artificial intelligence actually, and is it new? And you can see from 1950s, the AI was used, and I'm quoting here even an application from in 1979, and the role of really AI and how it affects actually the AI patient, and as well the medic as well. And you can see there, even I have some reflections about really IBM Watson, and IBM Watson, they spent so far, to the best of my knowledge, is about actually 10, well, they started with 1 billion and they moved into $4 billion, and still actually it has shortcomings. It has not been really rated as a successful really system in AI in terms of really providing the best of really diagnostic really and treatment options available, and there are so many of flows. And you can see even in some of the really applications in Southern Korea, 49% of success. So there are really failures. And you can see examples of actually no commercialization has been added. This is actually to do with what? With Watson. Okay. Now, if you go into the second wave, so this is very importantly in terms of really here, this is what, thank you for letting me saying that. For the second wave, we need to think about, is it really simple? Is it simply cancer care informatics? It's not. It's not just simply cancer care and informatics. It's informatics really going really threaded into the cancer care. So there is really multi-threading going into the cancer care. And this is really my sort of really view of the cancer care informatics process. So it is, I look at it really as being really completely different. You can see from the classical view, you can see that informatics is really is going across actually as a main thread. And you've got the classical as well process there. And at the same time, you've got lifelong learning. You've got research and development, you've got supportive care, you've got quality management, change management, management of change as well. So it is really a holistic process. You cannot do this without having the informatics with it. So if I this is actually summarizing to you the view regarding really the second wave. And the second wave really needs to be looking at strategic strategies and goals for the cancer care organization. The process architecture, how the processes inside those centers actually are floating around, and the relationships, the information strategy and really related architectural aspects there. Also the software cancer services that are provided to the different stakeholders, and also how we can make sure that we provide really intelligence from really the data, really analytics based on the big data, and as well performing what really we call here digital cancer genetic counseling, precision medicine, change management, quality governance. But the most important thing is what? Look, my friends, this is what I have actually circled here, is interoperability. This is actually what defines, in my view, the usability. So if you want to ask me whether you have a usable really system, or a usable really service provided in cancer care empowered by informatics, then you need to look at really the interoperability really level. Okay, so these are actually here very important aspects of really the founding of the discipline that we started with King Hussein Cancer Center jointly with my really precious colleagues, Dr. Asim, Dr. Abdul Ghani, and Dr. Ed, and the rest of the group, Dr. Suha, and many as well from outside, that we have been really working together on the development as well as we go. And very importantly, I would like to mention to you is really we'll be very delighted. We've got the second really run of the first international master's program in cancer care informatics, and we are doing the launch in for the recruitment in April. So please, I'm very happy really to work with you and my colleagues in King Hussein Cancer Center as well to, inshallah, really promote the event, and as well as much as we have our first ambassadors and they are about really to complete. So we can see that we have so much really that we have really been trying really to work together in terms of really providing really possibilities of answering some of the key KPIs here that we may be interested in terms of really how we look at as well answering or adhering to the as well to providing that what we call really qualitative and quantitative as well evaluation of how good we are doing really in really facilitating the care for the cancer patient. And I brought here an example from breast cancer, but I know the time has been cut. I cannot really go more than that. Also, we need to look into aspects
Actually,
of how.
Dr. Aoud, you are very popular. People want to hear more from you, so you have a couple of minutes also.
Oh, that's very kind of you. That's extremely very kind and very humble from you. Thank you so much. So we have as well the United Nations Sustainability Development Goals, these 17 goals that we always been asked about how really you adhere to that. And many of really these goals, they need to be answerable through as well the cancer patient really journey. And we need to look at that. We have done some research as well, and we published some work in this really direction with King Hussein Cancer Center, and as well of my colleagues Ian Beeson as well, and undertaken actually some research as well there. Okay, so traditionally you've got what we call really the tumor board in cancer care centers, and you can see how the cancer, the tumor board or the MDCs, they work in cancer care organizations, and you can see those actually big minds, they are actually think tanks, they are working together in order to provide really the best really sort of maybe protocol of treatment for a given really case of a cancer patient. However, we would like to really move further by saying, well, we are not trying to replace actually those really physicians by really software services, but we are trying to say that, well, the palliative, maybe the care, maybe the radiology or the radiological or diagnostic really imaging, they can be not replaced, but they can be complemented by what we call really radiology software agents, medical oncology software agents. And you can, so before those actually colleagues, those think tanks, they meet in the meeting, then you will have those actually working, those agents, software agents, they are working in each specialization, and they are coming with really a fantastic, really summative report for them to read or see or be presented with before they start their tumor board. And I attended some of the really tumor boards, and I was so much fascinated by the way that they work. But at the same time, I recognize that there is a lot missing actually in the information that they need to have, and the timely needed information, because there may be some case remote somewhere in the world that has been treated by certain maybe types of drugs or maybe levels of chemotherapy and or maybe surgery and combination of treatments, and there were really maybe a protocol that really worked better, or maybe a drug that worked better, and it really made really a bit of a difference or more difference for whatever really we could make to the cancer patient is really significant. So really here we are not looking really to replace really the nurses or the physicians or the pharmacists, but we are here aiming to really complement them and add to them. But the risk here is that we may start to think about, well, it's actually a black box really solution, which I'm against it completely. I'm against really thinking about really black box because there are so many ethical issues as well to do with the black box solution. So simply, if you apply really artificial intelligence, as I said, I mean, artificial intelligence or applying AI in really healthcare has been really since 1950. It's not new. All these buzzwords that we hear about actually AI and big data analytics, well, big data because of actually the volume, the variety, the veracity of the data, many of these dimensions that time does not really allow me to go that. But if you really, I like actually, Susie, when she was asked about this question as about 2 plus 2, she answered by it depends. And her mom, maybe, or her teacher, she said to her, well, this is not low. In other words, what we really hear very, very much, I would like really to pass a message here is that with AI and with data analytics, we are actually looking at correlations, not rather than causations. Okay, so we are actually providing correlations. And in medicine, because it is evidence-based, this is actually the golden rule. Possibly it needs to change at some point. Is that the golden rule is actually, it looks at evidence-based. I need an evidence to show me. I need to look at the causation. I need to look at those actually causation relationships. Whereas actually, when you move into really data analytics and AI, you will work in the field of really correlations a lot. So are we going to accept really correlations? Okay, and here, with the big data, these are actually very important because we're looking at the holistic view of having really all of these services providing the support for the patient as a cancer patient. So there are aspects to do with big data challenges. There is actually the aspect to do with precision medicine and big data. The black box, is this actually black box? Which really sort of really version of this black box as software? Is it version 1? You've got Windows version 10, or maybe Mac OS version 1. What sort of algorithms are really in these actually black boxes that actually we would like to really use and utilize? Where are really the liabilities of these actually cancer care organizations and also the providers of these software systems? And there'll be as well here the role of the FDA in this regard as well. What about actually big data and as well and ethics? And as well big data and in terms of really the privacy, also the sharing of the healthcare records as well. What about malpractice when we go into really more of actually having the automation really going really in terms of extremely really hand by hand by the professional staff in the cancer care journey? What about intellectual property rights and the patents? Because when we use the patient records and we deduce new knowledge, because applying really data mining and machine learning algorithms, then what will happen if we create new knowledge? Who owns that knowledge? The patient participated in that, the cancer care organization participated in that, and is it really that company that worked with us to generate really those algorithms and actually that knowledge, and then we just say that we own it? What about the others that have been really involved really in the process? So it's really very important really to reflect on that and try to think about it. I'm actually putting really thought-provokings here. Is ethical really driving legal? Is ethical equal to legal? We have to be careful about that. Not everything that is really legal is ethical, but maybe that everything is ethical should be maybe going into that direction. So we need to think about whether the era that's really coming in terms of AI, and by the way, my talk is not saying that AI is actually the second wave. No, AI has been there in the first wave. So what I'm talking about here, as what I'm saying, is that we are looking at really at a holistic really use of informatics, whether it is to do with the modeling of the cancer care processes, the information consumed and produced by these processes, the information floating around from inside and outside, and how we can deduce data, how can we consume data, can we generate intelligence of these data as well. So AI has been really there for really about maybe more than 70 years now in the healthcare field. But what we are really now and we need to look at why, like an example like IBM Watson has not really succeeded. We need to understand really, after really spending about $4 billion, and IBM wanted to do a business of $10 billion of that and has not really done really up to now really very significant really commercialization really partnerships that have been really successful and really to a good really level. And you can see there are so many really errors as well in the diagnosis and the treatment really directions that are provided in a number of cases. So we cannot claim that actually that that it is a significant experience, and IBM has done really massive, really contribution really to the field. And as they say as well, that they are in the process of improving, and hopefully that IBM Watson will make the change. I would like to conclude I'm concluding now. Really, I think what we are now, we are in the infancy stage still, okay? And we need a mindset change, very importantly. And also that we need to have the informatics infrastructure for the full cancer patient journey. And we need as well to align with the laws and regulations. And also very importantly, to include lifelong learning really platform for the whole really people involved in the cancer care journey, including what we are really talking about in terms of the next generations of really ambassadors in cancer care informatics. Okay, I would like to thank you so much really for allowing me to talk and extending my talk, and this is really marvelous from you and very appreciated. Thank you so much.
Thank you, Dr. Oude. Thank you so much. Questions are coming in. Please keep bringing in the questions. The floor is yours, Dr. Omar Al-Nimri. I have introduced you. Everybody knows who you are. And please, the floor is yours.
Thank you very much. Can see the presentation?
Yes.
Okay, good afternoon. It's a pleasure to be with you again. I'll be talking about strategies and the cancer burden also, because in the morning I noted that not everybody know what is the burden of the cancer in the country, and little details. As we in Jordan, we are celebrating nowadays 100 years of our country as a state in this world. And it shows that our population is about 0.13% of the whole population of the inhabitants of this world. And also we have very good success and challenges during this 100 years. And cancer is one of these things. So with the 100 years, the journey is continuing. You asked me to talk about strategies, and in the morning we said there is no strategies for the cancer in the proper way as it is required or needed. But again, there is some guidelines and some booklets and instruction. The cancer doctors in Jordan, they are working according to it. It has been modified to our situation and to our patients here. But again, it is not our national guidelines or things to go through it. So we need our own, because as in the morning we said, there will be like the genetics of our population is different from the Western population, but still there is a need for the full and proper guidelines. So strategy is taken from the military rules or military sciences. It's a battle, and cancer is one battle we are facing, a very precious and very... Sorry, the sound is not there. So we are facing a battle with the cancer, and we should conquer this cancer and win our battle for the benefit of our patient in the country. So to prepare a strategy, there is some basic thing it should be there. The strategy is an outline steps, or it's a action plan should be going through it step by step to achieve something. And this here, it is the benefit of the cancer patient and the cancer continuum as a whole, starting from the prevention, screening, diagnosis, treatment, and the palliative care. All these challenges, all these action, all these objectives should be focused on a national cancer plan. If there is a proper national cancer plan, it will be serving all these aspects of the cancer issue in the country. Again, the strategy, it should be specific because we are dealing with specific disease, one of the NCD diseases, and it is more than 100 diseases in the cancer. So we need a specific guidelines or specific action plan to deal with these cancers. Again, it should be measurable because if you are doing something, need to know if it is succeeding or not. There will be like evaluation at some time or at some point, and according to the result of that evaluation, there will be like changing or modifying or introducing new thing, removing something, going to the ultimate goal, which is the goal you have set it from the beginning, which is the benefit or the control of the cancer patient in the country. In Jordan, cancer, as you said in the morning, my dear colleagues, and you were talking about the treatment. The treatment in Jordan, it is very good and very advanced even, comparing to the neighboring country, even in the world. So the aspect of treatment, it is there. But the problem in Jordan is the distribution of these services or the equity for everybody in the country. For the locals, even the non-Jordanian coming to the country, this services is not everywhere and it is not provided to everybody on equal basis, something like that. So we need to have some actions or some laws to get our services to everybody on a level accepted at least as a human being. They should be treated with dignity and have their own treatment in a very good condition, very good situation. And also the data or the numbers of these actions, it can be recorded usually according to the registries, what we're talking about in the morning, the hospital registry or the population registry. This will be keeping the numbers of the magnitude of the problem. And according to these numbers, you will be having the answer for your inquiries and questions. I am doing it right or I am doing it in an incorrect way. I need to modify here or there. And this sum of data, it should be used by the academia, by the researchers, by the government, stakeholder, policymakers to get benefit out of these figures and numbers which are collected. In our country, we are fortunate that the cancer patient, at least as a Jordanian with a national number, he will be treated on the expenses of the government. Mainly it is in the MOH hospital, Al-Bashir hospital. So this is again is a very good and a positive thing to have treatment as a very costly disease like cancer on the expenses of the government. Again, as we said in the morning, that is also there is like the Royal Medical Services, the teaching hospital, the King Abdullah, and the KHCC. Also, all of them, they are treating the patients. Even in the private sector, there is the treatment. It is costly, but there is some arrangement or some rules how it should be treated, each patient. Again, it is costly for the real patient or to a patient to give money out of his pocket. So always in a cancer cases, it is required that there should be the third party will be paying the bill for the cancer patient. One of the good things that King Hussein Center, they have insurance, I think it is called Afia or something like that. They have very small amount of money, annual payment. And if you get cancer, you can be treated immediately without waiting for transfer or to get exemptions or something like that. So this is again a positive thing for a cancer patient if he needs to be treated on speedy way, something. As we said, we don't have the National Cancer Control Plan yet, but the government is assigned as such policies to the High Health Council. The High Health Council is entity. It is directly with the Prime Minister, with 7 or 8 ministers as a member, and they are concerned with the making laws, health laws in the country. So the policy should be done or made through them. But unfortunately, till now, we didn't manage to develop this health policy for a cancer, at least. There is some policies as the government or as the Jordan health system. They had one, I think it was in 2012, and there was one 2016 till 2019, something like that. But again, it is not very well and solid plans for the cancer itself. This is what we see. As a Ministry of Health, through the higher council, these are the main things they should be doing, like maintaining the public health by offering preventive and curable control services, organizing and supervising the health services, also providing a health insurance, which we are trying for many years to have a universal health insurance coverage, but still, again, it is an obstacle and not done well. Also establishing and controlling management health education training. This is for the medical people or the medical staff and the human resources in these health facilities. Again, we said, despite many attempts, still we don't have the plan yet, but we are hoping we will be having it, because if it is there, it will be for all health sectors, not only for the Ministry of Health or the King Hussein Center or the universities. It will be all the health, different health stakeholders. They will be having collaborative actions, and they have ability to face the challenges and the consequences of the cancer as a whole, and they will be having a very good and powerful continuum for the cancer issue as a whole. Here I'll be giving you some numbers about the cancer burden or the cancer from the registries. The data is of 2016, which is the last one published. But also we should keep in mind, they say it is only about 5 to 10% of the cancer cases are due to genetics. Some defects on our system or on our bodies, it will lead to a cancer. And about 90 or 95 of the cancer cases due to environment or lifestyle. It means it is outside the body. Risk factor will be affecting the body, and ultimately there will be a change or a cancer. This means we can do something to prevent these 90 or 95 risk actions or risk factors, which will eventually lead to less number in the cancer cases. Here you can see in the last report, we registered about 8,150 cases. These are Jordanian and non-Jordanian. Out of these, there was about 6,000 Jordanian new cancer. This is incidence. We are recording only incidence, not the prevalence in the registry. Each year, we record the incidence for that specific year, and the figures show that there was about 3,800 males and 4,263 females, and the rest of the other numbers. Also, the pediatrics, usually we are classifying pediatrics in our registry 15 years and below. We had about 236 patients of children cancer, and the crude incidence rate for 100,000 population, it was around 80 for males and 92 for females. To do or compare our situation, always we should do the age standardization. So age standardization, the figures will be going up to 130 and 138 as age standardization rates. The age at diagnosis, it was for males 59 and for females 53. This also reflects it is a young age. You will be losing your productive years when you are diagnosed as a cancer patient. Sorry. And this is also important for the prevention or early screening program as a general. So you will be knowing at what age you should start your screening program. This here you can see the numbers from 2006 till 2016, a 10-year span. The upper one is for the Jordanian, and below it is for the non-Jordanian. And you can see around the 2013, 2014, the numbers were high because of the Syrian refugees at that period of time. We had a lot of non-Jordanian coming to the country, so we registered the cancer cases among them, and there was a big rise in that number, that period. These are the 10 most cancer among the Jordanian population in both genders. You can see it is breast, colorectal, and the rest of the cancers. And here it is in the males. You can see the lung is number one, colorectal, prostate. Sometimes the change for the first rank and the second rank, it is similar because the numbers are very close to each other. And if it is 130, 132, something like that. But if you take it as a cumulative, the colorectal cancer among males, it is number one now. And this is for the female. Breast is number one. You can see more than 1,200 cases per year. Colorectal also, and the thyroid, these are the top cancers among females. These are the cancers among the children. You can see leukemia, lymphoma, brain. These usually are the cancer for this such age group. Also, you can see here the distribution of the non-Jordanian registered in Jordan, Iraqis, Syrian, Yemenis, Palestinian, and the rest of the nations registered as the cases that year. Here you can see it is from 2010 to 2016 and 5 or 6 years. The increase of the cancer, it is about 20% from this period of time. But again, this can be due to the normal increase in the population. And you cannot take it, it is increasing in the cancer patient as a number because the rate is almost the same. It is as a rate, it is not in much increase. This is the mortality due to cancer. You can see the lung and the colorectal and the breast. They are the most causes for mortality in Jordan population as a cancer cause. Usually in Jordan, the government, they register around 19 to 25,000 more deaths per year. Out of these numbers, about 16 or something percent like that, due to neoplasm. So there is around 3,100 or 200 deaths due to a different cancers and also in different age groups also. This is more recent about mortality of the cancer. It is for males, it was 21 for the lung and colorectal 10, and females, it was the breast and the colorectal, as you can see the figures of the number. In the morning, we were talking about the screening program, and as I told you, we are having some talks or some actions to do or start a colorectal screening program. This quote from the 2012, I think, report about cancer incidence. At that time also, our minister was very enthusiastic and he said that there will be a program for colorectal cancer. And you can see now it has been 6 or 7 years and still nothing has been done. Even he said it is opportunity to start a screening for the colorectal, but again, it was not there. These are something which is positive if we want to start a national program for a cancer, because this is our added things to do the things in the correct way. We have national registration. Also, there is in the King Hussein Hospital registry also. We have the early detection program, and we are hoping to start the colorectal beside the breast cancer. Also for the treatment, it is available, as told you in the morning, but the distribution and the equity of these services is not there. Palliative care also, it is there in Jordan. It's a new aspect, but for the last 5 years or so, we have some action with the help of the WHO and the King Hussein. We published like a national guideline for the palliative care and the palliative care medicines. And there have been training for, I think, 200 physicians or nurses. But unfortunately, again, the palliative care in the Ministry of Health have stopped and there is no action yet. Also, of the positive things, we have a political commitment supporting the cancer issue. His Majesty and the Princess also, they have some positive actions or attitude against the cancer, and this should be used as a fortune. Also, in the future plan, there is the NGOs as a general. We have many, they are talking or they are ready to help in implementing a new aspect for the cancer control, prevention, and all these things. Also, there is international and local cooperation among many NGOs. Also, the wide coverage of the primary health care centers, it can be used to provide or educate the locals or provide some services, screening, these sort of things. Also, the human resources is there, new technologies and equipment, supportive program. Also, the multi-sectors as approach, because other ministries or other entities in the country or the government have interest in also providing help or assistance in this issue.
Dr. Omar, we should conclude now. I assume you're finalizing, right?
Okay, yes, 2 slides, I think. This is the, again, I think we have talked about it. This is the negative things. And what we are going, we have to be committed for such action which we are planning to do in the future. And this diagram, I think everybody can understand what's the meaning of that, equity and equality. And the best thing is to remove any obstacle, so everybody will be having the services directly without any obstacle in their hand. And again, we said if we are together, all together, hand in hand, we'll have new ideas and we will have new approaches. We can make changes. It will be worth it to have hand by hand actions. And this is, I think, a Chinese proverb I thought can help. Tell me I forget, show me I may not remember, but if I am involved with the thing, I will understand it and it will make me do things. So I will be having action. Also the action, it is not always one way. There is my way, your way, but the result is one. So we can help each other, and thank you.
Thank you, Dr. Omar, for such informative information about our strategies and giving us our latest published numbers, which are much needed. And it continues the presentation from the discussion in the morning. Thank you so much. Please keep your questions coming in the chat box. They're really interesting. I will move to our next speaker. We're a little bit behind time, but it was very interesting. I couldn't stop our speakers. Our next speaker is Dr. Laith Abu Hilal, He comes from a different discipline, but he would like to share with you the interaction between healthcare and engineering. He was the general manager of Safeway and Sameh Mall Group for over the past 12 years. He's an industrial professor at the German University, an industrial engineering lecturer for master programs at University of Jordan and Princess Sumaya University. And he's also the president of the Industrial Engineering Association. He's the vice president of Al Jazeera Sports Club, and he's a board member of investments at Tafila Technical University. And he's also a board member of research at the Middle East University. Dr. Laith, the floor is yours.
Thank you, Engineer Dano. Thank you so much for the kind invitation. I'm not sure if the screen is properly available. So can you see the presentation now? Okay, good. Good. Good evening. Thank you so much for the invite. As Engineer Dana said, I come from a totally different field, and hence I will speak from a different perspective. And of course, I'm not familiar at all with the jargons and terminologies of the medical field, as we said. So I'll talk today about simulation modeling and the possibility of utilizing it in the healthcare industry. The main agenda items will be simulation modeling background, then areas of simulation modeling in the healthcare industry, as far as the healthcare facilities and patients flow on one hand, and the stochastic modeling of patient statistical data on the other hand. What is simulation? Simulation modeling in general entails building a model that mimics the real life system. So we build the real life system into the computer, including its entities arrival and inter-arrivals into the system, the processes, the routes that it goes through, the resources that serve those entities. The entities in our case can be the patients, and the resources can be the doctors, your good selves, as well as the nurses. The interactions, the decisions, and the logic. So in any system, there are some decisions, there are some routes, some interactions, and some logic. The main steps of building any simulation model include conceptualization, whereby we build the objective, the problem statement, the objectives, the scope that we will capture and we will focus on. Then we start with input analysis. Based on the conceptualization and the objectives, we collect data. And data are paramount and extremely important in our analysis because, as they say, garbage in, garbage out. So we have to collect statistically significant data that represents the real system, and it has to be validated and verified. Then we start with the model building and construction. So as we said, we build those resources, be it the facilities, be it the emergency room, the beds in the emergency room, the reception and triage, be it the nurses as well as the doctors, be it the CT scan and whatnot. So those are, we build them into the system, and we build, as we said, the logic. Then we do the verification and validation, whereby verification, we verify that the model runs properly and per its requirements, and the validation that it is valid, that it matches real life. So for example, if we are to build the ER of, let's say, King Hussein Center, if they handle, let's say, 200 cases a day, then we should be able to handle 200 cases in the simulation model because it mimics real life. It should not have 5 cases or 10,000 cases. So it should be valid. Then we do the output analysis. Now that we verified that the input data is proper, that the model is constructed properly, it matches real life, that it is valid and validated, now we can do the output analysis as well as the what-if analysis. So we conduct what-if analysis to suggest some improvements on the as-is system. So there is an as-is system, and we do some adjustments to come up with a to-be system that's optimized and that is better, and of course the conclusions. The simulation model can run for a long enough period of time. The beauty of it is that, as you may imagine, we can fast forward life. So we build the model and we can fast forward it for a year or 2 years or any period of time. So we need to run it for long enough periods of time and sufficient number of replications in order to conduct what-if analysis instead of conducting them on the real-life system. So now that we built the emergency room, we can do what-ifs and we can do any changes, which is less risk, especially to the real entities and especially if it entails humans. So we can simulate what we would be doing without really touching any patients or any system or any doctors. So we can simulate that. It's less time consuming. As we said earlier, we can fast forward a year in a couple of minutes. It is less interruptions to the real system. For sure, nobody wants the emergency room that we start doing what if on the emergency room and start moving the triage and start moving the equipment and the tools. It's less incurred costs because we can do all of the what ifs and all of the analysis on the system without incurring basically any cost at all. Some of the areas include manufacturing systems, airport operations, supply chains, call centers, services such as supermarkets, banks, restaurants. So as we said, we can build a model basically of any kind of system that exists in real life, telecommunications, any kind of systems. In the healthcare, for sure, we can build healthcare facilities, emergency rooms. We can work on the scheduling of patients because we can simulate that and we can see and predict the inter-arrival rate of the patients. And we can do what if on the scheduling of patients. And we can take some of the complexities into account, including the number of available resources such as beds. We can include the number of doctors and nurses, and we can include a whole lot of constraints and matters into consideration. As we said, scheduling of staff. We can also do simulating recovery patterns. So all of the data, as Dr. Oude mentioned, and I was extremely happy that he mentioned a lot of things that I can relate to about artificial intelligence and about machine learning, because this is the fields that we work on, and demand sensing and different kind of tools in order to conduct and create predictive models. Simulation is a pretty powerful, and I can say that it is extremely simple if I compare it to artificial intelligence and whatnot, algorithms, and we can build artificial intelligence and algorithms into simulation. But in general, and I will show you in a minute, we can generate and create extremely simplified models that mimics real life. And we can generate extremely simplified patterns, be it statistical distributions and stochastic modeling in a very simple way. So this is very useful and handy in that aspect. Simulating medication effectiveness. So again, we can also simulate the effectiveness of medications. Some of the sample projects that I have worked on include emergency room at one of the hospitals here in Jordan. So the objective was to maximize the ER capacity, minimize the time, minimize the time wasted due to improper design and layout, increase patient satisfaction, and determine the optimum staffing levels. So this is simplified patient arrival, triage, critical. If it's critical, we classified into green, red, yellow, red, and black. So if they are in a extremely urgent situation, emergency, they go immediately to treatment, they are rushed into the surgery or operations. Whereas if it's not critical, they go through the registration and the second triage. Then if it's critical or not critical, whether we do examination or not. The main components in the model included the ER with its reception and triage, the cardiac in case of black customer situation, 6 beds in this case, and waiting area. It included also the X-ray area with its reception and other scanning X-ray machine, the pharmacy itself, and the testing labs with some of the lab work. So it was a very simplified model. And in order to simulate that, we collected types of patients and the percentages of those patients arriving into the system. Of course, the inter-arrival of patients, so how frequently they come. And of course, as you can imagine, there is a trend. For example, in the morning, more cases come, then it relaxes a little bit, then it increases for many people going back from work and so on and so forth. So we found out those trends. Of course, the annual seasonality as well, with, let's say, the flu season in the winter and whatnot. So there is seasonality in the arrivals, and there is also stochastic nature of the percentage types of patients, the sequence flow, the process times, the number of employees, the working hours. So all of those are parts and components of the system. And this is a very simplified model. These are the logic of the system on top. And relatively speaking, such a model, probably maybe it shows that it's a little bit complex. It has some complexity, of course, because we are matching real life. But in reality, it can be built by someone trained and experienced in quite a fast and it's not extremely complex. So for example, if I am to build it out of data collection, I can build it maybe in a couple of days. So it's not a very complex situation. And the animation of the logic. So this is some of the logic. So there is triage and there are decisions. Of course, the decisions entail percentages of the emergency classification. Green patients, let's say maybe 30%, then yellow 20%, then red, let's say 10%, and black 5%. The black, of course, top priority, and they go immediately, as you can see, into, they seize the medical attention immediately, whereas, for example, the green patients, they go into a hold, and there is a yellow hold and a red hold. So as far as the logic, the priority is by far is the black, then they all go into a hold. We start with prioritizing the red, given that the black is okay and served, so we serve the red, then we serve the yellow, then we serve the green. So the logic of the treatment and the logic is taken into consideration and conducted. Again, the logic of whether they need X-ray, there are decisions, for example, if there is lab test, is it needed or not? So if it's needed, for sure, it will go to the lab work, and there is a flow here, sub-model for the lab test and what will happen in the lab. If they need X-ray, then for sure there is a flow. And here, if I click on this, there will be a sub-model for the X-ray and what happens in the X-ray. Then after all of those operations are conducted and done, pharmacy as well, same thing, if they need to do medication. Now, the difference is that typically for the vast majority, based on our calculations, is that especially in Jordan, the patients, they have companions. So the companions will go to the pharmacy and do some of the registrations. Then we match them together and they go through the checkout after we match the patient with his companion. And we match him, of course, with his lab work test, X-ray test, examination, and whatnot, and then they go out of the system. And of course, we can take all kinds of statistics here. Patient total time in the system, the total time he spent in the system or she spent, the patients leaving the system, the counter, how many. We can take all kinds of statistics, how much they waited in the queues, how much they waited, waiting for the medical attention, and so on and so forth. So all of those are stochastic based on the input analysis, based on the modeling, and we conduct the analysis. So this is a very simplified model. And here, as you can see, this is the overall model of the emergency, and the people are moving and cars are coming and patients are going, doctors and nurses are paying attention. And this is the output analysis. So we get the output analysis from the system. So in essence, we simulate real life. And as we can see incoming cars, we can see ambulances as well, and we can see people moving around as per real life. On the right, we can see some of the statistics. We can see the utilization. We can see the waiting times and all kinds of statistics that are needed to measure the capability of the system and its effectiveness. Those are some of the output analysis. As we said, we can see the value add time, the non-value add time, and waiting time, queuing time, transfer time, all kinds of statistics. We can also build all kinds of statistics. So let's assume that some of the management, they are interested in specific, let's say, statistics and KPIs, key performance indicators, for sure we can design any kinds of reports that can measure those. And we can also measure, for example, the radiologist, he's 95% utilized. So this is somewhat high. So we can look at some of the results, the red tech, and so on and so forth. So from this model, some of the suggestions to change the layout, also to bring the pharmacy, it was extremely far away, but these are just simplified. We can do way more complex. Adjust the beds and staffing. The staffing was totally improper. We had overstaffed during the non-peak hours and lack of staff during peak hours. So we readjusted that, relieve the bottlenecks through adding more resources to the bottlenecks, introduce scheduling, proper scheduling. These are just some of the profitability, the total profit from 359,000 to 381,000 and so on and so forth, just some quantification. Another sample project was the picture archiving and communication system packs at King Hussein Cancer Center. So previously and before the packs, as the ER requests, they would write the request, and the porter takes the request to radiology. RedTech informs the radiologist, triage, patients pays, etc. A nurse takes the patient to the first floor, CT or MRI, radiologist urgent calls yes or no, print the film, put the patient in patient jacket, radiologist write the report. So as you can see, this process is somewhat complicated. It takes somewhat a long period of time. The matching, it entails some of the non-value-add activities, as well as printing and waiting for printing and moving the reports and putting it in jackets and matching the jackets and all of that. So for sure, the pack system was much better. As we can see here, 38% no contrast, 62% contrast, etc. Yani we can see a lot of statistics that we can calculate, and this is sample data of different kinds of triage cases and so on and so forth. The more data in our field, the merrier. So it becomes more statistically significant and more representative of real life, and becomes much more valid. Those are the distributions. So in this case, it was beta of 0.38 plus 1.86, etc. And this is how it looked, the statistical data. This is the waiting time. Again, it was, I think, uniform distribution in this case. Yes. So in general, 38% of requests needed triage, 18% of patient needed MRI, the remaining are CT scan, 60% of the scans are urgent, etc., etc. So those are input analysis and output analysis. This is the model, very simplistic in this case. Triage and CT or MRI, those are percentages, CT and MRI. It goes to packs. So this is the to-be system.
Dr. Laith, you have 1 minute.
Okay, so this is the packs and this is the outputs, and these are some of the outputs and some of the output analysis. So as you can see, the average time was reduced from 27 minutes to 3.9 minutes, and the WIP, number of people in the system, was reduced from 50 to 8. So as you can see, there is dramatic improvement. So to summarize all of the above, and to come with the next field. All of the above, to summarize it, we can simulate the real life system, and we can do what-if analysis and come up with very good improvement suggestions that can add value, that can optimize, that can minimize the total time of the system, can minimize the waiting time, can minimize the number of people waiting in the waiting areas, and so on and so forth, based on what-if analysis and improvement suggestions. The next field, I'm out of time, so I'll just touch upon it very, very quickly. So we can look at historical data, and we can fit those historical data into distributions. And as Dr. Audi said, we can do machine learning, and we can do all kinds of statistical and stochastic modeling, statistical analysis for the specific patient to simulate and forecast future and for new medication and or procedures to simulate anticipated results. So let's say that 27% had lung patients, 22 are colon patients, and 17% leukemia, 12% prostate, and the remaining, which is let's say 22%, are benign. They are not cancer patients. So we can simulate that, and we can generate all kinds of systems, and we can generate all kinds of distributions, Erlang plus gamma of 2.5, etc. And we can come up with the trends. We can study the trends and the results over time, and comparative analysis of variance, statistical distributions. So I will stop here, but just to conclude is that simulation modeling can be utilized effectively even in the pandemic. Let's say the COVID-19, we can simulate the rates, and we can simulate even the seasonality and the waves. Same applies to the stochastic and statistical and variable, it's extremely variable nature, and come up with simulated predictive models to predict the percentage survival. Thank you so much for your attention.
Thank you, Dr. Laith. That was a nice graphical presentation of what simulation modeling can do. Unfortunately, we have gone over time into the next session. So what I advise the speakers, please, if you put in, just like Dr. Oda put in his email address, if you have any questions for Professor Oda, Dr. Umar, or Dr. Laith, and they can answer your questions. Dr. Suha, are you ready for the next session?
Dr. Mohandas Dana, can I just...
Or until Dr. Suha is ready, I can take a question. Let me see. A quick question.
Dr. Sarhan has a...
This is a question for Dr. Umar. What exactly, in your opinion, is preventing us from having an NCC? This question is for Dr. Umar al-Nimri.
Great question.
Any other questions?
Yes, there is a question from Dr. Sarhan.
Dr. Suha, I think you can start your session. We've taken enough time from your session.
That's okay. I just checking. Dr. Laith, can you stop sharing? I can't. Would you mind just to stop sharing?
Mohandas Dana, I don't know, can you hear me? There are some really good questions. I think they will be good to really reflect on.
Unfortunately, Dr. Muhammad, we had to just give time to the speakers on the count of discussion. And in the morning, actually, we had like a busy session with, we had a busy session with discussion. Actually, we went over like an hour and a half discussing most of the issues that we talked about. And I'm not sure, like apparently Dr. Umar al-Nimri is not with us now. So I think we will conclude the session and we have to go to the next session. So I was checking if Dr. Sana is with us.
Yes, يسعد مساكم.
أهلا. So before, okay, thank you, Dr. Sana. So I just wanted to start the next session, which is going to be focused on breast cancer. We talked in the morning about breast cancer, and I think the discussion was really fruitful. So we'll give the time to the speakers. I was supposed to present first, but I will give the time. زي ما بقول أنا ضحيت بوقتي عشان السيشن اللي قبل because I believe إنها كتير مهمة وشكرا كتير. فهلا بمناسبة اليوم العالمي من السرطان, it's good إنه نبدأ البريست سيشن مع دكتورة سناء. And because I genuinely believe that it's part of networking what we do here. So I will briefly present Dr. Sana and her CV. So Dr. Sana is a consultant in medical oncology hematology, currently president of the Jordanian Society of American Medical Graduate and immediate past president of the Jordanian Oncology Society. She is the co-chair of Resource Stratified Guideline Advisory Group of the ASCO, chair-elect of the International Affairs Committee of ASCO, and she had earned her medical degree from the University of Jordan with honors and pursued a Master of Science majoring in cancer biology from Wayne State University in Michigan. She completed her internal medicine residency at Detroit Medical Center, followed by postdoctoral research at Wayne State University, while pursuing her fellowship in medical oncology and hematology at Wayne State University. So she's an American board certified in internal medicine, medical oncology, and hematology. She is the recipient of multiple national and regional awards, including the Distinguished Women Physician Leader Award from the SIGI under patronage of Hivos and Ministry Affairs in the Netherlands in 2017, and the MAASC Recognition Award for supporting oncology education and cancer awareness in the Arab region, Beirut, in 2014. She is interested in translational research, and I think this is really important, and it's one of the things that we hope that you know, the audience in these 2 days will be inspired to do, particularly development of biologic and immune-based therapies with predictors of response to systemic therapy targeting breast, ovarian, pancreatic, and other solid tumors. Also because she led the perennial campaign on the World Cancer Day in 2015, and that started in Amman and went through the kingdom to spread awareness how to prevent cancer through healthy lifestyle over 3 years, 2015 and 2018, while she was the president of the Jordanian Oncologic Society. So I think we're really honored that she's with us here on World Cancer Day 2021. I don't want to take much of her time, so Dr. Sana, you can start.
Thank you, Dr. Sehat, for this kind introduction. Congratulations for this actually impressive effort during these challenging times. It's very hard to keep the enthusiasm with Corona around us. So يعطيكم العافية, impressive effort. Again, we are in the era of precision medicine, and I thought let's talk about something practical like what we talked about in the morning. I always talk about neoadjuvant treatment in cancer. Here, I'm trying to hopefully convince you that neoadjuvant therapy right now is not a preferred method, it's mandatory. Indeed, at least in breast cancer so far. So I will be discussing residual disease. What is residual disease in terms of definition and significance? What have we learned so far? What do we need to learn, and my future perspective on what we have learned so far? So quickly to remind you, the established benefit of success of complete path response and once achieved in neoadjuvant therapy in the case of breast cancer has been established over the past 5 years. First, this FDA-led meta-analysis of more than 12,000 patients enrolled in neoadjuvant randomized trials, 12 neoadjuvant randomized trials, did clearly demonstrate a positive impact on event-free survival and overall survival. Look at the difference. 20% improvement in event-free survival for the patients whose tumors achieve a complete path response in response to therapy, independent of the therapy, be it chemo, targeted, whatever you use. Hormonal, if the patient tumor achieves complete path response, there is a 20% improvement in event-free survival, and even more remarkable separation goes up to 30% improvement in overall survival. So I think these graphs speak for themselves. Complete path response in the tumor, if you tell your patient, it's very good news. How about less than complete path response? Complete path response is no residual invasive tumor, whether in the breast or in the axilla. That's the complete path response. DCIS, by the way, is considered complete path response. However, the residual disease that is left beyond complete path response varies. And in oncology, we have developed something called residual cancer burden, at least for breast cancer that indeed correlates with outcome. It takes into account, the calculation for this is available online. It takes into account the tumor size, initial tumor size, cellularity, size and number of involved lymph nodes. And depending on the residual cancer burden, which is classified into 1, 2, 3, the outcome is determined. As you can see here, when it comes to hormone receptor positive tumors, HER2 negative tumors, contrary to the widely spread belief that you do not need complete path response. Yes, you do not need complete path response because less than complete path response, as you can see here in residual cancer burden 1 and 2, they still do as well, but residual cancer burden 3 do not do as well. And indeed, complete path response when you have a hormone receptor positive tumor is wonderful news. Look at the curve, it's almost flat. And those are patients who have been followed for more than 15 years. Unfortunately, our success to achieve complete path response depends on the grade, goes up to 15% if the patient has a tumor grade 3. So keep this in mind. Even if the patient has hormone receptor positive disease, grade 3 tumor can achieve a complete path response. And we need to use chemotherapy when indicated. When it comes to the other extreme, triple negative tumors, very interesting. Complete path response and residual cancer burden 1, which actually corresponds to isolated tumor cells. Look at them, they do quite remarkably well as compared to RCB 2 or 3. So RCB 0, which is a complete path response, or RCB 1 for triple negative breast cancer patients is wonderful news. And those who achieve less than that, whose tumors achieve less than that, they need help. And we'll talk about that. Now we are learning what to do to help those. Finally, HER2 positive tumors. And please note, triple negative tumors, 1 in 3 will achieve a complete path response of those tumors. Contrary again to the widely spread belief that they do not do well, actually 1 in 3 will have a complete path response. And 1 in 2 will have an RCB01. So that's quite remarkable. When it comes to HER2 positive tumors, similar to triple negative tumors, quite responsive to chemotherapy, and the proportion goes up to 50% when using trastuzumab. And it's even higher when adding dual tumor blockade. Quite interesting, please notice, when it comes to HER2 positive tumors, anything less than complete path response is bad news. So you really need to achieve a complete path response. And if you don't, we need to help those patients, and we will talk about it. Those patients with RCB 1, 2, 3 definitely need help. Whenever you talk about a patient with minimal response, be it HER2, hormone receptor positive, HER2 positive, or triple negative, it is very bad news. And something needs to be done about it. That's why neoadjuvant treatment indeed can easily identify which patients need further intervention, which patients need close surveillance, because you're expecting a worse outcome. So we need to keep in mind, after neoadjuvant therapy, what is the residual cancer burden? Take into consideration the subtype. Another recent study just published late last year confirmed what we saw in the meta-analysis, and this is a individual patient meta-analysis of close to 28,000 patients from 52 trials. Look at the separation for the patients who can achieve a complete path response. Again, 20% in favor of event-free survival and a 20% separation when it comes to overall survival. Quite remarkable. I mean, you cannot have a better, easier indicator to get to tell your patients about the outcome. Each patient asks you, what is the prognosis? And usually we refer to studies, and studies talk about an average attributed to patients, included to thousands of patients enrolled in those trials. But here you can tell your patient the exact expected predicted outcome based on the pathologic response. Interestingly enough, the separation is remarkable for triple negative breast cancer, HER2 positive tumors, even seen for hormone receptor positive tumors. Look at the remarkable improvement in event-free survival, 20% point, 30% absolute points for triple negative, 20% for HER2 positive, and 10% for hormone receptor positive. Even more remarkable from that meta-analysis, which I believe the future will be telling us, among patients who achieve a complete path response, actually without completing adjuvant therapy, the outcome was independent of further treatment. So achieving a complete path response with a tumor really portends an excellent prognosis independent of whatever therapy you give the patient afterwards. This is a hypothesis generating, but probably is the case, as illustrated in this meta-analysis. And it is the future, actually, it is the subject of many ongoing trials as we speak right now. So how can we improve the outcome of patients with residual cancer burden? Let's start by patients with HER2-positive disease because the data emerged initially for those patients. In the Catherine study, patients with residual disease after treatment with HER2-targeted therapy on neoadjuvant basis were randomized to the classical adjuvant therapy of trastuzumab to complete 1 year with radiation and endocrine therapy if indicated, versus T-DM1, which is a trastuzumab conjugated to a chemotherapeutic agent that is delivered inside the cell. Exactly the same number of cycles on adjuvant basis. And guess what? Disease-free survival was improved by an absolute 11.5% difference. So improvement in event-free survival of more than 10%, 11.5%. 50% reduction in the risk of recurrence if those patients were maintained on T-DM1 as opposed to trastuzumab independent of their hormone receptor status. With the initial median follow-up of 2 years, there was no impact on overall survival as published in New England Journal of Medicine yet. What's really remarkable, the difference, the improvement in overall survival and event-free survival was exactly a mirror image of the absolute improvement in disease-free survival that actually resulted in the adoption of 1 year of trastuzumab adjuvant therapy. Can you imagine switching to another HER2-targeted therapy, T-DM1, for patients with residual disease improves the outcome further 10%. So from 62% to 73% to 83% just by switching to another targeted therapy for those with the residual disease. And if you look at the forest plot analysis for the subgroups, all subgroups benefited, independent of the stratification factor, particularly those who had received even dual blockade in the neoadjuvant setting still benefited from switching to T-DM1 in the adjuvant setting, though the numbers were small. Also independent of age, even those who were aged above 60 did benefit from the switch if there is residual cancer disease. Even those with no negative disease, they have residual cancer. And of course, not all HER2-positive breast cancers are created alike. On a molecular level, we know that HER2-positive tumors, the majority are HER2-enriched, but still we have basal-like, we have luminal B and luminal A subtypes. And the response to trastuzumab-based chemotherapy is actually dependent on the molecular subtype. It actually goes up to 80% if you are treating a HER2-enriched molecular subtype examined not by immunohistochemistry but by molecular profiling. And the outcome for those patients is also different. As you can see here, it is worse for the basal subtype of HER2-positive tumors. So molecular profiling is not 100% concordant with immunohistochemistry, unfortunately, so far. And keep this in mind when thinking about response, complete path response in HER2-positive tumors, as illustrated here, goes up to 1 in 4 for luminal B HER2-positive tumors, 1 in 3 for basal-like tumors, and 2 in 3 for HER2-enriched tumors. Of course, no pain, no gain. T-DM1 is not like trastuzumab. It carries a risk of peripheral neuropathy that can actually be persistent for up to a year. However, mostly it is reversible. Please note, reversibility goes up to 80% if there is no baseline neuropathy, but can be only seen in 2/3 of the patients if there is baseline neuropathy attributed to chemotherapy. So keep this in mind and follow the patient. It's not like trastuzumab. And also thrombocytopenia is another risk, especially among patients who have been exposed to platinums in the neoadjuvant setting using the Slayman protocol TCH. It can be seen in 1 in 4 up to 1 in 3 patients. The good news, it's completely reversible. The good news also, it is quite tolerable with most patients. You can see here 70%, only 10% respond to trastuzumab on completing all scheduled cycles. However, 15% will require dose reduction. Moving on to the triple-negative breast cancer population, we know that 1 in 3 will achieve a complete path response, 1 in 2 will achieve an RCB0, RCB1, meaning isolated tumor cells, and they do well. But what about the other 50%? Similar to HER2 positive tumors, triple-negative breast cancers are indeed at least 4 subtypes, and these subtypes have different sensitivity to DNA damaging agents, meaning anthracyclines, alkylating agents, to targeted therapy. And lately, just last month in the States, a new targeted therapy has been approved. It's called sacituzumab for triple-negative breast cancers, targets topo2 isomerase, and quite effective in these tumors. And finally, to immune modulating agents. Depending on the subtype, some of them respond really nicely to bevacizumab. One thing we have learned from the neoadjuvant setting, chemotherapy can achieve a complete path response in up to 40% of the patients, and this is across 3 major prospective randomized trials examining the efficacy of different regimens in triple-negative breast cancer across the continents. This is the German trial, and this is a European trial, and this is a North American trial. Consistent benefit for neoadjuvant anthracycline taxane therapy. When you add platinum, whether you are in Europe or in the States, you are adding another 15 to 20% absolute improvement in complete path response. A lot of argument goes about that, which subset of triple-negative breast cancer patients, but indeed, when it comes to the neoadjuvant setting, it is worthwhile considering adding platinum. And right now, it's included in the guidelines, though some experts still caution about selecting patients. So, we achieved a complete path response in 50 to 60% of the patients using neoadjuvant chemotherapy. What about the rest? Indeed, the Japanese were among the earliest to address residual disease among patients with breast cancer after neoadjuvant therapy, randomizing patients to either hormonal therapy if indicated or just observation versus giving them capecitabine for 6 cycles. And as you can see, there was a trend for improvement in disease-free survival and overall survival. What's really interesting is that most of that benefit was driven by the subset of patients with triple-negative breast cancer. Those that had hormone receptor positive tumors, as you can see here, did not benefit as much as the triple-negative breast cancer population. And that was independent of the use of previous chemotherapy, and particularly so if resistant to taxanes as well. That is a subset of patients that really need help. So it became the new standard since 2017, based on one study denoting the fact that we do not have many options. And you can see here, we are achieving 20% point separation in favor of reducing the risk of recurrence and improving overall survival. 8% improvement in overall survival for the subset of patients with triple-negative breast cancer. The Spanish trial decided to replicate the Japanese experience, and they did carry the same concept, randomizing patients with residual disease, triple-negative breast cancer patients with residual cancer after neoadjuvant anthracycline and taxane to either 8 cycles of capecitabine versus observation. And what they found, unfortunately, no impact whatsoever on disease-free survival or overall survival for the triple-negative breast cancer population. So how can we look at both trials and come up with conclusions? Look at the separation, look at the improvement with the Japanese trial versus minimal, if any, with the Spanish trial. We mentioned earlier that triple-negative breast cancers are not created alike, and probably the distribution of the subtypes in the Spanish population for triple-negative breast cancer was different. What they did in the Spanish trial, they defined an immunohistochemical definition for the non-basal subtype as EGFR positive or cytokeratin 5 and 6 positive, and demonstrated a positive impact for adjuvant capecitabine on event-free survival and overall survival along the same value that has been demonstrated for the Japanese trial. So, coming up with a conclusion for the non-basal immunohistochemical subtype of triple-negative breast cancer, worthwhile to give capecitabine. However, the oncology community have adopted capecitabine in general for patients with triple-negative breast cancer with residual disease. And if you look at the forest plot analysis, the benefit was driven mainly by the non-basal population defined by immunohistochemistry in the Spanish population. So that was the conclusion for the Spanish trial. The problem is immunohistochemical definition of basal subtype as opposed to the molecular definition. As you can see here, the overlap is only seen by 13%, 13 of 142, less than 10%. So your definition of basal subtype really is not that accurate, and in that particular trial depends on what they have used, cannot be mirrored using molecular subtyping, which makes things more difficult, because if you consider immunohistochemical definition, there is really no impact on breast cancer specific survival based on definition by immunohistochemistry. But the separation is quite remarkable if you take molecular subtyping, with basal subtype having inferior outcome compared to other subtypes in this prospective retrospective trial. They applied the definition retrospectively to the prospectively collected data. So I'm not sure what to make of the Spanish one, except that, again, similar to the oncology community worldwide, most have adopted capecitabine on adjuvant basis for patients with residual cancer disease after neoadjuvant therapy. And as I mentioned earlier, definitely the distribution of the molecular subtypes of triple-negative breast cancer in the Japanese population was different from the Spanish population, accounting for these differences in outcome. And if you are using a targeted therapy, maybe capecitabine is indeed a targeted therapy for a subset of triple-negative breast cancer. If they are not there, you will not see the difference. So what about those given platinum in the neoadjuvant setting? There is an ongoing trial right now looking at adjuvant platinum versus capecitabine for those who received neoadjuvant therapy without platinum. Another trial is looking at adjuvant olaparib for 1 year versus placebo for patients with BRCA-mutated tumors. And finally, for patients with PD-L1 positive tumors with residual cancer disease, they were randomized to either observation versus immunotherapy for 1 year. How about hormone receptor positive disease? And please notice, in response to chemotherapy, 15%, 16% are achieving a complete path response, contrary to the widely spread belief of no complete path response to chemotherapy in hormone receptor positive disease. You need to treat it when it's indicated. Any biomarker to guide further therapy? Before I go further, actually the biomarker that guides further therapy is Oncotype DX. It can predict response to chemotherapy very nicely, but at the cost of $3,000. Can we do it at a much cheaper cost? Probably yes, for the cost of 30 JDs, if we could have at least a national standard for the definition of what's called Ki-67. The POETIC trial, very nice name, the POETIC trial, indeed randomized patients to preoperative endocrine therapy for 2 weeks and followed by surgery and continuing endocrine therapy for 2 weeks post-operatively versus surgery, and looking at the surgical biopsy pre and post surgery. What it demonstrated that if patients start with low Ki67, they are likely to have an excellent outcome. If they start with a high Ki67, more than 10%, that was their definition, they have twice the risk to have a recurrence during follow-up. So baseline Ki67 correlates with outcome. Can we change that outcome? Indeed, we can. If the Ki67 starts low and continues low, the outcome is quite remarkable with 5-year risk of 5% recurrence. If it starts high and after 2 weeks of treatment with endocrine therapy, it drops, the chance of recurrence goes up to 9%. It doubles, but it's still low. If it starts high and continues to be high after neoadjuvant therapy, the chance of recurrence with hormonal therapy goes up to 20%. 1 in 5 will have a recurrence. And here probably that can guide our selection for treatment. Unfortunately, in this trial, they didn't continue to tell us if using chemotherapy will reduce that risk. But that would be a subject for selecting patients to guide them to be enrolled in clinical trials if they were available or for close surveillance. So, what to do to overcome endocrine therapy? Should we use targeted therapy? Now we have CDK4/6 inhibitors, mTOR inhibitors, or should we use chemotherapy? The temptation is to use targeted therapy, but guess what? They tried everything to look at the endpoint of complete path CR, combining with a PIK3CA inhibitor, or mTOR inhibitor, or CDK4/6 inhibitor, did not increase the complete path response. They looked at the intermediate point of Ki67, and indeed, no impact for PIK3CA inhibitors, improved actually Ki67 suppression with mTOR inhibitors and also with CDK4/6 inhibitors. However, I'm sorry to share with you that despite the fact that abemaciclib and palbociclib dropped Ki67, the adjuvant trial of palbociclib did not increase disease-free survival, while the early results from the abemaciclib combination adjuvant trial was positive, still with huge skepticism because the median follow-up is quite short. So most likely, the addition of targeted therapy will only temporarily delay recurrence rather than abolish the risk of recurrence. At least this is what we have learned so far. And indeed, from the neoadjuvant setting, we have seen in the NeoPAL-ANA study, where anastrozole was given for 4 weeks, followed by a combination and the surgical biopsy specimen taken pre-hormonal therapy, after hormonal therapy, and after combination, demonstrating that only 1 in 4 tumors were completely sensitive to anastrozole as defined by suppression of the Ki67 to less than 2.7%. Another 60% were sensitive to the combination inhibition, but that has to continue. So it looks like it's a temporizing measure to to delay recurrence rather than prevent it, while still we have 15% of tumors recur despite or do not get suppressed despite the use of this combination. So Ki67 should be one of the biomarkers to guide hormonal therapy in ER-positive breast cancer. To conclude, one size does not fit all. It has to be subtype specific approach. What's new for triple-negative breast cancer is the era of more refined approach, limited data with capecitabine, at least non-basal RCD defined by positive cytokeratin 5 and 6 plus minus positive for EGFR by immunohistochemistry. We need larger trials, assess immune approaches, other possibilities, but for now, adjuvant capecitabine is a reasonable choice. HER2 negative hormone receptor positive breast cancer. Again, this is the era of exploiting the concept of overcoming endocrine resistance. CDK4/6 inhibitors suppress Ki67 without improvement in overall response, increasing past CR. There is no established role for PCR, but for Ki67, possibly a surrogate endpoint for adjuvant decision, and that needs an international consensus. For HER2 negative hormone receptor positive breast cancer, this has to be the HER2 positive hormone receptor negative breast cancer. This is the era of exploiting the concept of overcoming HER2 resistance by using T-DM1 and probably the newer targeted agents that are coming, like deruxtecan and margetuximab, are going, and tucatinib will be other options. But for now, T-DM1 for HER2 positive residual cancer is like capecitabine for triple negative breast cancer. For all patients, we need to have other biomarkers examined, and this is what's going on right now: circulating tumor DNA, circulating tumor cells, molecular subtyping, and Ki67. With this, I conclude, and thank you for listening.
Thank you, Dr. Sana. This is really, really excellent presentation. And actually, it was really great that you did this presentation ahead of Dr. Mahmoud's presentation, because I think they're complementary. And I think there are a few questions, but we'll leave them to the Q&A. Now we're just gonna move with Dr. Mahmoud. Dr. Sana, would you mind just to stop sharing the screen, please? So,
yeah.
Thank you. So now we're gonna go with Dr. Mahmoud Abu Daqqa, who is a consultant oncoplastic and reconstructive breast surgeon. Dr. Mahmoud has earned his undergraduate degree from Cairo University, and he completed his surgical residency in the United Kingdom. He has completed the prestigious International Traveling Fellowship in Oncoplastic and Reconstructive Breast Surgery at the University Hospital of Cambridge in UK. And before moving to Jordan, Dr. Mahmoud has worked in the United Kingdom as a consultant oncoplastic and reconstructive breast surgeon, where he was also the breast cancer and clinical governance lead at Sherwood Forest NHS Hospitals, UK. He has also over 30 publications and presentations in the field of breast and general surgery. Dr. Mahmoud has worked in King Hussein Cancer Center, then he moved to Qatar Hamad Hospital, and now he moved back to Jordan, and he's currently in Farah Hospital. His talk, as I said, complements Dr. Sana's talk, and I think this is really a great session. He's going to talk about an issue that is pertinent to the neoadjuvant chemotherapy, because we're hoping with more neoadjuvant chemotherapy that will be doing less of mastectomies. And this is something that Dr. Mahmoud is going to talk about with his presentation titled "Mastectomy, Should It Be the Patient's Choice?" So Dr. Mahmoud, you can proceed. Dr. Mahmoud, we cannot hear you.
Hi, can you hear me now?
Yes, but you have to go back because we didn't hear anything.
Okay. Right. Good evening, and thank you, Dr. Suha, for the kind introduction. And it is indeed actually a continuation of the precision medicine and a tailored therapy to each and every patient. And this is why I'm going to talk today about mastectomy. Should it be a patient choice? So to start with, I'm just going to talk about focus on the T1, T2 tumors. So these tumors that actually can have BCS, which is breast conserving surgery. I have no disclosures. So it all started with this man. And in the 1970s, I read about it. I wasn't there, but I read about it when he was very strongly opposed, when he suggested conservation surgery at a time where the gold standard surgery was the radical mastectomy, which is the Holstedian mastectomy. And this Mr. Veronese, has came up with this comparative study where it showed similar overall survival between the hosted mastectomy and quadratectomy. And slowly but steadily, he certainly changed the dogma that existed in that time. And we managed to remove the hostidian lying in every surgeon of us. So what I have noticed from the practice when I moved to the Middle East, that there is rather a strong belief that amongst our patients, that mastectomy is often the ideal solution for any type of breast cancer or sometimes even breast problems. I've seen patients coming from Egypt who had mastectomy for granulomatous mastitis. And they feel that it is a bigger operation, it's a better operation. And I thought that we as doctors need to raise the awareness of patients. However, my biggest surprise was when I've noticed that even some doctors share the same belief. And this where I really thought that we need to take this, talk about this subject and take it more seriously. So, first of all, I need to emphasize that I'm talking about patients who have early breast cancer, suitable for conservation, but the patient wishes to have a mastectomy or have been told that mastectomy would be better for them. And they want to have to worry about things after they have the mastectomy. So there are three main things that I need to discuss today. And the first one is about consent and the first rule of medicine, which is do no harm. And I'm going to compare the oncological safety, the quality of life, and the functionality of BCS and mastectomy in both groups, in mastectomy and BCS. So if you go to any textbook, which most of the medical students are reading now, you'll find that mastectomy, the indication for mastectomy, patient wish is one of them. And I think it's not fair just to teach them this without elaborating on this subject. So talking about the consent form, I'm going to talk about the UK rules, and it may not all apply to our local rules in consenting patients. So I'm going to talk about the Montgomery case in 2015. This was a landmark in the UK for informed consent, and there has been a major review after this case. So Nadine Montgomery is a woman with diabetes of a small stature. She's diabetic and have a small stature, so as one would expect, she has a large size fetus. And she delivered her son vaginally, so the born experienced some complications owing to shoulder dystocia, resulting in hypoxia and eventually cerebral palsy. And the obstetrician did not disclose the increased risk of complication in vaginal delivery. So Ms. Montgomery sued for negligence. And this created a national review of consenting process. And few rules come out of that review. So one of the main rules or issues that were discussed in the review was autonomy versus medical paternalism. And while this is a controversial area and lots of different options and opinions come into play, they decided that always patient autonomy obviously comes over medical paternalism. When discussing mastectomy with patient, they need to know about BCS. They need to know the benefits of BCS when it's a viable option. However, if you look at things from a different perspective, you'll find that one of the other things that came out from this review that if the options are not equal, giving the choice is actually not denying the patient informed choice. And I'll give you an example of that. I've worked as a general surgeon for a very long time. And if you have a patient with cecal tumor, you actually never propose a total colectomy. and you just consent them for a right hemicolectomy. And that's because it's an oncologically safe and it's a functionally much better operation for them. So you don't even talk about total colectomy. And I believe it should be the same when it comes to the breast. If the patient chooses mastectomy, do we actually give them enough time to talk about the benefits of the BCS? And I'm not really sure if we do. So the main question to answer here is actually whether BCS is equal to mastectomy or not. And to answer that, we have really to compare BCS and mastectomy from oncological safety, cosmesis, and quality of life. And I was going to leave the answer of this question till the end, but I thought I'll let you know how I feel about this. And my answer to this is that BCS is actually not equal to mastectomy. In fact, BCS is better than mastectomy. So talking about the oncological safety, now if you look at this large observational study, this is the Danish group, and they published this in 2018. And they looked about patients between 1995 and 2012. They compared BCS and mastectomy from survival point of view. And they ended up with 3 different groups, as you can see, mainly the ones who had mastectomy and another group who had BCS. The total number of patients is massive, around 58,000 patients. And they had the survival and the SMR as their endpoints. And as you can see, these are the overall survival lines for the mastectomy. And you can see that the BCS survival is superior to the mastectomy group. And these are the adjusted values of the mortality rates and SMR. As you can see, no matter how you look at things, if you see at these columns here, no matter how you look at things, there is a tendency of 20% increase in mortality in mastectomy patients. And if you look at this forest plot, they did a stratified analysis, and you can see that no other factor actually affected the outcome. So BCS was favorable with different variables, including age, nodal status, adjuvant treatment, and year of inclusion. So if those factors are actually not affecting the outcome, could it be the radiotherapy? So what they did, another sub-analysis, which they stratified patients into patients who had radiotherapy and who hasn't had radiotherapy. And unfortunately, the radiotherapy had no effect on the outcome. BCS patients were still doing better regardless of radiotherapy. So they concluded from that study that BCS have, as you can see, better survival than patients who has assigned to mastectomy. Mastectomy seems to have a 20% higher mortality rate, and the radiotherapy does not seem to explain the observed difference in survival. This is another large population-based study from Netherlands, and it looked at the national registry at around 130 patients, comparing BCS with mastectomy, where they analyzed 2 different cohorts in older era between 1999 and 2005, and the more recent era between 2006 and 2012. And again, they looked at their endpoints were the breast cancer specific survival and overall survival. And whether you look at the older era or the more recent era, at young age or other variables, the hazard ratio, as you can see, is well under 1 in favor of BCS. What about young age? Young age groups in breast cancer has always been of interest. And there is a general belief that young patients should actually have mastectomy because it might be better for them because they're young. But even in young patients, studies show that BCS is a better option when it's a viable option. So this is a publication from Villa et al. From Milan. And it's a meta-analysis published in 2015. They looked at 5 population-based studies, and a pooled study of 2 clinical trials. Total patients about 22,000, all patients below 40, and the primary endpoint, overall survival and distant metastasis-free survival. And the results are quite obvious. It showed 10% risk reduction in patients underwent BCS over mastectomy. And risk reduction, I mean risk of death. Although the results were not statistically significant. This slide summarizes many different population-based studies, including the Danish group we discussed, the Dutch group we discussed, but there's also many examples, including the Americans, the Canadian studies, and they all have the same outcome, favoring BCS over mastectomy. Obviously, these are not randomized controlled trials. They're all observational population-based studies. But if you look at the number of patients involved in these studies, it overtops, any randomized controlled trial we ever had. So perhaps it's a level 2 evidence, but the evidence is overwhelming. So the second part of the talk is actually would be just one slide about the theories and why do we think that survival is better with the BCS. Obviously, there is no consensus on why BCS patients is showing a better survival, but these are some of the theories that I would like to share with you. The first one, is it the breast cancer, is it related to the circulating tumor cells which is being activated, which Dr. Sana, I think, also alluded to. Radiotherapy, from the Danish study, you can see actually that it isn't, but there has been some theories about this, what we call the abscopal effect of radiotherapy. This has been described in the literature in 1953. And what it means is that the effect of ionizing radiation on the residual breast tissue starts a systemic immune response, and that can protect these patients. Another theory about surgery, mastectomy, is not as small as people think. It's a bigger operation. It's more tissue damage. It's more inflammatory changes, and this could suppress immunity and affect the outcome. And finally, is it chemotherapy? Because there are some data that show different immune response after chemotherapy. So now comes a comparison between mastectomy and BCS patients from quality of life and aesthetic, and I call this the functional outcome of BCS. So the literature in this aspect is actually stating the obvious, that many studies show that patients are much happier when they keep their breasts, provided that they had an oncoplastic kind of breast conserving surgery. And to name some of these studies, this is a Nottingham study, and it's a comparative study from, I think, the Queen Medical Center group, and it's published in 2017. And the authors reported a case match comparison between BCS and mastectomy, but again, it's important to mention that the BCS arm mainly had therapeutic mammoplasties, which is the more oncoplastic kind of BCS, and for larger tumors usually. And the mastectomy arm was with those who had immediate reconstruction and implant-based reconstruction. At that time, they didn't have the breast Q questionnaire, so they used the BIS, which is the body image scale, and the PROMS, which is the patient-reported outcomes. In the BIS, these were the results. In the BIS scale score, the lower the value, the better the outcome, and you can see that BCS is scoring better in all aspects. And they also looked at radiotherapy and factored in radiotherapy in the results, and as you can see, BCS is still the better even with or without radiotherapy. This is another example, again, from the literature. This is from Sloan Kettering, and it's a comparison of the patient-reported outcomes comparing BCS with mastectomy. Again, mastectomy with implant-based reconstruction. The number of women, around 3,200 patients, and they filled or completed a breast Q and a PROM. And as you can see, BCS was associated with statistically significant higher scores over time compared with mastectomy and implant-based reconstruction. P-value was 0.001. And what was also noticed from this study that regardless of type of surgery, breast satisfaction scores decreased significantly over time. But the psychosocial and sexual well-being scores increased significantly over time. Again, just to highlight the group of patients, the young age group below 40, many again believes that women who are under 40 should have mastectomy. This is a retrospective study presented in San Antonio in 2018, and it actually compared the quality of life in young women below 40 between BCS and mastectomy with reconstruction using the breast Q. Included about 560 patients below the age of 40, and nearly 1/3 had BCS. But again, BCS scored higher in all subscales. So to conclude, I think in early breast cancer, where conservation is possible, again, we're talking about T1, T2 tumors, mastectomy is not an equal option to oncoplastic breast conserving surgery. And offering mastectomy in such patients, in my view, is not appropriate. If the patient expresses her wish to have a mastectomy, a detailed consultation about the benefits of BCS over mastectomy is a must, as evident in the literature with the current evidence, until we have different evidence. Oncoplastic BCS is oncologically superior to mastectomy with better survival as per the most recent evidence. Again, it's superior in the quality of life outcomes, scores higher than mastectomy in all subscales, so in functional, physical, psychosocial, and sexual well-being. Thank you very much for listening. And if you have any questions, I'm happy to answer.
Thank you, Dr. Mahmoud, for this presentation. I think the questions will be after Dr. Mahmoud al-Balas's presentation. I just want to check. I think he's with us. Dr. Mahmoud, you're with us now? Okay, so I'll present Dr. Mahmoud al-Balas, who is also a breast oncoplastic and reconstructive surgeon, and also is a consultant and general laparoscopic surgeon. He is a graduate of the Jordan University of Science and Technology, and he did his residency also in the Jordan University of Science and Technology. He had fellowship training in breast surgery in Italy, and he is an assistant professor of general and breast surgery in the Hashemite University, and a consultant breast and oncoplastic and reconstructive surgery in Prince Hamza Hospital and the private sector. And I know that currently he's pursuing a master's degree in cancer care informatics, and this really adds to the, the value of this conference, that we are just, going into new horizons. So he's gonna present a talk on breast cancer in the elderly, and Dr. Mahmoud, you can start sharing.
Okay. أي واضح الشيء عندك حاول still.
Yes, please. You can. Can you with my slideshow?
Okay. Is it clear now?
Yes, but if you just put it on full screen slideshow.
Okay.
Oh, great, thank you.
Okay. Thank you all, and thank you so for your nice introduction. Actually, I would like, before I proceed with my presentation, I would like to acknowledge that I totally agree with what Dr. Sana and Dr. Mahmoud has presented previously in their presentations. And actually, as physicians, cancer care providers, if we need to make a change, we have to start with ourselves. And the reality of both either neoadjuvant and the breast conservative surgery is not well actually clear for cancer care providers in Jordan. So we need to work more on those terms, and before even we try to convince people with these modalities. Today, my talk will be a little bit specific for a group of patients who are elderly patients. I will talk briefly about how can we select patients and select best treatments for those patients, and to clarify a little bit how those patients are treated in different countries according to literature. So at the beginning, we know all that cancer is commonly a disease of the old, and the median age of diagnosis for all sites cancer is 65 years old according to the United States shared data. And although the median age at presentation of breast cancer is 61 years, about 45% of breast cancer patients are 65 years and older. And the incidence of having a breast cancer actually increases with age. So is it clear from our table, adjacent table, that ladies who are 60 or more, they have a chance of 3.5% of having a breast cancer in comparison to 1.4% for ladies who are 40s. And about 1 in 4 patients with breast cancer above age of 65, or 10.6% of the total breast cancer population, are 80 years old or older. So elderly cancer patients represent a major public health issue, especially because of a high number of patients in this age group. The number of elderly patients living with cancer has increased in the last years due to longer life expectancy and the possibility to diagnose cancer early and to treat it accordingly. As by the year 2030, 20% of the population is anticipated to be aged over 65, so the proportion of elderly women with early breast cancer will probably grow considerably in the future. Breast cancer in this population tends to present later and may receive less than standardized surgical treatment due to comorbidities or prescriptions of the perceptions of the surgeon. They also don't receive less often chemotherapy or radiation. That's why, taking in consideration all these variables, management of patients in this age group will be challenging. So how can we define elderly women? Actually, chronological age of at least 65 years defines elderly or older persons in most developed countries. But this definition may not be easily applicable to many developing countries. Common use of the calendar age to mark the threshold of old age assumes equivalence with the biological age. Yet, at the same time, it is generally accepted that these two are not necessarily identical, and biological age is also influenced by the socioeconomic status. So, most people in the age range between 60 and 80 may enjoy high quality of life, but the condition of frailty characterized by bodily failure and greater dependence becomes increasingly more common with increasing age. A group of geriatricians proposed a general definition of frailty as physical state of increased vulnerability to stressors that results from decreased reserves and dysregulation in multiple physiological systems. And this actually is more encountered in elderly women. So what challenges in the breast cancer management we face in aging population? First of all, there is a large variety in characteristics within this population. So people might have additional comorbidities in addition to their age. The lack of evidence on the most suitable therapeutic approach, because those patients, mostly they are excluded from trials. There is limited data on older patients' preferences and higher risk of experiencing adverse effects and complications from surgery, radiotherapy, and even systematic therapy. So the cancer in elderly is not just a disease and a different age group, but also it has almost a different biological characteristics in comparison to young women. In one paper, which is a systematic review talking about breast cancer in elderly women and altered clinical pathological characteristics, they noticed that the mortality and even the incidence and even the mortality is higher in women who are beyond the age of 70 in comparison to those who are 40s or 50s. So a comprehensive geriatric assessment represents the best instrument to assess biological age and to assist surgeons, medical oncologists, radiotherapists in defining a personalized approach to the treatment of elderly women with breast cancer. In this systematic review also, they showed even those patients who are elderly having usually fewer T1 or more tumors in comparison to young age. They have more advanced tumors and even more frequently to have lymph node and even distant metastases. The breast cancer specific mortality was higher both at 5 years and even at 10 years. Regarding tumor biology in elderly, the prevalence of tumors with more indolent features is higher in elderly women compared to young population. Mucinous carcinomas represent between 4 to 6% of breast cancers in women, but this percentage is almost 1% in premenopausal women. According to the data derived from San Antonio Breast Cancer Database and the Surveillance Epidemiology End Results Registry, breast cancer diagnosed in elderly women had lower proliferative indices, normal p53 expression, diploid DNA compared with the breast cancer diagnosis in younger women. More ER expression, more PR expression, and lower HER2 overexpression. So the tumor biology in elderly women is expected to be more indolent than all population. In this study also, we can see that patients who are 70 to 79 years, almost they have 57% cases within T1 tumor, but this percentage dropped to 42% in those who are 80 years old. Even lymph node metastasis and metastasis, general metastasis or systematic metastasis is more common in those who are more than 80 years in comparison to those within the age group 70-79. Again, the overall survival in patients with 10-year survival in those patients who are 80 years or more will be less in comparison to young population. So how can we evaluate patients, our elderly patients for treatment? So we need to do what we call geriatric assessment. We can start our screening, what we call G8 questionnaire. And this is a short survey in which you can qualify your patients. Either they are fit to proceed for treatment or to send them for more comprehensive geriatric assessment to be sure that their medical conditions can be treated, can be managed before we start the treatment. So different studies have evaluated the G8 questionnaire and with a sensitivity of more than 92% and negative predictive value of 78%. So these are different studies that evaluated the G8 questionnaire, and we can see that the range of sensitivity for this questionnaire range between 90% to drop down to 77%, but still we can rely on this initial assessment before we take a decision for our treatment. So this algorithm shows the way that we evaluate and treat patients with or elderly patients with breast cancer. So we apply the G8 screening tool. If they score more than 14, then we go to standard or tailored treatment. But if they fail to score beyond the score 14, then we perform a comprehensive geriatric assessment, identify underlying problem, try to solve them, reassess again based on G8 questionnaire. If they reach more than 14, then you start a treatment. Otherwise, patients go to more or to receive less treatment or what we call palliative care. This is a G8 questionnaire, we can see there are almost 8 items, starting from loss of appetite, loss of weight during the last month, mobility, neurophysiological problems, body mass index, a number of prescriptions they receive, age, and even the general perception to their health score. So this can be easily applied before you take a decision to treat your patients. So how can age affect treatment? Actually, what the differences or the observed differences about elderly breast cancer treatment, in that there is less utilization of surgery, there is less utilization of sentinel lymph node sampling, so there is a tendency to understage patients in this age group. There is less utilization of radiotherapy. There is an increase the use of primary endocrine treatment as a sole treatment modality. There is less even to no participation in clinical trials. In this paper published in 2010 about breast cancer in elderly in comparison to young population in Netherlands, we talk about here about staging, and we can see that the blue rectangles here show that patients who are 80 or more, they are less likely to be staged in comparison to young population, and even they are less likely to present in early stage or what we call stage 1 in comparison to young population. So these are two main problems in this age group, either understaging or having an advanced stage at a presentation. Okay. Even let us see here how those patients are treated according to their age. We can see that patients who are 80 or more, they are less likely to receive radiotherapy after breast conservative surgery. They have higher rates of mastectomy in comparison to breast conservative surgery. They have less percentage or less chance to have axillary lymph node dissection. They are more likely to receive hormone therapy as a monotherapy, and even they have less chance to receive an adjuvant systematic treatment. So the problem here right now is, can we by our decision, can we result in under treatment for this age group or not? So the issue is under treatment or over treatment. A specific geriatric assessment tool should be applied for elderly breast cancer patients. It might help us in choosing adequate treatment. The ultimate goal mainly of cancer treatment for sure is to improve breast cancer specific survival with minimal toxicity, especially for this frail population. So what is the optimal treatment for elderly patients? Elderly women generally did not participate, as we said, in clinical trials, so we could not know what is the best treatment for those population. There is a lack of evidence-based guidelines dedicated to the treatment of breast cancer in this population. There is a variation in treatment patterns among elderly and younger women. It may be also due to difference, not also because of the age, but also breast cancer features and comorbidities, as we illustrated before. So before we take the decision to cancer treatment, we can refer patients to geriatrician or geriatric oncology to be evaluated, and if they fail to pass the 8 score, we need to perform a comprehensive geriatric assessment before we take a decision for their treatment. So there is nothing said only elderly patients. We need to know either they are healthy elderly patients or frail elderly patients, and this is the difference. This is make the difference, not being elderly, but the general condition of the patient what makes the difference in treatment. So let us talk about lumpectomy radiotherapy in elderly population. In a paper which is an Asian population study, and another paper published in Surgical Annals of Surgical Oncology about outcomes after mastectomy, lumpectomy in elderly patients with early stage breast cancer. It has been reported that older women have been less likely to receive lumpectomy in comparison to mastectomy or non-operative treatment. Other studies have shown rates of lumpectomy mastectomy to be similar to those in young population, but you need to know how did they select these patients. Seer analysis of patients 70 and over, examining tumor characteristics, treatment patterns, breast cancer specific survival, identifying improved survival with breast conservative compared with mastectomy in older patients. And Dr. Mahmoud Abu Daqq, before our presentation, said that mastectomy has been shown to be have more than or higher mortality in comparison to breast conservative surgery. Even the NASPP P6 trial established lumpectomy with irradiation as an equivalent therapy to mastectomy, and even it might be better as previously explained. So, according to the cancer leukemia group, they randomized about 9,343 patients, according to patients with the treatment with lumpectomy, tamoxifen, plus minus adding radiation therapy. They showed that radiation have improved the local control for this patient with no impact on overall survival, even after 10 years of follow-up. So breast conservative surgery for those patients with radiation still have a good option for improving the survival, even if you could not deliver a radiotherapy. So we can avoid mastectomy even in this age of this group of patients. Again, in another trial, which is a randomized control trial about breast conservative surgery with or without radiation in women aged 65 years or older, patients were randomized to receive or omit whole breast radiation. Patients were selected. They are 65 years old or more. They have early stage breast cancer, which is hormone receptor positive, node negative, and all patients received lumpectomy and adjuvant endocrine treatment. And according to this trial, they showed that there is after 5 years of follow-up, the ipsilateral breast tumor recurrence was almost 1.3% in women assigned to whole breast radiotherapy, and for 0.1% in those who not receive radiotherapy. But even the tumor recurrence in women assigned to no radiotherapy was 5.19, which was significant. But in both the groups, the 5-year overall survival was similar. So there was no impact of radiotherapy on overall survival of those patients. Again, back to the study, which was the Asian population study. In this study, they concluded that extremely elderly patients, especially with the stage 1-2 breast cancer, do not fare worse than younger patients, and they should be offered surgery if they are fit. So we should not depend only on chronological age before in deciding the treatment plan for our patients. Again, here, if we, for example, here, if we compare patients who are aged 80 or more with those who are aged 80 or less, we can see that patients who are aged 80 or more with surgery, they do better than who are aged less than 80 without surgery. So still surgery have a role in improving the outcome in patients, in elderly patients, if they are candidate. So what about mastectomy? So mastectomy, the general perception of mastectomy, it might have a less local recurrence. This is in according to our population, but it may be also a preferred operation, actually in multicentric disease, in cases if you could not perform breast conservative surgery because of advanced tumor size, or even, as Dr. Muhammad said, patient preferences. But some studies have found that as women age, they are more often treated with mastectomy compared to other therapies, because as we illustrated previously. And even in a survey of surgical medical radiation oncologists regarding treatment choices, oncologists were more likely to recommend mastectomy for a woman aged 84 compared to 76-year-old woman with the same disease characteristics. So this is the perception even according to cancer care providers. A paper have compared the outcomes after mastectomy, lumpectomy in elderly patients. It has been shown that patients who had lumpectomy with radiation or without radiation did better than patients with mastectomy in terms of overall survival or survival probability of breast cancer related specific survival. A survey of women of various ages who underwent mastectomy for breast cancer demonstrated women aged 50 and over identified that same reasons for mastectomy preference compared to the women under 50, and the perception that it might result in a reduced recurrence, improved survival, but actually it was not the reality based on evidence-based. While patients' preference is an important element of shared decision-making, this result identify potential lack of education in patients regarding evidence-based surgical management. We need to work on our patients and other healthcare providers in terms of selecting treatment. There may be also an element of surgeon bias toward mastectomy, as the patient will usually not require adjuvant radiation, even it may be omitted as previously discussed and can be omitted safely in this age group. So even let us talk. Can we offer breast reconstruction in elderly women? Still, it is an option. Reconstruction after mastectomy is often overlooked in older patients, and age alone has been shown to be a factor in decreasing the use of immediate breast reconstruction. And according to SEAL Medicare study, they found that 6% overall rate of breast reconstruction in patients who are beyond the age of 65. And analysis of the National Cancer Database data found that 11% of patients who are 65 years who received mastectomy had immediate reconstruction, and increasing rates of reconstruction in this population each year in the study period between 2004 and 2012. Lower rates of reconstruction were found in increasing patients' age, more comorbidities among those who received treatment at community small hospitals. So still, right now, we actually in our practice still we defer patients who are elderly from reconstruction. But if they ask for it, we need to discuss this with them in details. Axillary staging and dissection. We know that for several years, omission of axillary surgery in older women has been explored, and in order to decrease surgical-related morbidity. A clinical trial of Italian patients more than age of 70 with a clinically node-negative invasive breast cancer who received lumpectomy were randomized to no axillary surgery or complete axillary dissection. There was no survival advantage to axillary dissection with up to 15 years of follow-up. So we can avoid even it can result in understaging for those patients. It remains clear in those with positive note on clinical evaluation, adequate axillary surgery to prevent disease progression may be a standard of care. And again, here a paper published in the Journal of Geriatric Oncology about omitting axillary staging in elderly patients with early stage breast cancer, and if it impacts regional control or survival. They found, according to their randomized controlled trials, that axillary staging reduced the risk of axillary recurrence in comparison to no axillary staging, but there was no differences observed in breast recurrence or distant recurrence, and no differences in overall or breast cancer specific mortality. So breast cancer in elderly treatment, we have for sure favorable features for elderly breast cancer in comparison to young, but still we have also unfavorable features, including life expectancy, comorbidities, frailty, and in conclusion, we should say that chronological age of the patient alone should not contradict delivery a comprehensive adequate treatment for breast cancer women. The choice between mastectomy breast conservative surgery is mainly linked to the disease specific factor, patient preferences. Omitting radiotherapy after breast conservative surgery is not associated with worsening survival in comparison to radiotherapy group. The omission of axillary staging in clinically negative axilla may impact adjuvant treatment decision with no impact on survival. Comprehensive assessment is essential for classifying elderly into healthy or frail patients for proper treatment selection. Finally, as cancer care providers, if we need to make revolution in cancer treatment, we should start with ourselves. We should break all borders, even traditional borders in treatment, try to implement evidence-based medicine before making decisions in our treatment. Thank you all for listening, and any questions are welcome.
Thank you, Dr. Mahmoud. Actually, this is really an excellent presentation, and it's really an important topic. I don't see any questions in the chat, but I just have a question maybe to you and Dr. Sana. But if you could stop sharing the slides, Dr. لو سمحت. I mean, is hormonal therapy less harmful, you know, for the elderly? Because, you know, I'm always faced with this with the patients. They think that, you know, they're like literally some patients, they say that, oh yeah, I'm fine, I have breast cancer, I'm just taking this pill and I'm happy with that. And I'm not sure if it's really less harmful. Sometimes they ask me this question and I told her, please discuss this with your oncologist. So is it really less harmful? Because sometimes they don't offer the patient the standard of care, and these patients, they don't have other comorbidities, and maybe they're candidate for neoadjuvant chemotherapy if they were younger. I'm not an oncologist, and I don't want to step on the oncologist's work, but I have all of this question that is hormonal therapy less harmful? So I'm not sure Dr. Mahmoud Al-Balas or Dr. Sana can answer this.
Shall I start? Mahmoud, Dr. Mahmoud, would you like to comment first, or shall I go ahead?
Go, Dr. Sana, start.
You know, like Dr. Mahmoud said, age is not, you define your treatment for the patient based on the tumor and the patient that has the tumor. Yani the same tumor in two different patients would entail different decision. So is hormonal therapy by itself sufficient? I cannot say yes, I cannot say no. Some patients who are literally elderly, I have two patients in my practice with Alzheimer. They are in their early 90s, late 80s. One of them is about 92 years old with Alzheimer's. She has breast cancer. She's been in my practice for 3 years on hormonal therapy, controlled, local disease. I didn't put her through surgery after discussion with the family because there is data indeed in the literature. Those patients actually can do as well and even with morbidity less without exposing them to surgery. But this is the patient with specific comorbidity to derail me from going for surgery. At the same time, I had another patient who's 86 years old the other day with early breast cancer tumor, wire localized and removed and maintained on hormonal therapy because she looked like she's 70 years old when she came to my practice. She's completely with it. I offered her the proper treatment and she was a candidate for surgery. So I would never say because she's old, give her hormonal therapy and that's it, because you don't know how long she's gonna live. And indeed, breast cancer can behave nicely for 2, 3, 4, 5 years, and then it can mutate and become resistant. Another point, if the tumor dictates giving chemotherapy, you can adapt the chemotherapy to the status of the patient. And right now, we have guidelines for geriatric oncology. So I would not say no to chemotherapy because of age and just settle for hormonal therapy when chemotherapy is indicated. I might, however, attenuate the choice of chemotherapy for an elderly lady. So it is not age, it's age, performance status, comorbidities, and the tumor. It's never a pill only if the tumor is hormone receptor positive because she's old. By the way, I can treat a young patient also with only hormonal therapy without chemotherapy just because her tumor actually dictates that. And lately, last December, even patients with hormone receptor, with node positive disease, hormone receptor positive disease, they can only be treated with hormone therapy, some of them without chemotherapy. So it is not age, it's the tumor and the patient performance status and comorbidities. I hope that answered your question, Soha.
Yes, thank you, Sana. And I have another question. I think maybe you're the one to answer it, but like, you know, everybody can answer. I mean, so there's a question in the chat. Does hormonal IUD increase the likelihood of breast or any other type of cancer? From your observations, have you established a link between the two?
hormonal IUD.
Yeah.
Well, the data, I cannot say my observation, because this data usually is answered based on studies that included thousands of patients. Usually we refer to data from the Women Health Initiative study, and another large study national included healthcare workers. Hormone-based contraception, be it IUD, OCPs, or even hormone replacement therapy, has been studied. And lately, the risk for OCPs in particular has been demonstrated in a recent study to be minimal. So it increases the odds ratio at a rate of 1.12 to 1.6 or so. So it's minimal. However, your question is probably not related to general population. It's related to patients with breast cancer. If they have hormone receptor positive disease, it is a contraindication.
Yeah. Yeah, and that's important.
So I have a question.
Okay, yeah, تفضل دكتور.
So my question to Abu Daqqa.
Yes, please.
Mahmoud, it's somehow related to your lecture, but we are in an era where we expanded our indication for the genetic study, and even the number of genes in the test is getting like more and more. And we have a few data about the implication of positivity of that gene on the extent of surgery and the survival. So we know BRCA1, BRCA2, B53, but like nowadays I have patients young. We did a genetic study, came back like VUS for check2, ATM, PRD, I don't know what. So what do you think the best way to consent the patient, or our community, the patient always will put it back to you. You are the doctor and you know better than me, and you need to choose. And even if you told them I don't have data, and you need to be part of the decision to make like bilateral nipple sparing for a lady in her like 28 or 30, cosmetically it's gonna be fine, but she's gonna lose the sensation for the nipples and the skin, have a lot of implication on her like life. So how you deal with this situation for your patient, for that genes that we don't have data for it, for the VUS variant of undetermined significant, how you can address it to the patient and the consent and all these things?
Yeah, thanks, Ali. I think this is a difficult one because of the cultural differences and what we have there. That comes back to the medical paternalism. They want you to make their decision. It's easy if they are positive BRCA, you can tell them what to do. If it's negative, the VUS, I think as far as I'm concerned, it's negative because it has no clinical, till now. It might be significant in the future. But what is the reason for them to have the test? If they have a positive, strong family history, sometimes I still might steer the conversation towards having a mastectomy, depending on how many relatives, depending what's the relationship, is it a first-degree relative? And based on that, I might consider having a bilateral prophylactic mastectomy. But the main thing, whatever you're going to tell them, I think it's the consent, and you need to spend time with them and tell them. And often I don't make the decision the same visit. You send them away, come back in 2 weeks' time, you send them away another time, give them written material to read, and then they come back with it. I think that's how I do it. But VUS at the minute with no significant family history is probably not recommended.
May I have a quick comment? I completely agree with Dr. Mahmoud. Very nicely put. Having said that, not only that, VUS internationally is not recognized as increasing risk. Unfortunately, I wish we could put the data together and look at our own patient population, because remember, the association has been described based on family history from Western populations. We never looked at our region. Having said that, even when you have a pathogenic mutation in any other gene besides BRCA1 and BRCA2, there is no evidence that bilateral prophylactic mastectomy or oophorectomy has been associated with improved survival. So, for example, if you find a pathogenic mutation not VUS, in, for example, CHEK2, that is not an indication to avoid lumpectomy and breast conserving surgery. You still can do it and follow the recommended surveillance. Indeed, you cannot tell the patient that doing mastectomy would improve her chances of overall survival or local recurrence beyond a woman without that specific pathogenic mutation, which is contrary to what everybody else would believe. So you do it for the sake of more strict surveillance, for the sake of family follow-up or early detection. But indeed, not a single pathogenic mutation in any gene besides BRCA1 and BRCA2 so far dictates a different approach for surgery. Except, I agree with Dr. Daka, we might steer the conversation in favor of one approach versus another. But keep in mind, no evidence that we are really benefiting the patient.
It's clear for us that there is no evidence, but the problem in our society that, as Mahmoud said, you discuss with the patient, you ask her to bring, for example, her husband if she's married, and you discuss it again, you ask her, you don't need to answer now, think about it. But most of the time, especially for those with, I'm sorry, low socioeconomic status, they will throw the ball back to you and say, okay, listen, you are the doctor and you need to give me what do you think is right. And you just keep telling them, we don't have data that, which is better. We don't have evidence that this will increase or not, but this is what we have. The other thing, I think I will agree with Mahmoud. Sana, you think even if she has a strong family history of first degree relative with VUS, you think this will not add more risk for her upon the other population? And
No.
the other thing, the other question, if you think that this lady, for example, living in a district area, or for example, she is from our brother's neighborhood from Jordan, where they have a very bad situation, wars and all these things, and the follow-up will not be that much strict for her. So do you prefer to give this lady, for example, opportunity to do something more than lumpectomy, because you cannot guarantee that this patient will be really in a strict screening or follow-up after that?
Ali, I completely agree with you. Remember what I said, you take into consideration patient situation and the tumor. But believe it or not, if you go through the literature, even if you have a positive mutation, indeed, you diagnose the patient in her 40s, you put in an implant, and what is the risk of recurrence? If you go through the absolute numbers, they are minimal. And having implant for somebody in her 40s, exactly like what you said, hard to have follow-up and even care for that implant. And I'm not sure what's her social situation even after. Also, that carries a risk. They don't know how to follow that implant, how to do regular follow-up. If complications happen, nobody knows how to handle it. So there isn't white and black. You're absolutely correct. I do like Dr. Mahmoud said, I choose. And if there is a strong family history, I might be inclined for steering the conversation towards mastectomy. But indeed, if you look at the absolute numbers with a pathogenic mutation, not VUS is never an indication to do anything.
Sorry, Sana, even with a strong VUS, let's say CHEK2, ATM, whatever, VUS, and sometimes like 3 or 4 genes with VUS with a strong family history, like sister, mother. And her sister developed cancer in early stage. Like she's now 35, her sister in 32, 38, her mother somehow in 40s. So with such a situation, you still give the patient the full, the full way to decide, or you're going to steer the conversation toward, listen, you are at higher risk of getting cancer in the other side, and you need to go for bilateral mastectomy.
Can I comment on that?
That's a different scenario, Ali. that strong family history, most of the time without genetic testing, because with that family history, there is a gene that we don't know predisposing the whole family, even if I do genetic testing and it's a BUS. That's a different situation. What you are talking about exactly is a clinical judgment. Yes, I would be pushing for the approach for BRCA1, BRCA2 positive patient, even though I might test her and it's negative.
If I may, Ali, حتى without a testing, without even not
Exactly,
VUS, even if
that's what I'm saying to
yeah, even if it is negative, even if it was tested and negative with very strong family history. Yeah, that's what Sana said. I agree.
Yeah, I wouldn't even go for the genetic testing.
But again, do we do have data for this? Like, I agree with you, and this is my feeling and what I like to do. But do you have data that if 2 or 3 of the family, they are having a history of cancer, and the genetic study came negative, if the patient like well educated and asking for data, do we have data to confirm that this lady, she need to go for bilateral? I mean, to talk to lady like she is like 28-year-old. She is like in the beginning of her marriage, and then you ask her, okay, I need to take both breasts out, and you cannot be able to lactate. You're gonna lose the sensation in your skin and nipple, and all these possible complications. And you know, the cosmetic surgery sometimes will not get that much satisfaction for her. So this is again, if the patient asks for data, do we have this data, Dr. Maher or Sana or Mahmoud?
No.
Yeah.
No, I'll tell you what, Dr. Ali. If she doesn't have cancer, I will not offer it to her, even if she has 2 sisters and mother. If she has cancer and she is young, I will offer it to her clearly stating that we do not have data. Having said that, remember the initial data for BRCA1 and BRCA2 came before the full genetic testing, came from the Ashkenazi Jewish community. Actually, they did that before identifying the BRCA1 and BRCA2 and then reflected the data. So I will tell her, that's how I do in my clinic. We are Middle Eastern. The genes have not been fully tested in our population. I do the genetic testing to learn, but even without the genetic testing, in your situation, that is what I recommend, because your family is behaving like the families we know with genes. I might test you and all the genes are negative. That doesn't matter because we are still learning. I always tell my patients, I learn one new thing every day. I might answer you today about something a week ago I couldn't answer you confidently. All my patients know that. So I don't wait for the genetic test to judge my approach to my patient if she has such family history the way you are describing.
Just one comment to answer your question, Ali. In my practice, what I do, young patient, strong family history, mother, sister had cancer, she's 40-year-old. I will do the test because if she's BRCA or 1 or 2 positive, that's an easy decision. If she's not, now she's in a different, as Dr. Sanat said, category. There is no evidence in the literature to answer your question, but there is evidence that if she's a high-risk family patient, she goes into a different category where I can offer her different options. Option number 1 is prophylactic surgery, but we have to be careful about that. Option number 2, we can offer chemoprevention. And there is evidence for chemoprevention about high-risk patients, including A, family history, B, those with the indeterminate lesions like, the B3 lesions when we do the LCIS, the ADH people, all of these. There is the IBIS-1, the IBIS-2 trial. There is many. There is the NSABP-P1 in 1998, I think. There is evidence that chemoprevention can actually drop your risk of having cancer for high-risk groups by 50%. So that's another thing that you can offer those who are high risk, but they don't carry the gene mutation. And the third option is the surveillance, early surveillance and examination, MRI for youngs, etc., etc. So I hope that helps.
I'm sorry to interrupt, because we are 6 minutes past the next session. So, I would like you, there are lots of questions, but like I said, we can have like a forum online where we can answer these questions. So thank you. I would really thank Dr. Sana, Dr. Mahmoud Abu Daqqa, and Dr. Mahmoud Al-Balas for the presentations, and the audience, and all those who have asked questions and interacted on this session. This is really an important topic. I mean, the breast cancer, and I think as physicians and you know, each one of us faces this thing every day. So with now, I think I will ask Dr. Riyad Abdel Jalil, who is the moderator for the next session. Dr. Riyad, he is a consultant thoracic surgeon at King Hussein Cancer Center, and he's the head of thoracic surgery unit and the lung cancer service tumor board. And also he is the general surgery residency program director. Dr. Riyad had his general thoracic surgery fellowship from Mayo Clinic, and also he had other 2 fellowships in lung transplant and advanced thoracic surgery. And we're really happy that he's going to be moderating the next session on lung cancer. So Dr. Riyad.
السلام عليكم يعطيكم العافية جميعا ومساءكم سعيد. يعني first of all I would like to thank you very much for inviting me to this يعني interesting sessions. Actually the efforts are obvious, and it's very well organized and very beneficial for everyone, I think. I'm so honored to introduce the speakers for the lung cancer sessions. All of them are good friends of mine, and I'm so honored to introduce them. I will start with Dr. Salah Abbasi, who will speak about the personalized approach for treatment of lung cancer, non-small cell lung cancer. Dr. Salah Abbasi finished his medical school in Al-Ulum al-Technology, and then he went to the US, where he did his internal medicine in Iowa, and then moved to Washington, D.C., and did his fellowship in hematology oncology. Then Dr. Abbasi, he worked as a consultant there in Iowa University, and then moved back to Jordan, where he served in a lot of places as a consultant in medical oncology. He worked in King Abdullah University, and then in King Hussein Cancer Center, and then he's serving with excellence in the private sector. Dr. Salah Abbasi, the podium is yours.
Thank you, my friend Riyad. Thanks everybody. Thank you, Suha, and thanks for the organizers to invite me for this interesting topics today. I'm going to talk about personalized approach in the treatment of stage 4 non-small cell lung cancer patients. I'll share my slides. Okay. So as we all know, that treatment of oncology has been evolving over the last few years in a very quick pace. And yesterday there was good news for non-small cell lung cancer patients, that non-small cell lung cancer became number 2 in the world as cancer, and breast cancer now is number 1. So for the first time in years, non-small cell lung cancer is decreasing for some reason, or breast cancer is increasing. I'm not sure what's going on. So in my topic, I will talk about the personalized approach and how we are treating our non-small cell lung cancer patients according to their criteria. Not all patients are one, and we do not approach all of them in the same way. Before we go into details, I just want to remind everybody that the importance of a multidisciplinary approach in treating non-small cell lung cancer patients, even for stage 4 cancer patients, not only for early stage cancer. I remember when I was at KHCC, it was really very interesting, very important to discuss early stage cancer patients in the MDC. And we remember how we had really very nice discussions, and we came up with very nice plan of care. But now for stage 4 even patients, I think MDC approach is very important. And usually when we identify a patient, we identify the target lesion and we do the staging. And now we depend mainly on the PET scan for staging if available. Of course, we can do CT scan, chest, abdomen, and pelvis if it is clearly stage 4 disease, but probably PET scan for follow-up is more appropriate. brain MRI can be done in some selected patients, depending on their presentation and symptoms. And then we need a tissue biopsy. It's very important to have a tissue biopsy and good tissue, because now all our treatment depend on the molecular alterations in the tissue. And this can be done by a pulmonologist, interventional radiologist, or a surgeon, of course. Probably most of the cases are done by interventional radiologists nowadays because it's easier and faster. And our goal is to achieve to have a tumor biopsy or tissue biopsy by 2 weeks or less from identifying the patient to tumor biopsy should be taking less than 2 weeks. And then we have a pathologist, a very important rule now in the treatment of non-small cell lung cancer. Previously, we depended on the histology, squamous versus non-squamous histology. And of course, it was really important and still important to know if it is at least squamous or non-squamous. And now we really need a minimal biomarker testing on this tissue. EGFR, ALK, and PTL1, I think, is universal and essential in all institutions. Some institutions, they add more markers like ROS1 and BRAF and others, depending on the institution and the availability of the drugs. And our goal to achieve these results by 10 working days or less. This is to minimize the time before the patient have more symptoms and became not a candidate for treatment. So then the medical oncologist, of course, will decide the best treatment for the patient depending on these results. As we know, the classification of non-small cell lung cancer has evolved from histology to molecular subtypes. A few years ago, we depended on the adenocarcinoma versus squamous histology, and we choose the chemotherapy accordingly. And our results were good, but not as today. As you know, the progression-free survival with chemotherapy was only 4 to 5 months, and median survival is less than a year. It's usually 10 months. Now, as you can see here in this slide, in adenocarcinoma, we have many molecular targets now, and these are changing probably every month. We have a new marker. EGFR probably is the most important in patients with adenocarcinoma. But even patients with squamous cell histology, they still have molecular targets that we can look for. And EGFR can be seen in some few patients with squamous histology, especially younger patients who are non-smoker. So molecular histology and molecular classification of our patient is really very important. And here comes the role of the pathologist. It's really very important to have an institution, at least one institution in the country, who be able to do these molecular targets. So our optimal care for these patients depend on a tumor biopsy. To have these results, you need a good tumor biopsy and adequate biopsy. So FNA is not acceptable. Even small biopsies sometimes can be misleading and can affect the results. So we can take a biopsy from the primary tumor site or from the metastatic site, equally suitable. We do not recommend biopsy from a bone because of the decalcification and degradation of the DNA in bone biopsies, so the results will not be optimal. So if you have a bone metastasis, sometimes you can look for the soft tissue component of the bone metastasis, not the bone lesion itself. Of course, some patients, we're not candidate to have a tissue biopsy, so liquid biopsy can be done, although this is a little bit sophisticated and not available for everybody, and the results should be read carefully. But this is very evolving method to have a biopsy for some patients. The current recommendations for advanced non-small cell lung cancer, all patients should be tested for PTL1 expression using immunohistochemistry, regardless of their histology. Patients with non-squamous histology should be tested at least for EGFR mutation, ALK, and ROS alterations. Some can consider others like BRAF, MET, RET, and TRK. As I said, depend on the institution and the availability of the drugs. Some patients with squamous histology can be considered for these molecular testing, especially if they are young, never or light smokers, or the biopsy is small and you cannot decide on the histology. And as I said, the workflow, the procedure for this biopsy results should take 10 working days or less to be optimal. EGFR mutation probably is the most important molecular target nowadays in non-small cell lung cancer. And 10% of patients in the US and the Western population, they have this mutation, but we can see this mutation more in patients who are never smokers, adenocarcinoma, females, Asians. These patients, they have higher incidence of EGFR mutations. And the EGFR mutation, most of the EGFR mutations are present in exon 19 or exon 21, and these mutations are sensitive mutations. These are the mutations that we look for because of the availability of very effective drugs. Some mutations are resistant mutations, like mutations in exon 20, and we know that the most important resistant mutation is the T790 mutation, which is usually resistant to most of the first and second generation EGFR tyrosine kinase inhibitors. The incidence of EGFR mutations depends on the region. As you see here, in Asia, 40 to 55% of patients, they have the EGFR mutation. In the Western, probably 5 to 15%. In our area, in Jordan, and I think some of the data from the Gulf region, the range is between 15 and 20% of patients, of our patients who have non-squamous histology, they have the EGFR mutation, the sensitive EGFR mutation. And nowadays we have multiple options for patients who have the sensitive EGFR mutations. We have afatinib, erlotinib, gefitinib. We have the new drug osimertinib, which is active against even the resistant mutation, the T790 mutation. Some mutations, if you're available to identify some mutation, they will tell you which drug is best. But in general, most of the drug will work on the sensitive mutation in exon 19 and exon 21. So for patients who have EGFR mutation from the start, nowadays the recommendation is to start with EGFR tyrosine kinase inhibitor. The recommendation is to start with osimertinib if it's available in the institution, because as we will see later, it showed improvement in progression-free survival and overall survival over others. But you can start with either erlotinib, afatinib, or gefitinib if it is available. And once the patient progress, we test for the resistant mutation, the T790. And if it is present, then we go with osimertinib as second line. Osimertinib was compared to other first and second generation EGFR TKIs in the FLORA trial, and this is very interesting first line trial in patients who have non-squamous histology, who have an EGFR sensitive mutation, especially exon 19 or, as I said, in 21. These patients were randomized to osimertinib first line, as I said, versus other EGFR TKI. As you see here, there is significant improvement in a progression-free survival with a hazard ratio of 0.46. So more than 50% reduction in the risk of progression with first-line osimertinib in these patients. And even the update in overall survival, now it is available and it showed significant improvement with a p-value, significant p-value and a hazard ratio of 0.8. Median survival now is 38.6. So as if you remember when we talked initially about chemotherapy, in the era of chemotherapy, our median survival was 10 months. Now we are talking about median survival of 38.6 months in some patients. So osimertinib showed significant improvement in progression-free survival and overall survival if it is used first line, and it is recommended as first line if it is available. Because of the cost, I think it's a very big issue. So it is okay to start with gefitinib or erlotinib and to switch to osimertinib upon progression if it is not available as first line. So many drugs, even if you start with gefitinib and erlotinib, you still have a median survival of 32 months. So again, this is really very, very big jump since we used chemotherapy in non-small cell lung cancer. Another important molecular target is the ALK rearrangement, which is present in around 5% of patients, especially younger patients, light or never smokers, males here, more than females, adenocarcinoma patients. They have this ALK mutation. And we have many drugs now also for patients with this rearrangement. The first drug was crizotinib, and it showed really significant responses and was compared to chemotherapy and showed significant improvement in progression-free survival and was approved in these patients. And then we have second generation drugs like serotinib and alectinib. Alectinib showed even improvement in progression-free survival over the first generation ALK inhibitors. So alectinib was now it's approved as first line in patients who have ALK rearrangement. And we have other newer third generation drugs also for patients who progress. So if we use these drugs in subsequent method, probably you will achieve a good survival similar to patients who have EGFR mutation. We're talking here about more than 30 months median survival. Again, very excellent results in patients who have stage 4 non-small cell lung cancer. A few years ago, we never dreamed about these numbers in non-small cell lung cancer. Other targets will move quickly over them, like ROS rearrangement, which is present in 1 to 2% of patients. Again, younger patients, non-smokers, adenocarcinoma. Crizotinib showed excellent responses, 70%, progression-free survival more than 19, 20 months. Patients who have BRAF mutation also, 1 to 2% of adenocarcinoma patients, they have this mutation. You can target them with dabrafenib and trametinib. And they have responses of 60% or more. Patients who have MET exon 14 alteration, these patients also are very good candidate for treatment with the crizotinib. RET rearrangement, now we have a new drug approved for patients who have RET rearrangement. Previously, we used cabozantinib, which is used in renal cell carcinoma and showed excellent responses, but now we have a new drug, selpertinib, which is approved in the first line setting in patients who have RET rearrangement. And we have other mutations which are less, not very common, but you can look for them in patients who have no other options. So as you can see here, we have many molecular targets. We have many more to talk, but this is really just want to give you an idea about how we are dealing with non-small cell lung cancer patients now and how we can really subclassify these patients according to their molecular alterations, and we treat them in more effective way than previously with chemotherapy. Most of these drugs are associated with less side effects, better quality of life, and this is the data showed this. Most of these drugs are oral medications and give you a very good median survival, as I said, of 30 months and above. But if you take all these molecular alterations, you will find them probably in 20 to 30% of patients. So we still have 70% of our patients with non-small cell lung cancer who do not have any of these molecular targets. So, and obviously we can do chemotherapy in these patients with less responses and a median survival of 10 months. And here comes the role of checkpoint inhibitors, what we call immunotherapy. So this is for patients, the 70% of patients who do not have any of these molecular alterations. And very quickly how this works, we know that the tumor cells, they can express multiple antigens, which is not expressed in normal tissue. And these antigens can activate the cytotoxic T cells, and these cytotoxic T cells usually can go and have an anti-tumor effect, so they can clean the tumor cells. But some of the tumors, especially in patients with advanced disease, they can evade this immune response through the PD-1, PD-L1 interaction. So as you can see here, the activated T cells, they have in their surface the PD-1 expression, and some of the tumors, they can express the lesions like PD-L1 and PD-L2. And this interaction between PD-L1, PD-L2 on the tumor cell and PD-1 receptor on that T cell will deactivate or inhibit the effect of the activated cytotoxic T cells. So this way, the tumor will just suppress the immune response, and they will just evade the immune system in the body and will metastasize and increase. So what we do with immunotherapy, of course, we block the PD-1 or the PD-L1 with these immunotherapies. It's monoclonal antibodies, specific monoclonal antibodies, either against PD-1 or against PD-L1, depend on the type that you use. There's multiple drugs now available in the market. We call them checkpoint inhibitors. And by this way, you inhibit the inhibition. So the tumor will inhibit the immune system. So you will inhibit this inhibition. This way you activate the immune system to kill the tumor eventually. This is really very smart way, and it showed very effective way in treating cancer, many types of cancer, not even only non-small cell lung cancer. And what we will talk here about non-small cell lung cancer specifically. So these monoclonal antibodies can be used as monotherapy in some patients. One of the drugs, the earliest probably drug is nivolumab. Nivolumab as monotherapy did not show improvement over chemotherapy in these patients, even if they have high PD-L1 expression. But the other drug, pembrolizumab, for example, in this study, the Keynote 24 trial. These patients have a stage 4 non-small cell lung cancer. They have all comers, all histologies, squamous and non-squamous. These patients have high PD-L1 expression, PD-L1 of more than 50%. They were given either pembrolizumab alone or any combination of chemotherapy. And this is really a very clear evidence that immunotherapy alone in these patients with high PD-L1 expression is effective. We have a progression-free survival benefit with a hazard ratio of 0.5 and an overall survival benefit with a hazard ratio of 0.6. Excellent results. So in these patients, this is first line stage 4 non-small cell lung cancer, regardless of the histology. So immunotherapy can work alone. These drugs can at least pembrolizumab can work alone in patients who have high PD-L1 expression. In patients who have lower PD-L1 expression, it can work, but probably not. It doesn't seem that it works alone in a good way, like when the PD-L1 is more than 50%. So I'm not going to go into details, but I will just say about the combination of immunotherapy and chemotherapy in these patients. Because the idea, if immunotherapy can work alone, if we combine them with chemotherapy, we think that it will work better, especially in patients who have lower PD-L1 expression. So in this Keynote 189 trial, these patients with stage 4 non-small cell lung cancer who have non-squamous histology, they have any PD-L1 expression. They were randomized to pembrolizumab with chemotherapy versus the same chemotherapy with a placebo. And again, significant improvement in overall survival with the combination of immunotherapy, chemotherapy, with a hazard ratio of 0.45. So more than 50% reduction in risk of death with the addition of immunotherapy to chemotherapy. At 12 months, still 70% of the patients are alive. And they looked at the effect of this combination according to the PD-L1 expression. And they found that regardless of your PD-L1 expression, you will still have almost the same benefit. So almost all patients, regardless if the PD-L1 is negative, if the PD-L1 is positive but less than 50, and even if the PD-L1 is more than 50, all these patients, they have benefited from the combination immunotherapy, chemotherapy versus chemotherapy alone. Of course, from the previous data that I showed, patients who have high PD-L1 expression of more than 50, immunotherapy alone is better than chemotherapy. So the question here for these patients who have high PD-L1 expression, should we go with chemotherapy, immunotherapy combination, or immunotherapy alone? We don't have data which compare these two drugs or these two regimens in high PD-L1 expression. But we believe that patients who have high PD-L1 expression, they will do well with monotherapy. And patients who have less than 50%, they need a combination of immunotherapy and chemotherapy. And this also, the same way it was compared in patients with squamous histology. So the Keynote 407, these patients, stage 4 squamous histology. Again, all PD-L1 expression patients were included. They were given pembrolizumab with chemotherapy versus chemotherapy alone. And again, there is significant overall survival for the combination with a hazard ratio of 0.6. And again, the benefit was seen regardless of the PD-L1 expression. So we probably expect patients to have benefit if they have high PD-L1 expression, but even patients who have low expression and patients who have negative PD-L1 expression, they have the benefit from the addition of immunotherapy to chemotherapy in squamous histology. So the combination works regardless of the histology and regardless of the PD-L1 expression. Another drug is atezolizumab. It was also compared to chemotherapy in a stage 4 non-small cell lung cancer patient. And this is IMBioR 150 trial. Again included all patients with PD-L1 expression, and these patients randomized to one of the 3 arms, atezolizumab with chemotherapy, or atezolizumab with chemotherapy and Avastin, or Avastin and chemotherapy alone. So they added the immunotherapy atezolizumab to standard of care. And if you compare arm B and C, which is immunotherapy atezolizumab with the standard of care of Avastin chemotherapy, it showed significant improvement in survival over Avastin and chemotherapy alone. And also in this study, it showed that this combination, the 4-drug combination, it may be effective. I say it may be because this is sub-analysis from the trial. It may be effective in patients who have EGFR or ALK mutation who previously received a TKI and progressed. So this combination of 4 drugs may work in these patients in the second-line setting, because we know that patients who have EGFR mutation or ALK mutation or a driver mutation, they don't do well with immunotherapy. So, but this combination may have some activity. In the squamous histology, atezolizumab also was compared to chemotherapy alone. It was added to chemotherapy, and it showed improvement in progression-free survival, but this study did not show overall survival benefit. But it was significant for progression-free survival, which was the primary endpoint of the study. So what about patients who cannot tolerate chemotherapy? There was a combination of immunotherapy data. This is the Checkmate 227 trial for patients who have PD-L1 or patients who have no PD-L1. This is really a complicated multi-phase, let's say, multi-part phase 3 trial. It's a complicated trial, but essentially they randomized patients according to the PD-L1 expression and randomized them to nivolumab and ipilimumab, 2 immunotherapy drugs without any chemotherapy, versus chemotherapy versus nivolumab alone. So here we have a combination which is only immunotherapy combination without any chemotherapy. And again, if they looked at patients who have a high PD-L1, who have positive PD-L1 expression, let's say, and there was significant improvement in overall survival for the combination nivolumab, ipilimumab versus chemotherapy with a hazard ratio of 0.79. So significant result. Also, they looked at the results according to PD-L1 expression, even if for patients who have negative PD-L1, still the combination of immunotherapy, nivolumab and ipilimumab improved survival over chemotherapy alone with a hazard ratio of 0.6. So this is another combination. It's an immunotherapy combination for patients who cannot tolerate chemotherapy, for patients who do not need chemotherapy or they don't want to have chemotherapy. Is probably another option, and it works regardless of PD-L1 expression. What about the role of immunotherapy in the second-line setting? So some patients, probably according to institutions, I think some institutions, they still give chemotherapy upfront in their patients because of the cost of the immunotherapy. So for patients who never received any immunotherapy in the first-line setting, immunotherapy can still offer benefit in the second-line setting. And we have 4 trials in the second-line setting showed this efficacy. In the Checkmate 17 trial, nivolumab showed improvement in overall survival over docetaxel in squamous histology. And in the Checkmate 57, it showed nivolumab was better than docetaxel in overall survival in non-squamous histology. And these 2 studies were, the benefit was regardless of PD-L1 expression. In the Keynote 10 trial, pembrolizumab was better than docetaxel in the second-line setting, but these patients, all these patients have positive PD-L1 expression. In the OAK trial, atezolizumab was better than docetaxel, again in second-line setting, regardless of PD-L1 expression. So we have 4 essential trials showing that immunotherapy can still have benefit in the second-line setting, regardless of histology and probably regardless of PD-L1 expression. But just to say that, I said this before, that immunotherapy in general doesn't work well in patients who have a driver mutation like EGFR or ARC mutation. And these patients probably, if they progress after they receive multiple line of TKI inhibitors, they probably should be offered something other than immunotherapy like chemotherapy or any other target therapy. But immunotherapy doesn't work well. And for sure, we should not use immunotherapy upfront in patients who have a driver mutation. And I think this is important because now that's also emphasized the importance of having the results of the molecular alterations within 10 working days, because you need to decide what to give your patient as a treatment. If your patient has an EGFR mutation and you start immunotherapy and your EGFR mutation result will take 3 or 4 weeks, probably your patient will have 2 unnecessary and useless cycles of immunotherapy. So you really need quick results for the molecular alterations to have your decision and your plan of action. So now in 2021, this is how we look at non-small cell lung cancer. If you looked at the probably previous lectures in non-small cell lung cancer, we divided non-small cell lung cancer to only squamous and non-squamous histology. And in both parts, you will see chemotherapy options. And they're just different names, but different chemotherapy options with the same median survival almost. But now we have many, many options. So non-small cell lung cancer patients, now we divide them first according to their molecular biomarkers. For patients who have EGFR mutation, we have many drugs. Probably osimertinib is the best, but even if it is not available, it's good to start with any of the other EGFR TKI inhibitors and to leave osimertinib to patients who have progression as a second line if they have the resistant T790 mutation. Patient with ALK positive alteration, alectinib is the preferred therapy because the improvement in progression-free survival and because it is effective in brain lesions. But even you can use crizotinib or ceritinib or any other drug, and you leave alectinib or the third generation brigatinib for progression. So you have multiple drugs, and if you use them in sequence, probably you will achieve very good progression-free survival and overall survival. ROS1 even mutation, they have crizotinib, BRAF mutation, you can start with dabrafenib and traftinib. And for patients who do not have any of the molecular markers, you check PD-L1. And that's why we need to check PD-L1 in all patients. Patients who have PD-L1 of more than 50%, single agent pembrolizumab immunotherapy is effective and showed survival benefit over chemotherapy. The question that should we add chemotherapy to pembrolizumab if we have high PD-L1 expression? We don't have strong evidence for this combination, but from my experience and from some colleagues' experience, I think addition of small dose chemotherapy, it may be helpful initially, especially in patients who have very high load or high volume disease, to decrease the need for steroids and to decrease the inflammation associated with pembrolizumab.
Sorry for interruption. You have only 1 minute.
I'm almost done, Riyad. Thank you.
Okay.
So and we have multiple options. I'm not going. I went into details, but just to show that we have many options now for patients according to their histology and according to their PD-L1. If the PD-L1 is less than 50%, a combination of immunotherapy and chemotherapy according to the histology and the availability of the drug. And also we have an option of immunotherapy only regimen, which is nivolumab, ipilimumab in these patients. So we have many options now. And thank you, Riyad, and thank you for your time.
Thank you very much for the distinguished presentation and up-to-date scientific information. And we will leave the questions to the end of this session. Now we're moving to the next talk with Dr. Hamza Al-Baba, who's joining us from overseas, from Canada, Alberta. Dr. Hamza Al-Baba, he's a consultant in medical oncology in Alberta, Canada. He did his residency in internal medicine in Islamic Hospital and then did a fellowship in medical oncology in King Hussein Cancer Center. In 2015, he moved to Toronto, where he did his fellowship in in medical oncology in Princess Margaret Hospital, and he is now working as a consultant in medical oncology in Canada. Dr. Hamza will talk with us about the current and the future in non-small cell lung cancer. Dr. Hamza, welcome. Go ahead, please.
Thank you, Riyad, for the nice introduction, and مساء الخير للجميع. Thank for everyone who organized this meeting. It looks very interesting, to be honest. Also, Dr. Salah Abbasi, thank you for the nice presentation about lung cancer.
Thank you, Hamza. Nice to see you again. Thank you.
Thank you. As I tell everyone, Dr. Salah is one of my best mentors during my fellowship at KKHCC, and he is the one who has influenced my career after. Actually, I did my fellowship mainly in lung cancer in the last 5 years.
Thank you, Hamza. I'm proud of you.
Thank you, Dr. Salah. Let me start because I have some slides. There's a lot of data in lung cancer, which I'm not sure if I can summarize in that short period of time, but I will try to give as much as I can because it's exploding in the West now. Can I share my slide? Just 1 second, please. Share screen, this screen. I have no disclosures. So as we know, lung cancer is the most common cancer diagnosed in the developed countries, mainly in the West and North America, plus America. I think in the Middle East, still ranging from 2nd to the 7th cancer. It depends on the smoking in that area. It's the leading cause of death worldwide. It's the first fatal cancer cause in the world. Over than 70% of patients at time of diagnosis will be stage 4, and they will receive only palliative treatment. Until a decade ago, or even a decade and a half, the treatment used to be only chemotherapy with minimal few months improvement in overall survival. This is a recent nice special edition by the Canadian Statistics on lung cancer that was published just a few weeks ago. If you look at the solid line, which is the age standardized incidence in Canada, this is the male curve in the blue color. You can see between 1992 and now, it has been going down in the incidence, as well as the mortality is going down, which is great because lung cancer used to be one of the fatal cancers. Nobody used to even to treat them. If you look at the green solid one, it's for females. It's not going down. I think because of the smoking was high. The females who started smoking were higher. Also, their mortality is the same. If we look at one important part here for the subtypes of lung cancer or the histology, the smoker or the one types of lung cancer with associated with smoking is going down. Like squamous cell carcinoma is going down. The NOS part is going down, none otherwise specified. Large cell carcinomas also associated with smoking incidence is going down. But adenocarcinoma, for a reason or another that we don't know, it's going up, which is important. That's why we're looking at the testing now. This is the mortality rate in Canada. They are talking about that the mortality from lung cancer alone would be higher than mortality from colon, breast, and pancreatic cancer. We know these are one of the most common cancers, so mortality will be higher. In this curve, which was one of the time when we started to combine chemotherapy for lung cancer in 2002, we can tell that all of these combinations, platinum with paclitaxel, gemcitabine, docetaxel, or paclitaxel, they showed similar benefit. For sure, before that time, we used to have single agent drug chemo without a huge improvement. But after all of that, the median survival was around 8 months. The 1 year survival was 35%, which is not the greatest. After that, they start talking about the tumor histology. As Dr. Salah said before, we know that 15% are small cell lung cancer, but the majority are 40% are adeno. We call all of these as, except the squam one, we call them as non-squam. So then there was a study that introduced a new antifolate chemotherapy, which has showed further improvement, Pimetrix, that was 2008. If you look at this study, they compared this chemo, and I think this study opened the door for us to know more about tumor histologies. Because if you look here, they found out in survival probability in all patients were almost the same. But if you look at sub-tumor sites or histology, in non-squamous histology, which includes adeno, large cell tumors and non-otherwise specified, there was significant improvement. The hazard ratio for overall survival was not the greatest, but there was some reduction. So that was the era where they start talking about this chemotherapy and subhistologies. And then they found in squamous cell carcinoma, actually, it's not a good option. Actually, it's worse. If you look here, the blue line is the Pemetrexed with cisplatin. It has lower overall survival, which means the hazard ratio was increased. Then they start talking about maintenance, because before that, at the time of the Pemetrexed, we used to give 6 cycles of chemotherapy. Then they started the 4 cycles followed by maintenance Pemetrexed. If you look at the results here, there was significant improvement. Those curves with the amount of improvement was seen for the first time in 2009. And that was related related to Pemetrexed in non-squamous histology. So the progression-free survival showed hazard ratio of 0.44, and the overall also has been improved too. After that, they start talking about TKI, though we didn't know what they are. That was the first New England Journal of Medicine study on erlotinib. That was led by Dr. Shepard. By the way, she's one of my mentors. And this study in 2005, they treated patients with erlotinib after chemotherapy without knowing anything about EGFR mutation, by the way. But they realized that in this study, which I think, from my point of view, maybe it was not very ethical study because it was compared to placebo. For sure, if you give treatment, you compare to placebo, you might get any results. So they found out that overall survival has improved. It was 0.7 hazard ratio. The progression-free survival was 0.6. Everybody was happy with this result, has been approved, published in New England Journal of Medicine. But then a few years after, this guy, Kim, plus Dr. Shepard too, they did another study, but they compared gefitinib, which is another TKI or EGFR inhibitor, with docetaxel, which is a good study. Now you compare something with something. But they realized, oh, what's going on? Like everything is the same. There is no improvement. Nobody knew what happened. And the drug, for a reason or another, was approved only in Europe. Then this guy, who is the smartest guy, I have to know this name, Tony Mock. Tony Mock is one of the fellows actually who used to work with Dr. Shepard, but he's from Hong Kong. So he went back to Hong Kong. He did his study, compared gefitinib in the first line with the one of the commonest chemo we used, carboplatin paclitaxel, and patients with adenocarcinoma, Asian. So he was smart, then he was lucky because he was in Asia. He got all of those guys with the mutation. So after doing the study, he realized that overall there is some improvement if you look at the progression-free survival, but he realized that patients who have EGFR mutation and not expression, because before that time, before 2008, they knew only about EGFR expression, which is in about 80 or 90% of lung cancer. Then they realized after that there is something called EGFR mutation, and the hazard ratio was amazing. And he's the leader on most of these studies now. Also, progression-free survival for EGFR negative, it showed it was devastating. It's very bad. You cannot use this drug. And in patients with no EGFR mutation, it's like a lock and key. If you have that lock, you use the key. After that, they got some conclusions from the study. You can use this drug in mutation-positive patients only, but not for non-mutated patients. In 2009, most of the era of biomarkers started there. We moved from only sequem versus non-sequem cancers to all of those mutations. As Dr. Salah said, EGFR around 17%, and the Asian population up to 55%. But please keep an eye on the KRAS. This is one of the hot topics now here. Also, ALK mutation, we have the MET mutation. I'm going to talk quickly about each of them. But for sure, if anybody has any question later on, I have all the data. So this is another way we look at them. We divide patients to sequem versus non-sequemous non-small cell lung cancer, because the mutation that you can do, there are a lot, but you need to know when and where and which patients, because you cannot just do next generation sequencing or whole genome sequencing for every single patient. That would cost a lot, and most of the efforts would be just wasted, because most of those mutations are in non-sequemous patients, but you could find some of them in squamous patients and patients who are young and non-smokers. This is one of the ways that they use in most of the centers here in North America. They do first do immunohistochemistry to know if this is a adenocarcinoma or this is sequam versus others. Then they do for adeno or non-sequam, sorry, they do PDL1, ALK, ROS1, and EGFR. If there's any mutation, they treat. But if there is none of those and your patient is non-smoker, you might move to do further next generation testing. For sequamous patient, we do only PDL1. If my patient was non-smoker or they are young, I might do more, but I will not do those for smokers. This is another way to look at the same. If your patient has squamous cell carcinoma, do only PDL1. If the PDL1 is high, that's enough. You can treat. You have more than chemotherapy. But if they are non-smoker, again, we can do those testing. Just to let you know, most of those mutations are mutually exclusive, which means you could find one of those mutations in most, like in 97% of patients. Also you could find more than one mutation in the same, than one different EGFR and a mutation in the same category, but you cannot find EGFR with ALK. It's very, very unlikely, though I have seen so far 1 or 2 cases that they shared both EGFR and ALK. Now in 2021, there's many new drugs has been approved for EGFR. We have more than one drugs, but now everybody's going to osimertinib, and I will talk about it why. Though we have first generation gefitinib, erlotinib, this is the only second generation, and this is the third generation osimertinib. For ALK, as Dr. Salah said, there's many options right now, but to be honest, all of these now are superior to crizotinib. We have the MET exon 14, there is more than one drug. For ROS, we have the crizotinib plus the NTRK inhibitor, and more others, we have other options. I'll talk about the newer stuff in EGFR. As we said, 15-20% of the North American population, about 50% of non-smokers. There's many studies from the Middle East, Gulf areas, and other Middle East countries showed it's up to 25% in our population, because we are in between. We don't know if we are like Asians or like Europe, but most likely we are in between. There is higher incidence in females with adenocarcinomas, younger non-smokers. Most of those EGFR mutations are at exon 18 to 21, but 90% would be in those sensitive exon 19 and 21. There is some resistant mutations, as Dr. Salah said before, exon 20. Some of them are insertion, some of them deletion. You can target that drug accordingly. Also, T790M0 is the second most common acquired mutations. Many studies has been approved for those drugs which showed significant improvement in TKI or anti-EGFR with their first and second generation if you compare them to chemo in EGFR mutation positive patients. The response rate was between 50%, some studies to 80%. PFS has improved, also overall survival has been showed improvement. Like usually after we treat patient with anti-EGFR, like first generation or second generation gefitinib or erlotinib, many patients, they will progress. The message from this slide, please, if you've seen that your patient is progressing, don't just switch to another drug. You have to repeat the biopsy, because they found that around 60% of patients who have been treated for EGFR mutated lung cancer patient with first or second generation TKI, they have this specific mutation, one of the resistant mutation. It's called T790. And the theory about that the cancer has multiple clones. With the first, second generation, you might be killing most of the cancer clones except this one. But also we found other mutation. This is very important part. If your patient is progressing, but it's not behaving like an EGFR mutated lung cancer, it's not progressing slowly, and you've noticed a huge difference, please keep an eye on small cell lung cancer transformation, whether alone or with the same mutation, because it's around 4%. It's common, and we have seen that many times, which they would need chemotherapy first. Also, MET mutation, MET amplification, HER2 are common resistant mutation after first and second generation TKI. This is the study that showed osimertinib. It was a first, actually phase 1 study, after which osimertinib has been approved. And the idea about this drug, that on those patients with the resistant mutation, This is osimertinib. For patients with T790 mutation positive, there is a huge improvement in progression-free survival. Also, then after that, as we know, osimertinib has been approved in the first line setting, and that was after the FLORA study, which was published in 2018. This study actually showed a huge change in practice for TKI. Now for anti-EGFR mutation, if you look here, the progression-free survival for patient, whatever they have in the first line setting, even if they have T790 or they are negative for that, there is a huge improvement in progression-free survival with hazard ratio of 0.46. But the main area I need everybody to look at this one here, the CNS metastasis. As we know, in patients with lung cancer, the chemotherapy penetration to blood-brain barrier is less than 5%. If the patient has previous whole brain radiotherapy, SPRT, or even have cancer in their brain, you might have some improvement in the penetration of the chemo to the brain, or some drugs up to 20%. But to be honest, for the first generation, second generation, which they are erlotinib, gefitinib, and afatinib, the intracranial penetration is I would say not the greatest. It's less than 15% in some of the studies. But osimertinib has shown from this study that the penetration to brain could be up to 53%. This is a huge difference. Some of our patients with small brain metastasis, we don't treat them with whole brain radiotherapy. We just look at the response. It's amazing in the brain. So there was even significant improvement in PFS with patients with CN metastasis. For anyone who has a patient with EGFR mutation, if they have brain metastasis and they can offer this drug, ethically it should be used, to be honest. If you look at also progression-free survival in patients without CNS metastasis, it has improved with significant hazard ratio. Overall survival, it's also with good improvement in hazard ratio. Now it's the first line standard of treatment for treatment-naive patient with EGFR mutation, if you can afford this drug. Again, even after osimertinib, your patient might progress. You need to do the biopsy. Sometimes if your patient is young, he's interested, he has some money. I know in the private care sector now in Jordan, there is many resistant mutation. One of the most common is the C797S. Actually, the same guy, Tony Mock, is working on a new drug for this mutation now. But you can try to combine osimertinib with gefitinib because those can cover more clones. The other mutation is the C797S. Without, you can use brigatinib sometimes because it's like multi-kinase inhibitor. Small cell transformation, as we said, MET amplification, RET fusion, BRAF, HERAN2, and MEK. As Dr. Salah said, there is now some rule of liquid biopsy, but we need to be careful. We call it ctDNA. There is around 30% false negative results if you compare it with the tissue biopsies. So in some centers here, we send liquid biopsies. If it's negative, it does not mean that my patient does not have that mutation for T790. If there is any pleural fluid, I will send it. So again, as Dr. Salah said, I would confirm this info. If you have tissue, this is the best to send. If you have pleural fluid, would be number 2. Third would be the pleural biopsy. It's less actually informative than the fluid, the pleural fluid. And lastly, the bone. I would not send bone if I have other tissue. For alkyl arrangement, as you know, it's in younger patients, non-smoker, 47% of all patients, but up to 33% of patients with EGFR negative never smoker. There is many drugs has been approved. I will talk only about the newer generations. Dr. Salah has covered all of that before, but I have also mentioned in this table the different one: crizotinib, ceritinib, alectinib, brigatinib, lorlatinib. Will move now. All of them has been approved by NCCN guidelines, but I got this snapshot just to show you that the crizotinib is not anymore first line, and actually it's category 2B. Why? Because in 2017 we have the Alexa trial. Alexa trial actually the study that compared alectinib with the crizotinib in the first line setting, and that was amazing result. Like in here you can look. There is 0.47 hazard ratio and progression-free survival improvement. Alectinib showed a huge difference. In crizotinib before, we've never seen that with any drug. Also, the CNS progression, the main issue, it's the same as osimertinib. If you have a patient with ALK mutation positive brain metastasis, please stay away from crizotinib. It's not the nicest drug. But you can use alectinib, lorlatinib, all the other drugs. Their penetration to brain is much, much more. There is increase in the rate of in the response from 9.4 to more than 40%. Also, overall survival has improved, but you cannot see huge difference because of the cross over at the beginning of the study. Another study for another drug, one of the newer generation ALK inhibitor, brigatinib in 2018, alpha trial, the same, showed significant improvement because of the same issue. There is a huge penetration to the brain tissue with significant improvement. And the last trial that was just 3 months ago, the CROWN trial, compared lorlatinib, which is one of the most effective drugs. And because now if you look at ALK rearrangement, there is many subtypes you can look in beneath. And if you have the opportunity to test those mutation, you would find that lorlatinib will be covering most of those ALK rearrangement because they are not one. This one showed huge improvement. Progression-free survival, the hazard ratio was 0.28. For CNS, for patient survival without CNS progression, hazard ratio was 0.07. I've never seen that in any cancer study before, to be honest. For CNS progression, this is 0.06. This is huge. Now in some centers in North America, if somebody has a brain metastasis with ALK mutation positive, crizotinib is not ethical again. You have to use one of those if you have access. Because the study that, as if you're going to compare someone on crizotinib, they're going to develop brain metastasis. They're going to need whole brain radiotherapy, more mortality, more morbidity, more admission. So the cost effectiveness and cost utility of these treatment will be much less than starting, much higher than starting with lorlatinib. So it's not only the price of the drug. Overall survival has improved too. Now I'm going to move to another topic quickly, ROS1. As we know, there is 2 drugs approved, crizotinib, after this study, and which is part of the main study, the profile 1001, showed also significant improvement. This is the
Dr. Hamza, sorry for interruption. You have 2 minutes, okay?
Oh my goodness. Okay, I tried. So there is
I know a lot of information and a lot of
yeah, I will try to be
sure. Thank you.
So there was improvement in crizotinib. Again, there is another open label study approved, ceritinib, one of the ALK inhibitors, with significant improvement. But also here, one of the NTRK inhibitors, entrectinib, has showed significant improvement with patient with ROS1. And you can look at the cohort for ROS1, there is significant improvement. And this is the cut point for what we call partial response, 30%. Most of them responded. Even good brain penetration, you can look at the brain metastasis improvement. Even after only 1 or 2 weeks of treatment, all the patients responded. BRAF, there is 2 combinations, dabrafenib, traumatinib. You look at the waterfall, huge improvement. And this is one of the newer drugs. The message from this slide, I need to let you know that MET exon 14, you cannot test that in every single patient. You need to look at patients with sarcomatoid cancers. Lung cancer with sarcomatoid, the incidence is too high, 20 to 30%. And this drug, when you try it on those guys, it's amazing. The response is huge. You could look at the waterfall. Now we have at least 5 drugs approved for this drug, and some of them under studies, but this one is the most effective drug. Also, it has significant brain penetration. Again, there is overall response rates 40% to 60%. Depends on patients naive and patient responsive. There is more than one drug again. For RET diffusion, there is a lot of things happening right now. It happens in 1 to 2% of non-small cell, non-sequem, non-small cell lung cancer, but also 10 to 20% of biliary thyroid carcinoma. If you look at the newer drugs, serbercatinib, the overall response rate is 85% if you could find that RET mutation, which is a good way to look for it in young patients. Another drug with 93% reduction in tumor size is also another RET inhibitor. Again, it has significant brain penetration, which what we need for our patients. Lastly, quickly, I will talk about HER2 mutation insertion, 90% in exon 20. There is many drugs has been tried now, but please keep an eye on this drug. It's very toxic. It's extremely toxic. I've never seen any toxicities like this drug, but the response rate is high. And TDM1, the response rate is around 50%. This guy is not the greatest here. For KRAS, please, as we know, keep an eye on KRAS. There is many studies out there, but keep an eye only on those 2 drugs. Because as we know, KRAS is around 25 to 30% of non-small cell lung cancer. But we have this guy, G12C, which is one of the most common mutations in smokers, plus the one. If you have this mutation, there's this drug, Amgen study, or Amgen company, they did this study. The response rate is 100%. I've seen at least 12 patients on phase 1 study on this drug. There is no single side effects. The response is amazing. Patient who had chemo, immunotherapy without any single response, they responded in a very nice way. Keep an eye on this drug, please. For Intrac, everybody knows what Intrac. After that video came on some of the news in 2018, everybody was testing for Intrac. Please know it's less than 0.2% of cancers and only less than 1% of lung cancer. But if you have patients with salivary cancer, it's up to 40 to 50% of those, they have the mutation. Again, the response rate, and this drug is amazing, around 75% if you have the mutation, the Intrac or the Intrac fusion. Also, there is brain penetration with good response. I will be quick. I will not talk about immune checkpoints inhibitor. Dr. Salah has covered all of that. But again, you need to get this message. If your patient has EGFR mutation, please don't use this drug. There is a recent study, phase 2. They stopped using that drug because of the futility. There is a lot of fatal immune-mediated toxicities. A lot of studies also has been done on ALK and other mutated patients. It's not the greatest, but keep an eye on the EGFR one. And I think with all of that, I would conclude, keep an eye on the side effects from immunotherapy. It's very significant, life-threatening. But if you interfere early with the immune-mediated side effects, there is many guidelines. You can look at them. This is one of our work. You could look at this study. I could also share it, how to guide managing those side effects, because it's very critical. Otherwise, thank you.
Thank you very much, Hamza. Very, very nice presentation. And again, we will leave the questions to the end of the session. Now we have the last talk with Dr. Akram Ibrahim. When we talk about nuclear medicine, the name of Dr. Akram talks about itself for the proud. Dr. Akram, he is the head of nuclear medicine in King Hussein Cancer Center. He is leading the Society of Nuclear Medicine, the Arabian Nuclear Medicine, and he is the vice president of the Nuclear Medicine Federation in Asia. Dr. Akram will talk with us about the PET-CT scan and lung cancer. Dr. Akram, the podium is yours.
مساء الخير للجميع وشكرا دكتور رياض for the nice introduction. Also, I would like to thank the organizer for this national initiative in this important World Cancer Day and for their great efforts to have all of these high caliber speakers in this meeting. Today, I will be discussing the role of PET-CT scan in lung cancer. And as you may know, maybe since the introduction of PET-CT, and it was highlighted in the popular Time magazine in 2000 as the invention of the year, it is interesting to know that in Jordan, it was introduced just in 2004 and 2005 to Royal Medical Service and King Hussein Cancer Center. So we were from the pioneer in the region with the AUB in Beirut to start this service. And it has, PET-CT has really changed the way we understand molecular and metabolic function of the tumor and how we deal with the different type of cancers. And since the discovery of the cancer hallmarks more than 20 years ago, there have been many advances in our way to fight and deal with cancer, either in diagnostic or in therapeutic. And PET-CT as molecular-based imaging, we image at the level of the cells, at the level of the molecules. There have been many radiotracers which introduced, some of which have made inroad from the bench to the bedside, while others are still awaiting more robust data to give them the clinical phase. However, in Jordan, as you know, FDG, fluorodeoxyglucose, it is being used in more than 90% of PET-CT scan. Also, we have the gallium-68 DOTATOC that may be used for neuroendocrine tumor and for carcinoid in case of lung tumors. We have also the rising gallium PSMA, which is now being one of the most requested modality for the imaging of prostate cancer. Also sodium fluoride for the bone imaging, among other different radiotracers. We expect also in Jordan to introduce the FABI and some tyrosine for the amino acid imaging in this year or in the next year. Talking about FDG BIT CT, it is important to know what is going on at the level of the cells. This is the normal cells, and this is the metabolism of the FDG. It is almost like a glucose, but it will be returned in cells and will not be further metabolism. What is going on the tumor cells? There will be overexpression of the glutamine receptors in the tumor cells, so there will be more FDG introduced inside the cells. And at this level, the hexokinase enzyme will be overregulated, so more glucose 6-phosphatase will be available inside the cells. Also, the glucose 6-phosphatase will be downregulation, so more FDG 6-phosphate will be available inside the cell, and this is what we image in the BIT CT scan. And just to know the normal distribution of FDG bit, this is the MIB image, the maximum intensity projection. We have the physiologic distribution in the brain, in the adenoids, in the tonsils, in the vocal cords, some mild activity in the bone marrow, in the myocardium according to the fasting or postprandial status, in the liver excreted in the urinary system. We can see also in the urinary bladder, in the ureters, and in the reproductive system in males and females. So the protocol, also briefly, just about the protocol, we prepare our patients by instructing them not to do heavy exercise 24 hours, not to do shifting of the activity to the muscles, also to fast 4 to 6 hours to avoid the postprandial status, and also shifting of the activity to the muscular system. Also, we inject the dose about 2 to 4 megabecquerel per kg according to the generation of the BIT scan that you have. Also, the uptake period will be 1 to 2 hours. Then we start the scanning, and I will describe the scanning protocol. Then we do the construction, and what we use in our measurements is called the SUV, standardized uptake value, and it is measured by figuring out the activity in the region of interest divided by the total injected activity corrected to the body weight or the body lean. This is in general, but this is semi-quantitative analysis because there are many factors that may affect SUV, and we have to be careful in interpreting. This is the protocol briefly. The BIT CT gantry, it is a hybrid modality. There is a CT gantry, and most of the CT in Jordan, you may know, the slice is 16 to 64 or 128, so we can do the total or dedicated diagnostic CT scan. Then the BIT gantry. So first of all, we obtain topogram by the CT gantry. Then we obtain, usually in most centers in Jordan, we obtain low-dose CT scan without contrast, just not to expose the patient for high radiation, because the patient already will have another CT scan, diagnostic CT scan. And then we will have the BIT scan. And after that, we will have the fused images. So at the end, we will have CT, BIT scan, and the fused images. So we can look at the metabolic information, we can look at the anatomical information, and we can combine them and have the high-end. So talking about the BIT CT in lung cancer in the big picture, there are many clinical questions we have to answer. First of all, is it a cancer? This is in case of solitary pulmonary nodule or in case of masses. Then the mode, can we facilitate or help in guiding the biopsy in certain situation when there is maybe distorted anatomy and the tumor is not obvious where it is exactly. And then the most important question, how BIT CT can guide radical or palliative candidate for treatment and define the treatment options. And this works at 2 levels, intermodality and intramodality. We may change the GTV or a gross target volume based on the BIT scan, or we may change it from, for example, curative chemoradiation to only palliative, or from surgery to only chemoradiation, and we will discuss this in details. Define radiation treatment volume and radiation. And another important question, particularly as presented by our colleague Dr. Salah and Dr. Hamza, with all these new targeted treatment and this immunotherapy, it is important to know as early as we can, is this patient responding to this treatment or he is not? And at the end of the treatment, if there is any residual or recurrence, all of these we can answer. Starting with the solitary pulmonary nodule, and it is defined as smaller than a 3 centimeter nodule in the lung, not attached to the border or pleura without associated lymphadenopathy. And it can be detected incidentally or by screening program in some countries or during the workup of cancer. So we have to describe this, and most of these will be detected by the CT scan or X-ray. So where is the role of BIT CT scan? We have to recognize that there are 3 subtypes of solitary pulmonary nodule: the solid, part solid, and pure ground glass. In a pure ground glass, there is no role for PET-CT scan. In case of solid and part solid, if the solid is more than 8 millimeter in short axis, or if it is more than the solid part is more than 8 millimeter, then we can employ PET for this indication to tell if this is malignant or benign, or it is more likely to be malignant or benign, and how we can manage or follow up these nodules. For example, in solid nodule, if we have SUV more than 2, then this is concerning for metastasis, as we can see in this case. If it is less than 2, we can go back to the facial categories or the follow-up. Also in the subsolid, when we have, for example, cystic or subsolid parts, and we have solid part, also when the uptake is more than 1.5 according to the guideline, this is highly suggestive and concerning for being malignant, and we have to do either resection, which is both diagnostic and therapeutic, or taking biopsy from these lymph nodes. Another example we can see, for example, this 1 centimeter nodule, when there is no uptake at all, this is reassuring, and this is non-progressive, mostly benign, we can follow up by imaging. Another scenario, when it is high FDG like this, it is highly suspected, even it is 1 centimeter nodule also, and in this case, we have to do some further investigation like resection or taking biopsy. Another indication for PET, as I mentioned, is to delineate or help the guiding the biopsy. In some cases, when we have atelectasis and collapse, it is very difficult to delineate the tumor, and it is maybe difficult for the interventional radiologist to know where to put his needle. So PET scan can help in this scenario, and as we can see in this case, the viable tumor is only in this part, so the biopsy can be taken from this part, and this will save time and maybe effort for the patients. So in imaging, you know that the TNM is the major descriptors and the major delineator for the treatment options for those patients. And according to the NCCN guidelines and most of the international societies, the workup of PET-CT now is done by chest CT, contrast enhanced CT scan for the chest, and MRI to rule out brain metastasis. And we do PET scan, and it replaced the bone scan and the whole body CT scan for the abdomen and pelvis. And so PET scan can look exactly for the nodal metastasis or for the M status of this disease. So PET scan now, it is the major rule for the nodal and for the metastatic status. And talking about TNM, as you know, there has been a new edition which was introduced 3 years ago in 2017, and there was some important changes. Mainly these changes regarding the M status. Now it was the M1B has been divided to M1B, where there is just single extrathoracic metastasis, or M1C when there are multiple extrathoracic metastasis, and this introduces us to the oligometastatic status and oligometastatic concept, where more radical or more curative intent treatment may be applied. Also, the T has changed significantly. The T staging has, but no changes has been done to the nodal staging almost. So regarding the descriptor, as I mentioned, that it is the main role of the contrast enhanced CT scan. PET may has some added value, like for example, in this satellite nodule, to tell if this is hypermetabolic concerning for metastasis or not. Also, in some scenarios, I would like you to remember always that we have both modality in the hybrid PET-CT. We have the PET and we have the CT. So this is, for example, the CT part can answer some question, maybe like in this case, when we have minimally invasive or adenocytal carcinoma, it can help to recognize these ground glass opacities or some minor small subcentimetric nodule, which will not be detected by the PET part, but will be depicted by the CT part, and it will be reported in the PET-CT scan. So about the nodal staging, PET-CT has the major role. It is the modality of choice to assess the nodal. As you know, previously, we consider the CT scan lymph node more than 1 centimeter in short axis suspicious for metastasis. However, it is known that 20% of these lymph nodes smaller than 1 centimeter will be metastasis, and on the other hand, 40% larger than 1 centimeter will be benign. So PET-CT can answer these questions very precisely, and we can determine the treatment and the prognosis, and it is more accurate than CT scan. In this meta-analysis, looking at 39 published studies, the sensitivity of CT scan was 85% compared only to 61 in case of CT scan, with 90% specificity compared to 79. And this is also they looked at the enlarged or non-enlarged lymph node, and both PET scan did a great job in the assessment of the nodal metastasis. These are some cases from our daily practice at Kingston Cancer Center. As we can see, this aggressive and ugly looking right upper lobe hypermetabolic mass, and we can see this small lymph nodes, which maybe by CT criteria it would not be classified as metastasis, but it is hypermetabolic when, and usually we consider 2.5 or 3 as SUV max as concerning for metastasis. When biopsy was taken by EBUS, it was proven to be metastasis. Another case, almost the same lymph nodes or slightly more prominent, but there is no activity at all. And in this case, PET CT scan may provide knowledge about that. This is mostly not metastasis. However, till now, and according to the most guidelines, if the PET CT scan result would change the management plan, it is recommended to try to take biopsy by minimally invasive procedures such as EBUS or endoscopic ultrasound. Another case also, we can see that in this tumor with this small lymph nodes, I just put this case to highlight one fact, that even in the EBUS sometimes we have this hypermetabolic lymph node. The EBUS was negative, but when the endoscopy was done and this lymph node dissected, it turned to be positive. So sometimes the PET may provide more accurate information. It is according to the EBUS procedure, not always will be successful. There have been some limitations, and we have to take this in our consideration when discussing these cases one by one at the MDT level. Another scenario, also when we have this peripheral tumor, we have this mildly hypermetabolic elongated lymph node, we can suggest that this is not metastasis, but also this needs to be verified by EBUS or histopathology. Important concept here about the SUV in the primary tumor, as it is increasing, there were two important studies in this regard. It would expect more to have metastasis. One study put a threshold of 6 SUV max and the other of 10, and they both showed that this will increase the probability of having mediastinal lymph node metastasis. Another scenario, not always we will detect, in some scenario we will exclude, like this left perihilar lymph node. It would place the patient as NE3, and at this case it will be stage 3B beyond the surgery, but PET CT scan excluded any hypermetabolic activity. And in this scenario, when we have this high intense activity in the primary tumor, this would exclude about any concern in this lymph node. So how we verify some of our results by PET? As I mentioned, there is the endobronchial ultrasound and the endoscopic or endoesophageal ultrasound, and these are the lymph nodes in pink that can be targeted by the EBUS and endobronchial ultrasound. These in yellow can be targeted by the EBUS, and these in the blue can be targeted by the endobronchial. And sometimes in expert hands, we can go and take biopsy even from the adrenal gland, which is a common site for metastasis. Talking about the metastatic status or M status in the TNM staging, it is also the main role of PET scan, and PET scan has prevented more than 20% of futile surgeries, because it can show that this patient has metastasis, and this has been encountered in about 1/4 of patients who haven't been diagnosed to have metastasis before PET CT, but after PET CT they have shown to have metastasis. And also this is important in case of the oligometastatic status, when we have, this is one example for this left-sided upper lobe hypermetabolic mass lesion, and we have this right infraclavicular lymph node unexpected, but it was proven to be metastasis. Another scenario where we have almost nothing in the adrenal by the CT scan, but we have a very well-defined hypermetabolic nodule, suggestive metastasis, and this will be M1B in this case. And maybe we can direct some curative treatment for this solitary metastasis. So it is important also sometimes we can downstage when we have the tumor signature of this very high intense FDG uptake and the contralateral nodule, there is almost no uptake. We can exclude metastasis by confidence, and we can follow up and provide the curative intent for those patients. So the impact, it has been shown that PET CT changed the stage in about 30%, and it has an impact on the outcome of those patients. in about 40%. And the oligometastatic status is very important, as I mentioned, to have single pleural lesions, or we can have, in the case of single adrenal metastasis, we can direct the treatment. Even sometimes in this normal bone scan, and we have this aggressive lytic lesion involving the cervical spine, which was not seen here, very intense, very hypermetabolic, we may provide some radiotherapy as a focal treatment for this lesion, also try to treat this one. This is also under investigations, but it can be explored. Another important aspect where PET-CT can help when we, in the case of relapse or recurrence and after a new adjuvant treatment, in this study, they have shown that it can provide downstaging 30% and upstaging about 23%, especially in those patients. The anatomical landmark will be distorted, and we need the functional imaging to provide more detailed information. As we can see in this patient, after new adjuvant, we can see that there is a viable disease, there is almost inflammatory changes, post-treatment inflammatory changes, and even this adrenal gland, we can say that this activity is less than the liver. The cutoff value for the adrenal is less than 3, and so we can suggest that this is mostly benign adenoma, not malignant. Also, how we can guide radiotherapy, the role of PET-CT is very essential and critical in the radiotherapy. As we can see from this case, this is what we see in the CT scan, and when we do the PET scan, we can delineate the GTV and the planning target volume very precisely, and so we can spare the normal organ, and we can modify the dose to deliver the highest radiation dose to the viable tumor itself. The role of PET-CT, it should be used first of all to choose the proper candidate for radiotherapy by excluded metastasis, or by providing more information about satellite nodule or nodal metastasis. Also by planning the radiotherapy, as we can see in this case, visual method is recommended than semi-quantitative or using the SUV. Also, it must be acquired in the full standard setting as being acquired in the radiotherapy department, and the scan should be very close to initiation of the radiotherapy. The recommendation to be less than 3 weeks. If we meet all of these criteria, the results will be very positive. We are pleased that we have participated in this multicentric trial guided by the International Atomic Energy Agency, how PET-CT can be utilized in the low and middle income countries and how it can improve the outcome. This study had 2 phases, one retrospective, and this was based the radiotherapy planning based on the conventional imaging without PET scan, and this is in red line here. And the prospectively, when PET-CT scan, when the GTV was based mainly on the PET-CT scan, and we see that there is a significant difference in the Kaplan-Meier in both overall survival and progression-free survival. It was in favor of PET scan, and this was conducted in 11 countries in the low and middle income countries after providing proper training for both the radiation oncologists and the nuclear medicine physicians. Also, this was just recently published in the Lancet Oncology, and also it showed that the patients who the target volume was based on the PET scan had better outcome compared to the patients where the staging was, or the GTV delineation was based on the conventional imaging alone. Another indication after the stereotactic ablative radiotherapy, as we can see in this case, and this is T1, can be treated by stereotactic radioablative therapy. And this is just post-CT scan, post-treatment. We can see that this nodule is almost a little bit larger than even the baseline. But when we look at the PET-CT scan, there is no significant activity, and this means this is a scarring tissue without any viable tissue, and we can follow up with those patients. As Dr. Salah and Dr. Hamza have presented a very sophisticated cocktails of the treatment. Also, there is a major interest about the immunotherapy and how we can assess response to immunotherapy. I guess in lung cancer, immunotherapy started in 2014, 2015 with the nivolumab, and after that there have been many tracers. So it has been investigated how PET scan can help to see and investigate this treatment. So we can define by PET imagers or by radiologists 4 types of treatment, of response to treatment. First is hyperprogression, and this is very, very bad prognosis for the patient. And the second one is the pseudoprogression, and this is very tricky for the nuclear medicine physicians and for the radiologists, as well as for the oncologists who are treating those diseases. And then the durable partial response or durable complete response. Those are the most difficult to recognize, and because they will determine how patients will continue to have this cost treatment and sometimes with significant side effects. So it is important to assess the response to treatment as early as possible in the course of the disease. So it has.
Sorry, Dr. Akram, for interruption.
Okay.
We have only 2 minutes to go.
Okay, almost.
Thank you.
We can use BIT before treatment to identify which patient may. This is all in the early phase of research, but there have been many important publications in this regard. Before treatment and then during treatment to tell which patient is responding, and then after treatment to tell when we can stop this type of treatment. So in this one publication, it published I think 2019, or they looked at the SUV max of the primary tumor, and interestingly enough, that patient with high SUV, and the cutoff value was here 11, usually would show better response compared to the patient with lower SUV when we use the PD-L1 immunotherapy or sensitive. This is also another indicator during the therapy how we can use PET CT scan. This is the baseline, and this is after 1 month of nivolumab. We can see by CT scan the nodule is larger in size, but the PET scan showed regression of activity. Follow up after 3 months, there is also regression of activity, and this is what we call pseudo progression, where PET scan can help, and as we can see in this curve, the PET scan can help. However, there are many publications and many concepts that we can use, like the metabolic tumor volume. We have to define 5 target lesions, not only 1 lesions, and the clinical outcome of the patient is very important. If the patient clinically is very well, and we have few lesions like this patient, he has a new brain lesion, but the other treatment, what we call here immunotherapy persist criteria, the other 5 target lesions show overall metabolic tumor volume less than the baseline, then we can continue provided the patient is responding clinically. Also, we have to recognize there have many side effects we have to be aware, like having radiation pneumonitis, and many side effects can be seen and may be false positive by BIT, but with expert readers, I think this can be avoided. So my take-home message that PET scan is indicated to assess solid and partial solid pulmonary nodule when it is more than 8 millimeter. It can guide biopsy. PET scan is the modality of choice for the definition of the nodal status and the metastatic status of lung cancer, and the critically impact management plan, and it has significant impact of definition the GTV and partial and the planning target volume for radiotherapy, with significant impact on the outcome, and it has a potential to monitor response to advanced treatments such as immunotherapy and some TKIs. Also, it can delineate a tumor recurrence, particularly when anatomy is distorted. And thank you for your attention.
Thank you very much, Dr. Akram, for the very nice presentation, and a lot of thanks to the speakers for the very distinguished presentations. We have one question on the chat asked by Dr. Mahmoud Sarhan for Dr. Salah and Dr. Hamza. And the question was usually within like how fast can we see the response of the targeted therapy? And the answer was by Dr. Hamza, within 1 to 2 weeks of targeted drugs, but for immune checkpoints, inhibitors need at least 3 months. Thank you, Hamza, for the answer. So I have a question for Dr. Salah. Actually, 2 questions. Do you do genetic and immune checkpoints testing for all patients diagnosed with lung cancer, or just when you have progression or when you have a stage 4 lung cancer? So do you do it up front or just when you diagnose stage 4?
Yeah, thank you, Riyad. I think so far we're doing it for patients who have stage 4 disease or patients who have early disease upon progression or relapse. I think the data for molecular targets in patients who have early stage disease is not very strong yet. Although now we're starting to see some benefit of adjuvant, like for example, adjuvant EGFR inhibitors for patients who have advanced early stage disease. But so far, it is only for stage 4 patients who have relapse or progression, not for early stage disease.
Okay, thanks. My second question is regarding the patients who molecular or genetic testing were negative, and they have PDL less than 50%. Do you usually start with chemoimmunotherapy, or you just give chemotherapy and preserve the immunotherapy as a second line?
Yeah, thank you, Riyad. This is really a very interesting question, and I think the answer depends on the institution and the cost. I think more important than the data itself. The data is clear that to start with chemotherapy and immunotherapy upfront is much better with progression-free survival and overall survival benefit than leaving immunotherapy single agent for disease progression or second line. So if the cost is not an issue, I think all patients with the PDL1 less than 50% should be offered chemotherapy and immunotherapy combination. Of course, if the cost is an issue, and as we know, non-small cell lung cancer patient population has been increased significantly over the last few years. So you need really a large budget for these patients. So if you want to limit your budget, you can do it this way. Start with chemotherapy upfront, and if they progress, you offer them second-line immunotherapy, but this is not the best approach, I believe.
Okay, thank you. I have another question for Dr. Hamza. You mentioned some important information about patients with EGFR positive and brain metastases. So for asymptomatic patients with EGFR positive, do you spare the whole brain radiation until they progress on EGFR targeted therapy, or you just go ahead with the brain radiation?
Yes, thank you, Riyad, for this good question. Yes, if they have small brain lesions, asymptomatic, and osimertinib is an option, for sure I will spare them. I would avoid the acute and late toxicities of radiotherapy because we have seen many patients who achieved complete remission in the brain with osimertinib alone. The usual dose, 80 milligram per day. Some studies showed doubling the dose, but 80 milligrams still enough.
Okay, thank you. My last question and comment for Dr. Akram is just the first. I will start with a comment for the planning for chemoradiation. We just in KHCC we just changed the one of the key performance indicators to involve the PET-CT planning for chemoradiation for all patients, and the target should be 100%. So I believe that involving PET-CT scan not only for diagnosis and staging, only for planning of a treatment is crucial. So as you mentioned, it's very crucial for decreasing the toxicity and being part of the treatment plan. My question is about the role of PET-CT scanning with GGOs. Do you use it just for diagnosis or for follow-up, or just follow up with CT scan, and if there's a progression or increase in the size or solid component more prominent with the pure GGOs, do you use PET-CT scan for follow-up or just for diagnosis upfront?
As I mentioned, in the GGOs, maybe the CT scan has better role in the follow-up. If there is any maybe equivocal lesions by the CT scan, in the follow-up phase, I will go for the PET scan. But in the GGOs, especially the CT scan may provide more precise information.
Okay, thank you, Dr. Akram. I don't see any more questions on the chat. And if there's no more questions, I think we can conclude this great session. And thank you very much again for the speakers for the state-of-the-art presentations.
Thank you everyone.
Thank you guys, it's nice to see you.
Okay, thank you. Dr. Sehat.
Okay, thank you رياض. I mean couldn't thank you enough عن جد جلسة رائعة بكل ما تحتمل كلمة من معنى. دكتورة ميسة معنا I think دكتورة ميسة خضرا هي رح تكون she's gonna be the moderator for the next session, and it's the last session of the day. Well, thank you everybody for staying for us that late on a Friday. دكتورة ميسة, she is the senior consultant obstetrician and gynecologist. She did her residency and her undergrad in the Jordan University, and she was a consultant in Jordan University hospital and one of the faculty at the Jordan University. She's now in her private practice. دكتورة ميسة تفضلي. دكتورة ميساء.
اوكي. هاي دكتورة سهى، مرحبا للجميع، يعطيكم الف عافية. It's my pleasure to be moderating this last session, which is very interesting for most of us gynecologists here. Our first lecture will be presented by Dr. Ihab Rayyan. It will be about updates on cervical cancer screening and management. And Dr. Ihab Rayyan, as all of us know, is a subspecialist gyne-oncology at King Hussein Gyne-Oncology Center in Amman, Jordan. He finished his subspecialty training in Sydney, and it will be our pleasure to host Dr. Ihab to talk about cervical cancer screening. Welcome, Dr. Ihab. We are listening.
Good evening, everyone, and thank you for inviting me to this great conference. So we'll just talk about the new updates on cervical cancer screening and management. As we know, cervical cancer is the second most frequent cancer among women worldwide and the most common cancer among women in developing countries, and it is the most frequent cause of death from cancer in women from developing countries. The cause of cervical cancer is the human papilloma virus, with HPV 16 and 18 form about 70 to 80% of all causes of cervical cancer, while the other high-risk types form about 20%. And once the cervix get infected with the virus can reach the basal cell, and in a few weeks, viral replication can occur, and usually the body will heal itself within 2 years in more than 90% of cases. But when the HPV DNA integrated into tumor cell DNA, cervical cancer can happen after invasion to the basement membrane, and usually it can take more than 10 years, and it occurred in less than 1% of cases. Risk factors for cervical cancer is infection with the human papilloma virus, starting first intercourse at an early stage, multiple sexual partners, lack of regular screening, history of other sexual transmitted infections, low immunity, HIV infection, multiparity, immune deficiency, prolonged use of combined oral contraceptive pills, smoking, and other genetic factors as well. If we look to the prevalence of cervical cancer, it is still high in Africa and Central America and Mexico. The prevalence in Europe is low, while in our region, we don't have the exact numbers, but it's expected to be lower than Europe. Cervical cancer deaths are expected to duplicate by the year 2035. And if we look to the numbers about the prevalence of HPV infection in the region and cervical cancer cases and deaths, it's still high in some of the countries around Jordan, with Morocco and Turkey occupying the top two most countries having high HPV prevalence. And when we look to the WHO data in 2018 for the size of burden in Jordan, they just published more than 100 cases every year, a new case every year, and more than 60% of those cases die, with a crude rate for incidence 2.1. And when we compare the cervical cancer mortality in Jordan compared to Western Asia and the world as well, our numbers are low, but the crude mortality can reach 1.2 compared to 2.3 in Western Asia and 8.2 in worldwide. Cervical cancer incidence in Jordan, if you compared it to Western Asia, Jordan occupied the rank 13 and the rank 14th in cervical cancer mortality compared to other countries in Western Asia. And if we look to cervical cancer incidence compared to other types of cancer in Jordan, cervical cancer occupies the rank 12th, with breast and colon cancer, they form the first two leading causes of cancer in Jordan. And it ranked the 14th in cervical cancer mortality from cancer in women in Jordan. This is mainly related to poor screening program in Jordan. There was two studies looking for the coverage of cervical cancer screening. The first one in 2007, and it showed that less than 1/4 of women above the age of 40, they had a prior pap smear or screening program before, and the numbers below the age of 40 are still lower. And they looked after 5 years from the first study, and the numbers are still the same. And again, only 26% of women above the age of 35, they had either at least one pap smear before. The most common type of cancer of the cervix is squamous cell carcinoma, and it forms about 3/4 of all types of cervical cancer, followed by adenocarcinoma, which form less than 1/4 of all types of cervical cancer. The primary goal of cervical cancer screening is to detect treatable abnormalities and precancer lesions, as well as detection of cervical cancer at an early stage, while avoiding the detection of transient HPV infection and other benign abnormalities that could lead to overtreatment and will be harmful for the patients. George Papanicolaou was the Greek doctor, and he was the one who started the cervical cancer screening, and actually he was studying the abnormal cells on the vagina of the guinea pigs. And after that, he migrated to the USA, and they applied his idea on detecting abnormal cells in human bodies. And in 1943, they published his idea about detection of cervical cancer by picking abnormal cells from humans. Methods of screening of cervical cancer, we have mainly two methods, either cytology or HPV testing. The cytology, which is divided into the traditional way, which is the cervical pap smear. It is the standard method of screening, and it can reduce the risk of cervical cancer by 60 to 90% and death rate by 90%. While the liquid-based cytology, or what we call the thin prep test, can be used as well. The other test is the testing directly the human papilloma virus. In 2003, it was approved by the FDA as a new approach for cervical cancer screening, but as a co-testing in conjunction with pap smear, and it is indicated only for women above the age of 30. But in April 2014, the FDA approved the HPV testing as a primary screening for cervical cancer. Pap smear is very simple procedure. We're just collecting the cells from the ecto and endocervix, spread it on slide, fix it with alcohol, and send it for the lab. While the thin prep, it is different. After collecting the cells from the cervix, it is inserted into a special solution undergoing centrifuge, and to separate the abnormal cells from blood mucus and discharge. And after that, they collect the cells from the bottom of the bottle, and they send it again for the lab. So the issues to be considered with cytology, it has a low sensitivity and about 20% false negative rate. This is mainly related to sampling error or artifact, mainly from blood, mucus, or air dry while collecting the sample. And it is unable to identify those women who are at a further risk of developing cervical cancer. and the precancer lesion. If we look for the evolution of cervical cancer screening, it has started in early 70s with identification of HPV changes in cytology. And in 1996, the introduction of liquid-based cytology as a reflex testing. In 2000, FDA approved the HPV test as a co-testing for ASCOS pap smears. In 2005, there was a shifting in HPV 16 and 18 genotype to distinguish high-risk types causing high-grade dysplasia. And lastly, in 2014, the FDA approved HPV as a primary screening program. All that happened after one study, which is called the Athena study. And all recommendations was by the American Society of Colposcopy and Cervical Pathology. They used to start the screening by the age of 21 by pap smear, and HPV was not allowed until the age of 30. But after that, the FDA approved the HPV as a primary screening program, and many published guidelines were available now for the HPV to be used as a primary screening for cervical cancer. So what happened in the Athena study? It was a randomized controlled trial, a cohort of more than 46,000 women who had a gynecological examination, FINPrep were collected, HPV testing with genotyping, and colposcopy was performed for those with positive high-risk HPV and abnormal pap smear. And then they evaluate the performance of primary HPV screening in women above the age of 25. And the results showed that HPV testing was significantly more sensitive for detection of high-grade dysplasia than cytology alone. And they looked for the absolute risk of CIN with negative cytology, mainly in women above the age of 30. So low incidence of CIN2 or 3, which is a high-grade dysplasia, were discovered in patients with negative HPV, but patients with positive high-risk HPV, the numbers of detection of high-grade dysplasia rise, especially if they perform the genotyping HPV 16 and 18. And after that, there was a lot of randomized controlled trials. All of them emphasized the benefits of HPV testing as a primary screening for cervical cancer. What we can say about primary HPV screening, it is safe and effective as cytology. A negative high-risk HPV test, it provides good reassurance of low risk of having high-grade dysplasia than negative cytology alone, and can be considered as an alternative to cytology based for cervical cancer screening. And nowadays, several countries like Netherlands, Australia, USA, and United Kingdom are adopting this technique. In Australia, for example, by December 2017, they announced the end of pap smear. And they changed their national screening program for cervical cancer. So instead of starting the exam by the age of 18, it is now at the age of 25, and they extended from the age of 69 to the age of 74, and they are using the HPV testing, and it is repeated every 5 years instead of 2 or 3 years for the traditional pap smear. In USA, their protocol was starting with primary HPV screening, with genotyping any patient with positive HPV 16 and 18, they refer the patient immediately for colposcopy, while those patients with positive other high-risk types, they perform or they collect the pap smear, and if there's any abnormal pap smear or cytology, they send the patient for colposcopy. In England, again, they start with high-risk HPV testing, and they started it by the age of 25, and it ends by the age of 64. So again, they perform the high-risk HPV testing, and if it's positive, they do reflex cytology, and when they have abnormal cytology, colposcopy is indicated. So what are the issues with primary HPV screening? There is a high number of tests and number of women requiring workup and follow-up, with slightly reduced in the specificity of the screen, but still much better than cytology alone, though it will not pick up non-HPV cancers, or that besides the cost and the acceptance by the patients and by the health work providers as well. In 2020, new guidelines were published by the American Cancer Society about the recommendation for cervical cancer screening. And if we are going just to compare their old recommendation by 2012. So for the age, in 2012, they used to start the screening by the age of 21, and it is repeated every 3 years with cytology alone. And in 2020, no screening is required below the age of 25. For patients above the age of 25 up to the age of 65, the old recommendation was performing either cytology alone, and it is repeated every 3 years, or co-testing with cytology and HPV, and it is repeated every 5 years. Now, they use only the HPV test, and it is repeated every 5 years, though co-testing or cytology alone is still acceptable if the HPV testing is limited or if it is not available. After the age of 65, they just stop the screening, providing the patient are properly screened and documented of proper screening programs before were available. After hysterectomy, the old recommendation was to stop the screening if the patient has hysterectomy due to high-grade dysplasia, CIN2 and more, and up to 20 years from being diagnosed with high-grade dysplasia. And in 2020, this was extended for 25 years instead of 20 years from being diagnosed with high-grade dysplasia. HPV vaccinated women are still screened the same as unvaccinated women, and nothing changed regarding this category. Having said that, the HPV testing is only acceptable with 2 components. So what happened is that the FDA approved the HPV as a primary testing for only 2 components in USA, which is the COVAS and OnClarity. This is the only 2 components that is allowed to perform the direct HPV testing, while the other components, it is approved to be done as a co-testing with the pap smear, but not as a primary screening alone. The age to begin the pap smear, we said it is the age of 25, because in young women, there is a high prevalence or an incidence of HPV in young women, and there is a low rate for persistent and progression into high-grade dysplasia or cancer, while a high rate of regression of precancer abnormalities compared to old age group. And the studies using large clinical data show that the lowest detection of cervical cancer and the precancer changes happened in women below the age of 25. This is a new study, and they looked for the distribution of cervical cancer and cervical cancer deaths in women according to the age. Only 1% of women were diagnosed with cervical cancer below the age of 25, and less than 1% of those were diagnosed with or died from cervical cancer. When to stop cervical cancer screening? According to the American Cancer Society in 2020 recommendation, discontinuation for individuals with a cervix above the age of 65 with no history of CIN2 or higher lesion within the past 25 years with documented adequate negative screening in the past 10 years. And they put a definition for adequate negative prior screening as a 2 consecutive negative HPV testing or 2 consecutive negative co-testing or 3 negative cytology tests within the past 10 years, with the most recent test occurring within the recommended interval for the test used. Individuals above the age of 65 without condition-limiting life expectancy with available sufficient documentation of prior screening should be screened until cessation criteria, while cervical cancer screening may be discontinued in individuals of any age with limited life expectancy. The same study showed that it showed that 1 in 5 new cases of cervical cancer occurred in women above the age of 65, and 1 in 4 deaths of cervical cancer occurred in women above the age of 65 again. But the randomized trials and observational studies have demonstrated the effectiveness of cervical cancer screening up to the age of 65 only, and the evidence of effectiveness of screening beyond the age of 65 is limited and based only on observational and modeling studies. One last thing to mention is self-sampling. HPV self-sampling have been shown to be feasible and acceptable, and it is a viable approach to screening in patients with whom never screened before or under-screened population, and it had many advantages over in-office collecting the sample, as it is more convenient, privacy, less embarrassment and anxiety, easy of use, less discomfort and pain with lower cost. However, it has not been approved by the FDA until now. And thank you.
Thank you, Dr. Ihab, for a very informative lecture. And we'll leave the questions for the end of the session. Let's welcome, thank you very much, Dr. Ihab. Let's welcome Dr. Abir Annab, who will be giving us a lecture about cervical cancer disease burden and vaccine. As we all know, the pleasant Dr. Abir Annab, she is a senior consultant OBGYN in the private sector. She has established many initiatives at raising awareness of breast and cervical cancer, and she's involved in many academic and medical training programs. Dr. Abir, you are welcome to start your lecture.
سامعيني؟ Hello. Can you hear
Dr.
me?
Abir?
سامعيني? I just want to share my slides.
Okay. We'll be waiting, Dr. Abir. Take your time.
يمكن دكتورة حضرتك استعملتي اوكي
اذا بدك ارجعي اطلع من السكرين ادخلي، يمكن اخترتي السكرين الخطا يمكن.
انا اللي سهى اللي بعتي لي اياه انا.
لا صح احنا شايفين السكرين تبعتك، بس انه يمكن ما اخترتي المحاضره، لازم تفتحي المحاضره قبل. ستوب شيرينج السكرين وافتحي المحاضره وشير اجين.
اوكي ماي دير. واضحة هلا سهى؟
ممتاز.
اوكي تمام.
ليس سوري.
مساء الخير وجهود مشكورة للجميع، وعلى راسهم دكتورة سهى الغول. My talk will be about burden of the disease and vaccination. We know that cervical cancer is the 4th most common cancer occurring in women worldwide. And it is the second بس نقيم هدول لانهم مسكرين علي كلياتهم هدول البدايه. دقيقه بالله يا سهى لانه هدول فوق مسكرين علي هدول كلهم.
احنا دكتوره عبير السلايدز واضحين بالنسبه لنا.
بس لا بدي انا مغطين علي فوق كل الحكي.
اختاري ريفيو، غيري ريفيو دكتوره.
يا
من فوق على اليمين.
من فوق على اليمين. يس. Okay, تمام. And it's the second most frequent cancer in young women according to European statistics for females aged between 15 and 44 years of age. It's estimated that approximately 570,000 women were diagnosed with cervical cancer in 2018 worldwide, and out of these 311,000 died. يعني 50% is the mortality rate تقريبا من عندهم كلياتهم. Cervical cancer incidence and mortality estimated by region. It's shown everywhere, and it's more in South Africa with a high mortality rate of around 50%. We're lucky in Jordan. We have cervical cancer data according to the Middle East area. It's 2.4 times 100,000, comparing with the average of having a 9 per 100,000. It's worldwide recognized now that HPV is highly associated with CIN and cervical cancer. Cervical cancer is essentially caused by oncogenic HPV. Infections with oncogenic HPV types is the most significant risk factor in cervical cancer etiology. HPV is the main cause of cervical cancer. We're lucky to know that this cancer is caused by a virus, and there is a vaccine for it now. In the start of studying the disease, analysis of around 900 specimens from women in 22 countries indicated the prevalence of HPV DNA in cervical cancers as 99.7%. Tissue samples were analyzed using the HPV DNA. The HPV is non-enveloped double-stranded DNA virus with more than 100 types identified, out of which we have 15 to 20 oncogenic HPV 16 and 18, accounting for the majority of cervical cancer worldwide. And we have the type 6 and 11 HPV. They are responsible for the external anogenital warts. The HPV 16, as an example, this is the structure of the virus. It has many proteins the most significant out of which causing replication and control over the nucleus is the E6 and E7. These viruses selectively amplify their genome in the differentiating keratinocytes. Viral E6 and E7 proteins have the ability to abolish restraints on normal cell proliferation and retard normal terminal differentiation into neoplastic transformation. This is what happens when you have an HPV infection after sexual intercourse. If you were unlucky and you have risk factors to have the infection, out of the friction, there will be abrasion in the cervical mucosa, from which the virus goes down to the basal cell layer. And then we have the viral replication and assembly and shedding of the viruses to infect other nearby cells. The keratinocytes is the target cell for HPV. The squamated cornified cells are continuously shed from the stratum corneum and serves as a vehicle for transmission. Coilocytes is the morphological manifestation of a productive HPV infection. Each coilocytes contain around 50 to 100 HPV virions. This is the histology when you take a biopsy for CIN. This is the normal epithelium, and then this is CIN 1, 2, and 3. One in which the changes affect the lower 1/3 of the cervical layers, and if it's more than 50% affected layers of the cervix, it's CIN2, and if it's more than this, it's affecting the whole epithelium and the whole layers of the cervix, it is CIN3. We have over 100 different types of HPV recognized, 32 which are in the cervix. Cervical HPV are classified either to high oncogenic types, of which we know the 16, 18, the 31, and the 33. We have the low oncogenic types, the 6 and 11, and we have some still undetermined oncogenic types. Diseases that are caused by HPV: cervical cancer, cancer of the vulva, vagina, anus, and penis. We have the warts, and we have the vagina, and the juvenile, and the adult onset papilloma in the larynx, okay, beside the vocal cords. HPV, this is how it is worldwide distributed. Prevalence around 10 to 15% worldwide. 16 and 18 are the nasty ones out of these. And these are photos of the genital warts, and usually these are benign warts, and they are of the 6 and 11 type, and they are responsible for more than 90% of the cases of anogenital warts. The vaginal intraepithelial neoplasia, the main predisposing cause is HPV, and usually when you have the vein, you have to check for VIN and SIN. Usually it's associated with it. We are seeing now more cases in younger women diagnosed with vein, and true incidence is unknown, but it is lower than SIN. Incidence is expected to rise due to the wider use of cytological screening and colposcopy. We have also the vulvar intraepithelial neoplasia. Incidence of VIN is increasing also worldwide. Mean age of women with VIN is decreasing. Symptoms occur and may be present for a long time prior to diagnosis, which may take up to 1 year. HPV-16 appear to be the most dominant HPV type associated with high-grade VIN. Majority of VIN1 are associated with types 6 and 11, while 16 and 18 are more with VIN2 and VIN3. Laryngeal papillomas, HPV is well-established cause for it. We have the juvenile type, which is happens to babies born to teenager mothers, and we have the adult type associated with oral sex and multiple partners. And HPV has been associated with squamous cell carcinoma of head and neck and benign cancer as well. And this is the location for the papillomas, usually beside the vocal cords. Usually it could be recurrent surgeries for recurrence appearance of these papillomas. due to HPV infection. Big study was done in Hussein Cancer Center. Dr. Maher Sghayar was involved in it. 48 cases of cervical cancer with paraffin blocks were identified. DNA was extracted. We had 1 case of adenocarcinoma, 1 case of adenosquamous carcinoma, 46 squamous cell carcinoma. The median age group was 44 to 49 years. And the conclusion that HPV 16 and HPV type 16 and 18 are the most common types in cervical cancer in Jordan. Other types has been also found. And in private sector, we have detecting the genotype of human papilloma virus in Jordan. Over 200 pap smears were examined. 10 cases were diagnosed to have a higher grade lesion. 3 were 16. 3 others who had the 35 type. 2 had genotype 18. 1 genotype 39, and 1 had genotype 45. Now, the CDC recommendations after discovering the cause of cervical cancer to treat the HPV, the vaccination. So on June 29th, 2006, the CDC control had recommended routine vaccination for females of the age 11 to 12 years of age with 3 doses of a quadrivalent HPV vaccine. The vaccination series can be started as young as the age of 9 years of age. HPV vaccine is the first vaccine as anti-cancer immunization. In the vaccine, they used viral-like particles constituted of the major protein L1 of the capsid of the virus without any viral genetic material, and immunological but not infectious and non-transforming type of vaccine for the prevention of precancerous and cancerous cervical, vaginal, and vulval lesions was introduced. So we had the Gardasil. It has the 4 subtypes of the HPV, 6, 11, and 16, and 18. And it's manufactured with the yeast derivative vaccines given to millions of children and adults with aluminum adjuvant. And the dose is IM injection of 0.5 cc and 3 doses, 0, 2, and 6, like the HPV, like the hepatitis B vaccine. The vaccine has no effect on existing lesions or the course of the viral course of the viral infection carried by healthy individuals. يعني بأثرش عليه. Was the core objective of this vaccine was to reduce the cervical cancer, the CIN, the VIN, the vein, the genital warts. In a new news release, very new, April 2020, a meta-analysis of 6 mostly observational studies comparing excision of cervical intraepithelial neoplasia 2 or greater, and CIN 1, 2 or plus, and 2 or 3, with versus without adjuvant HPV vaccination in unvaccinated patients. قال لك النتيجة تبعتها vaccination was associated with a lower risk of recurrent CIN2, okay, and any CIN. So now we use this convincing people to get vaccinated. These findings further support our approach of discussing HPV vaccination as part of the management of CIN in unvaccinated patients. So we have the quadrivalent vaccine, the Gardasil, and now we have the 9-valent vaccine, targets 6, 11, and other types. This is the 9-valent, and I think shortly we will have it in Jordan. Maybe in 1 month we will have it in Jordan, the 9-valent type. And we had the Cervarix, which was the bivalent vaccine for other drug companies, 16 and 18. This is the Cervarix. Vaccination with 9-valent, quadrivalent, or bivalent vaccine provides a direct benefit to female and male recipients by safety protecting against cancers that can result from persistent high-grade HPV infection. Although the burden of HPV-associated disease is lower in males than females, and thus the direct absolute benefit to males is smaller, the indirect benefit to males from vaccinating females only is incomplete, and vaccinating males, يعني مهم جدا نحن to vaccinate the males as it is important to vaccinate the females. In accordance with the Advisory Committee on Immunization Practice in the USA, they recommend routine HPV vaccination for females, which is a grade 1A, and males grade 1B in the following age ranges. HPV vaccine should be administered at 11 to 12 years of age. It can be done as a younger age group, like 9 years old. Optimum time for HPV vaccination immunization is prior to an individual sexual activity. For individuals starting any HPV vaccine when they are younger than 15, 2 doses will be enough. Okay, we suggest administering 2 rather than 3 doses. In such patients, the 2 doses are administered 6 months apart. For individuals starting HPV vaccine at 15 years and older, it's 3 doses, 0, 1, and 6 months. And in immune-compromised patients, also we recommend a 3-dose series. For adolescents and adults aged 13 to 26 who have not been previously vaccinated or have not completed the series, يعني بتاخد دوز وبتنسى تكمل البقية, catch-up vaccination is recommended. Catch-up vaccination is not routinely recommended for older adults. They note that the decision to vaccinate adults older than 26 should be made on an individual basis. For previously unvaccinated adults من عمر 27 to 20 to 45 years of age who have a low likelihood of prior HPV exposure, يعني ما في كتير sexual experience or limited, but they have a future risk of HPV exposure, we suggest HPV screening. بس البروتكشن بده يكون أقل وبنزل لحد 50%. If cost and availability are not issues, we recommend the 9-valent HPV rather than the other HPV vaccine, and it covers عدد أكبر من الجينوتايبس. HPV vaccination during pregnancy is typically avoided because of the limited information about its safety. However, some of the ladies were pregnant when they took the vaccine and they didn't know, and there was no side effect on the newborn. Multicenter double-blind placebo-controlled trials have demonstrated the efficacy of quadrivalent, 9-valent, and bivalent HPV against incident and persistent cervical HPV infection due to vaccine types and the development of cervical intraepithelial neoplasia. And the same for the vaginal and vulvar neoplasia. They have also demonstrated efficacy against genital warts as well, with the types of 6 and 11. And there was a reduction in anal intraepithelial neoplasia in men with men's sex, anal HPV infection in females, and oral HPV infection in females also has been demonstrated. Data from both registration trials and both safety surveillance system demonstrated that the vaccine is safe and well tolerated apart from mild injection site reactions. Post-vaccination syncopal events have emerged as a potential serious adverse effect, although it does not appear unique to HPV. كل اللي بياخدوا vaccinations, they might have this syncope attacks. Patients should be aware that HPV immunization is not effective in clearing HPV infection. هي دايما بنتأكد عليها. Genital warts or anogenital intraepithelial neoplasia that's already there. HPV vaccination status does not impact cervical cancer screening recommendations. We have to go on with the screening. Cost-effectiveness studies varies in different countries. In UK and Australia, it is cost-effective. In Iran, it's not unless prices are reduced. More than 270 million doses are given worldwide. Both effectiveness and safety has been demonstrated. Primary, which is the HPV vaccination, and secondary prevention approaches, اللي هي screening, treating precancerous lesions, will prevent most cervical cancer cases. When diagnosed, cervical cancer is one of the most successfully treatable forms of cancer as long as it is detected early and managed effectively. And thank you very much.
Thank you very much, Dr. Abir. For a very informative. Now, allow me to present Dr. Maher Zghayer, and he's going to present a very interesting title, actually. So in the era of to vaccinate or not to vaccinate, Dr. Maher Zghayer is going to talk about not COVID vaccination. It's rather about cervical cancer vaccination, why we should not vaccinate. Dr. Maher Zghayer is a consultant pathologist, and he is the head and the chairman of the Department of Pathology and Laboratory Medicine at King Hussein Cancer Center, Amman, Jordan. And he was previously an associate professor at the pathology at Al-Quds University and chairman of pathology at Al-Maqasid Hospital in Jerusalem. Dr. Maher Zghayer, thank you for joining us late on Friday.
Thank you, Suha. Thank you, everybody, for inviting me to give this talk. Please give me feedback if whether my voice is clear to you all.
It's very clear, Dr. Maher. Thank you.
All right.
And you can start sharing your, yes, thank you.
Okay. So it's interesting to talk about vaccination these days while we are, talking about COVID vaccination. So vaccination for the coronavirus, nobody argues about it, I guess, in the medical field at least. But this one, we have a lot of argument about it. Now, the issue is to vaccinate or not. It's not whether to prevent cervical cancer or not. We have to prevent cervical cancer, but is it really worth it to give the vaccine or not? Now I'm moving my slides. Can you see? Because sometimes when I move them, they don't. You see my second slide?
Yes, we do. Thank you.
Okay. So this is a commercial from the CDC concerning the vaccination and how good it is. It prevents cancer. Okay, so I will be, I'll go very fast over the basic facts that everybody has touched upon so far. So one of the leading causes of cancer death, that's cervical cancer. The previous speakers have highlighted this. This is true, but it's not for us. This is true for the low and middle income countries that I will show you which countries, but it's not one of the leading causes of cancer death in the Mediterranean or in the Arab and Muslim countries, I mean in the Middle East. It's preventable, yes. It's caused by high-risk HPV, and HPV is the most common sexually transmitted disease. Okay, HPV infection, most HPV infections resolve by themselves, actually more than 90%. They rarely persist, and they take 10 to 30 years to develop invasive carcinoma if they persist. This very long natural history is an opportunity for prevention of because you can intervene during these 10 to 30 years by screening, of course. So the incidence and mortality, the same figures that Abir showed a minute ago. Hello? Somebody's talking. Anything going wrong?
No, we can hear you clearly.
All right. So as Abir mentioned in the previous talk, the incidence in 2018 was 570,000 cases of cervical cancer. And out of those, 311,000 deaths worldwide. And 85% of those, the low and middle income countries, but not us. So see here in the world map, the darker color indicates the very high incidence. It's South America, Sub-Saharan Africa, Southeast Asia, but not West Asia, which is here, the very light colors, exactly similar to the US, or even lighter, meaning less incidence. Again, the same thing applies for the mortality. Most of the mortality that we're talking about is in Africa, South America, Southeast Asia, but not us. The lighter color, except here, maybe Morocco, has a little dark color, but not very dark, though. And again, we are in Western Asia, and we are at the lower bottom of the incidence and mortality of cervical cancer. So it's not a priority. And here again, the worldwide cancer deaths in females of all ages. Breast is number 1, lung, colorectal, and cervix comes 4th, considering all those countries, sub-Saharan Africans and other countries that I talked about, not our countries. So it's not the number 1 or 2. Anyway, and here again, the EMRO region, which is our region, compared to the world. So it's cervical cancer here is number 4 again. But for us, there are here five more than cervical cancer in terms of mortality and incidence. Anyway, so we can actually skip some of these because it's just a repetition. So the high mortality in the poor countries is because of late detection and the absence of screening, not because of the absence of HPV infection. It's present all over the world and even in those countries with low incidence. So this is the slide showing Jordan here at 1.5 per 100,000 cases. And most of the countries in the region, they have low incidence, similar to the USA, which is actually achieving a good screening, excellent screening programs that reduce the mortality, as we're going to show. Algeria a little bit more than the rest, and Morocco is not shown here, also the same. So this is the Jordan number of cases in 2016, and you can see the cervix at 39 cases compared to 300 times more of breast cancer, which is 1,200 cases at that year. Again, the 10 most common cancers among Jordanian, both genders, you can see that cervical cancer is not among those. And in females, it's not even among those again. You see the corpus uteri, which is the endometrial carcinoma, is here, but it's not. So it's not a priority. Again, this is the mortality due to cancer types in both genders, and carcinoma of the cervix is not here. Maybe it's with the others because it's very, very, very low. This is more or less the same talk, number of cases, in Jordan, around 40, 50 cases every year. So as we say, cervical cancer is the most common cancer among women in 45 countries of the world. What countries I talked about in sub-Saharan Africa and South America. And the same thing for the mortality. Okay, so these are the countries here, South America, etc. The cause, everybody now knows, it's HPV, more than 100 types. Okay, we don't have, everybody talked about this. And this is the paper that was mentioned by Abir previously, showing the genotypes in Jordan. So 75% of our cancer, cervical cancer in Jordan, were caused by HPV 16 and 18, according to this study that we published. So most women infected with high-risk HPV do not develop cancer. As I said, 90% will resolve by itself spontaneously in less than 2 years. And a small percentage of those will develop persistent infection. And out of those, a very smaller percent will develop invasive cancer. So here is the virus infecting the basal cells and replicative infection producing viruses. Integration after 10 to 30 years will produce precancerous and cancerous lesions. And this is the number of HPV infections with age, it goes down. The number of precancerous lesions, and with age it goes down. And this is the number of actual cancers, very low compared to those. Again, the cleared infection here in pink, the persistent infection, and the actual invasive cancer. So it's 0.2 or I think 0.8% of all infections will lead to cancer. And even though they cause the large number of cancers in the world, in the low and middle income countries. And this is the squamocolumnar junction where carcinoma of the cervix start. And this also, this is the normal, this is the mild dysplasia, moderate dysplasia, and the invasive cancer in terms of changes in histology. This is also the cytology of cervical cancer and pre-malignant lesions and colocytes. And this is, CIN1. This is high grade, or CIN2 to 3. Colposcopic lesions, and this is the carcinoma of the cervix. And this more or less the same. So as I said, let's see, okay. So these are the cofactors previously mentioned in previous talk: tobacco smoking, oral contraceptives, immune status, the HPV type. So we need to prevent carcinoma of the cervix, there is a good opportunity to prevent it because of the big latent period. So the role of Pap test, that actually was one of the most successful prevention strategies in the world to prevent cancer, was the Pap test, or the screening for cervical cancer using the Papa Nicolau test. And this is from the US, showing without vaccination, with Pap test only, starting 1975, the number of new cases have significantly dropped, and the number of deaths from cancer of the cervix have significantly dropped just using the screening, the Pap smears. And this is not only for the US, this is all over the world. You can see the incidences and mortalities going down. Even in Colombia here, they started with very high rate, still high rate compared to those countries, but they achieved drop in the number of cases by just screening using the Pap test. And so what the WHO recommends vaccination, but we'll talk about it in a minute, starting at 9 to 13 age, and then secondary prevention, which is screening using the Pap smear or the HPV test. Okay, however, what the WHO says, you have to assess the affordability, the cost effectiveness, and sustainability of introducing HPV vaccine. And they recommend also the screen and treat approach in many countries as an economical and cost-effective way, and a good referral system. And this is another advertisement from the CDC showing how good it is. Now, what about us? Do we need to implement prevention using what? Vaccination or screening? So back to the WHO, what they say should consider introducing HPV vaccination when cervical cancer or other HPV-related diseases or both constitute a public health priority. So is it a public health priority being number 20 in cancer death in Jordan, for example, or in any other Arab country? Of course not. Then vaccine introduction is feasible. Is it feasible? Well, I don't know if it is feasible in many Arab countries where they can't really find other more important, like vaccinating against hepatitis A, for example, or other, pneumococcus pneumonia, which are more common, or Haemophilus influenza. Okay, is it sustainable? It has to be sustainable financially. Okay, you have to have the resources. And is it cost effective to vaccinate versus just do a simple Pap test, which costs, less than 3 Jordanian dinars? Okay, so, and if it is introduced, the vaccination, it should not undermine or divert funding from the development or maintenance of effective screening programs for cervical cancer. So back to this number, this is the mortality. We don't see cervical cancer in here, so it's not a priority, right? So we have an unpublished study from Jordan about the cost effectiveness of the vaccination. So the cost of the vaccination implementation is going to be several hundred times more than that of treating the 50 or even 100 cases that occur every year in Jordan. So it's not cost effective. And this is a published study from Lebanon that was published in 2019, showing that the cost benefit analysis using limited available data indicates that massive HPV vaccination would not be cost beneficial. And I understand Lebanon has more cervical cancers than we do. Now, also in the region, unfortunately, there is a big commercial influence from pharma companies, and this is from, I believe, probably Tunisia, false. This is their website, false information. HPV, they say cervical cancer caused by HPV here is a leading cause of death in women within the Middle East. And I have shown you, and North Africa, and I have shown you this is false. This is not right. And again, they have this map with the red color. Relatively speaking, they're trying to imitate the red color of the world map, but this is also a very low number. The entire region, according to their website, has 14,000 cases in a year, including not only Arab countries, including Turkey and Iran in this group. So the number, this is very low number, 4,000 cases. And even in their website on another page, it's 11 1,000 cases. So these are very low numbers. And they, in Jordan, they have 104, that's fine. Kuwait, 59 cases, I mean, per year. So those probably 11,000 coming, 3,000 from Morocco, okay. And maybe 15,000, I mean, yeah, 1,500 or 16,000, 1,600 from Algeria. And this is also has been shown before, showing that it will double by the year 2035. Fine, but that's still low. Again, the second largest cancer killer of women in the region. Oh, come on, this is false. They just driven by commercial companies to actually market the vaccine. And call to action, all this, anyway, I don't have to go. Again, this is Jordan Cancer Registry for, I don't know what year, this is 2013. There is no cervical cancer among the 10 most common, and you will never find it. So it's better to do the screening, and this is the screening recommendation, has been shown before. And this is fine, this is the, you do, I guess now it's co-test or high-risk HPV only. So I guess if you do high-risk HPV only every 5 years would be actually the latest guidelines. So the best for us for the region is to stick with the screening, whether by pap smears or by high-risk HPV testing, rather than waste all this money on vaccines. And we probably should waste it on, screening and other priorities in terms of cancer, like breast cancer, for example. And this has been shown before. This is what you do when you screen with high-risk HPV. Basically, it's just a repetition of previous slides. And that's all for my talk. Thank you.
Thank you very much, Dr. Maher. It's such a good way of saying against the vaccine. Allow me to present Dr. Mazen Freij for the Mazen Bishtawi, sorry, for the last lecture. And one of the benefits of online lectures is actually to be rejoined with all the friends and colleagues. Dr. Mazen Al-Bishtawi will be talking about management of cervical cancer. Dr. Mazen is a consultant subspecialist in gynae oncology, and he's the director of obstetrics and gynae department at Al Ahli Hospital. He is a fellow of the Royal College of Obstetricians and Gynecologists UK, and a fellow of the American College of Obstetrics and Gynecology at of the American College of Obstetrics and Gynecology, and he is currently the director of and the chairman of the OBGYN department at Al Ahli Hospital. What a great pleasure to have you with us, Mazen. Welcome.
Hello, everybody. Can you hear me and can you see me?
Yes, it's very clear, Dr. Mazen. You are very clear and your voice is very clear as well.
Okay, just a sec. Can you see the slides now?
Yes, Mazen. Just go, I think, to the presentation mode from the PowerPoint.
I am in the presentation mode.
Okay.
Is it in the presentation?
It's not actually to me. I don't know. Suha.
Did you open it from فتحت من PDF?
No, I opened it from the presentation itself, from the.
Okay. Maybe okay.
Let me open it from my screen.
Yeah, that will be easier.
1 second. Okay.
We're waiting for you, Mazen. It's okay. Take your time.
All right. So I'll just open my presentation. Can you see the presentation now or not?
No, Mazen, it's not apparent.
Okay, let me do it again.
Mazen, go down to the screen of the PowerPoint and do the slide.
I have shared the screen from the lower part.
You have a Mac.
Yes. And
Okay, now it's good.
it's good. You can see me. Okay.
Yes.
Just 1 second, because I can't see my screen. I just want to get rid of this share computer sound. How about now? Is it okay?
Yes, I guess.
Yes, Matt.
Okay. Thank you very much for inviting me for this prestigious meeting. Really grateful for the invitation and the huge effort by the organizing committee and Dr. Soha. The presentations on cervical cancer were really great. I felt like I need to change my presentation into answering and replying for Dr. Maher, but I think I'll do that along my talk as we go. It's always good to have two different opinions, and maybe we can reach an agreement in the end. So the outline of my talk, I'll talk about cervical cancer in global perspective. I'll talk about the updated cervical staging system. I'll talk about the surgical management in particular, and I will touch a little bit on the other management. We all know now about the cervical cancer burden in the world. And, you know, when we look at the statistics of Jordan, I do get sometimes different numbers from different websites. This is the Globocan 2020, where the 5-year prevalence of cases, 115 new cases with a death of 71. So this is really a lethal disease in Jordan. I believe the cervical cancer in Jordan are fragmented, where it's distributed between the King Hussein Cancer Center, universities, the army forces, and the Al-Bashir Ministry of Public Health. So I think that maybe participate in dilution of cases and dilution of experience. This is really one of my favorite slides. It tells you that cervical cancer is a behavioral thing. It's related to risk factors. It's not genetics. It's related of what we do in our life. The incidence of cervical cancer now in Jordan, it reflects our behavior 30 years ago. We all know that once you have an HPV infection, to change from an HPV infection into cancer, it takes between 10 to 30 years, which has been said by my previous colleagues. So if I want to do a screening, the question is, do we need to screen for cancer or do we screen for pre-malignant cells? So the right question is, do we need a program based on the current abnormal pre-malignant cells? We don't know the answer. All what we know at the moment is that the current incidence of cervical cancer. But the right question to be asked is, what is the prevalence of HPV in the population? What is the prevalence of the abnormal pap smears in the population? The current cervical cancer incidence, it relates to our behavior in the 90s. Now we have the millennial and we have the Generation Z. The behavior now is going to be reflected into cervical cancer in 20 to 30 years' time. So do we wait until we get an influx of cervical cancer in the future and then start to implementing a program? Or do we need to know at least what is the prevalence of abnormal precancerous cells in the population, and that warrants intervention or not? It starts from education to society. If you look at the coronavirus, we see people dying in front of ourselves, and we have the vaccine, and you try to convince the population, please go ahead and take a vaccine, and they will still think about the conspiracy theory. We're struggling to convince them for a disease that's killing thousands of people and millions of people worldwide. So I think we need to start working about education. Working about education, just give me a minute. Working about educating people. This is a cancer that is 100% preventable. This is a cancer that is going to kill in the future thousands of women. So I think until this question is answered, it would be very difficult to know what's going on. So I want to talk about the therapeutic approach for cervical cancer. I'll talk about early cervical cancer. We'll talk about locally advanced cervical cancer. We'll talk about cervical cancer with distant mets and recurrent. Just excuse me a minute. Sorry about that. Just my little daughter was trying to share the presentation with me, so I was getting distracted. So we all know that the cervical cancer treatment late in the 19th century with Watan, and the description of Watan was an operation where you need to go and remove the parametria. For early disease and for a advanced disease, we go for chemoradiotherapy. No matter what we do, really, we wanted to give the patient a one modality. So either we triage patient into surgery alone or radiotherapy alone. The last thing you wanted to is do surgery and then you have closed margins or you have lymph node metastasis and then you send them for chemoradiotherapy. Our understanding of radical hysterectomy has evolved with a new classification. We look at the parametria as a 3D view, where we look at the anterior parametria, posterior parametria, lateral parametria, and we wanted to tailor the surgery into the disease itself. We all know now chemoradiotherapy is the standard treatment for advanced cervical cancer. All the studies has confirmed on and on. However, if we are treating younger women with radiotherapy, one of the studies highlighted for endometrial cancer that the future development of a secondary malignancy may compromise the survival. So we don't want to send someone which we can clear by surgery into radiotherapy. And that's why cervical cancer really should be treated in a multidisciplinary team in a cancer center. And that's, I think, my voice today is we're trying to centralize the services. At least if there is a one multidisciplinary meeting, at least once a month between the fragmented services to discuss at least cases that need surgery. It's an excellent idea to have everyone on board to think about what to do with this case. Shall we go ahead with surgery or shall we do? And what type of surgery shall we offer our patients? This is an interesting slide. If you look at the 5-year survival across all malignancies in the United States between the 70s and 2007, 2013, all the cancers are moving forward. There's an improved survival. Look at breast cancer is around 90%. When you look at the cervical cancer, the survival is going backward. So there must be, we are doing something wrong. The survival now is much worse compared to the survival 40 years ago. And there are multiple factors. And I will go through them later. This is the old surgical staging for cervical cancer, which I feel there were lots of things that many consultants and many gynecologists, oncologists were unhappy of. We know that cervical cancer is prevalent mainly in the low-income countries and developing countries. So we wanted to keep the staging as simple as easy with no need for MRIs, ultrasound scans, and imaging. So you examine the patient and you say, oh, this is stage 1A or 1B or 1C. Sorry, stage 2 or stage 3. But that led to a different diseases within a one stage. So the new staging in 2019 tried to overcome this issue. One of the main important issues that involvement of lymph node was not in the previous staging, although we know that involvement of lymph node is the most important prognostic factor and survival factor for the cervical cancer. So there are a few changes within the stagings. I'll go quickly upon them. The new staging allowed us to use imaging. So if you do an imaging with a PET scan or an MRI scan or ultrasound scan, you see there is a large lymph node looks suspicious, you can say that this is stage 3C1 and you write R by radiology. Or if you remove the lymph nodes and you prove it by pathology, then it will be 3C1P. So at least we know whether this is done by pathology or done by imaging. So with stage 1A now, the lateral spread is no longer important. We just go into the depth of invasion, whereas in the old stage, we used to say it should be less than 7 millimeter lateral spread. Again, in the 1B now, we have, instead of 1B1, 1B2, we have 1B1, 1B2, 1B3, where 1B2 was divided into between 2 and 4 and then more than 4 centimeter. This probably would create a confusion. If a patient comes to me where she was staged before as stage 1B2, it's not exactly the 1B2 we're doing now at the moment. So I think it's very important to note that 1B2 according to 2019 staging rather than the old type of staging. And with the 2A, again, we have the less than 4 centimeter, more than 4 centimeters. The major changes were involving lymph nodes, where 3C1 would be for pelvic lymph nodes and 3C2 would be for para-aortic lymph node. In the previous staging, involvement of lymph node was only for prognosis and not an essential part of the staging, and no changes for stage 4. So let's look at treatment of an early disease, and that causes lots of confusion, different practices between different centers. Stage 1A, whether 1A1 or 1A2, it's a microscopic disease. You go and you do a cone. If the margins are negative, most centers would agree, just follow up. If it's a 1A2, if the margins are positive, you might need to recone. So if the final disease is a 1A1 and no LVSI, most people agree that we will do just a clinical follow-up. But for 1A1 and positive LVSI, many suggest to do some sort of lymph node assessment, either sentinel lymph node or lymphadenectomy. But because the tumor is small, I think sentinel lymph node will be the way forward. For a 1A2 with LVSI negative, many centers would advise simple hysterectomy plus minus lymph nodes. But if the LVSI is positive, we need to go for simple hysterectomy and sentinel lymph node. In the old days, 1A2 was treated by a complete radical hysterectomy. So that's a good change into the practice. So what about sentinel lymph node? We've been talking about sentinel lymph node in breast for a long, long time. We're still talking about it in endometrial cancer and in cervical cancer. We started doing it by radioimmunoassay with technetium or the patent blue. But the most commonly method used now is the indocyanine green. It's really great. You're doing laparoscopy, you inject the indocyanine green, and then you can switch between a normal mode and the indocyanine green mode, and you can see the lymphatic channels clearly. You can see the lymph nodes, the sentinel lymph nodes, and you can remove them, and you can switch between the two views. It's really amazing. And I think most centers now, they're going for the ICG indocyanine green rather than the conventional one. Lots of studies confirming the safety, the sensitivity, and the specificity of the sentinel lymph nodes, but it's site-specific. So if you don't find it on one side, you still need to proceed with a full lymphadenectomy. So instead of the old pathways where we think the tumor is early, we do radical hysterectomy, which includes lymphadenectomy, and if the lymph nodes are involved, we send them for chemoradiotherapy, having the dual modality. There is an approach in many centers to do first the sentinel lymph node. And if the lymph nodes are involved, you go for primary radiotherapy. If they are not involved, then you proceed with radical surgery. The problem with this is some centers, they go for frozen section, and frozen section has its own problem. It's not really 100% accurate, no matter how the center is good. Some of them, they do a 2-stage surgery. Some of them, they do frozen section, the 1st-stage surgery. It depends upon how each center have their own guidelines. Again, sentinel lymph node is used now as an essential part of fertility sparing surgery, where before trachelectomy or conization, we do the sentinel lymph nodes. If they are negative, then we go for fertility sparing. But if sentinel are involved, you go by centric, which is chemoradiotherapy. The problem with the sentinel lymph nodes is you are going to identify more and more tumors. You will have the big ones, the macrometastases, and you will get the micrometastases as well, which probably otherwise, if you have done standard lymphadenectomy, would not be picked up. And of course, we identify the isolated tumor cells, and many has agreed that isolated tumor cells does not carry any prognostic significance. The survival for those women with isolated tumor cells is exactly like the one who did not have a negative lymph node. But for macrometastasis, the survival will drop sharply. So lymph node status is probably the most important thing in management of cervical cancer. And as we can see, macrometastases behave exactly like macrometastases, unlike what we see in breast cancer. So sentinel lymph nodes, we know that we have a low rate of false negativity. We know that there is a low volume disease detected in sentinel lymph node by ultra staging in 10 to 15% of cases. We know there's a comparable prognostic significance for micromets and macromets, and the risk of micrometastasis in standard lymphadenectomy is really unknown. So when we want to go for an operate on cervical cancer. So we know it's operable, we need to go for surgery. Classically, we have been using our knife for a long time. Recently, we have laparoscopy and robotics. And as part of assessment, we really wanted to know whether minimal access surgery has any influence on the surgery. The first study, which came into shock, the LAC trial, they looked into randomized patients for open surgery and for minimal invasive surgery. Both arms were comparable in terms of tumor size, lymph, vascular space invasions, parametry, and vaginal margins. And when we look at the survival, it was really shocking. The survival after endoscopy, whether laparoscopic or robotic, was much inferior compared to an abdominal approach. And what's interesting is that the recurrence rate usually after 1.5 years after open surgery is static, whereas for laparoscopic, it keeps going and on and on and on. Another retrospective analysis from SEER data, they looked again into the laparoscopy versus laparotomy, and it did really confirm that laparotomy has a much higher survival compared to minimal invasive surgery. A plethora of studies at the moment really confirming that open surgery is the standard, and many centers have already changed their guidelines. Many centers in the United States now, they had converted completely into an open surgery rather than laparoscopic surgery. If you want to look at the quality of life, and people thought, well, let's leave it to patient, let's see whether laparoscopy has really a better quality of life that can offset the survival. But if you look at the total score between endoscopic and open, it's exactly the same. If you look at the physical well-being and the functional well-being between open and endoscopic, it's the same. The only difference is the mobility score before 1 month, but after 1 month, the mobility score did not make any difference. We tried to explain. So some people said, oh, because we're using manipulator, we're disturbing the tumor cell. Some people are incriminating the CO2 because the CO2 will be circulating, carrying the cancerous cells from the exposed tumor and spread it in the peritoneal cavity. Some doctors suggesting that we cannot do a full radical surgery with endoscopy, which I don't think the case. I think in laparoscopy, where we can do exactly the same radicality. And some were suggesting that it could be tumor spill from the vagina, because in open surgery, we close the vault and then we resect the tumor, whereas in laparoscopy, we open the vault laparoscopically. And some of them committing lymph node tissue manipulation. But we cannot for sure know exactly what did happen. But what we know for sure, if you're going to do a new randomized control trial, it's going to be very difficult to recruit patients after what we know. These are some of the recurrent cases after laparoscopy. You can see in the first one, laparoscopy at the port site. You can see this is in the liver or local recurrence in the pelvis. And the recurrence was much higher in the endoscopic arm compared to the open arm. If you look at the open radical hysterectomy, the surgery alone group, the survival is more than 95%. So how can you improve on such a great result? Lots of studies looking at the open surgery, most of them are above 93%. So open radical hysterectomy, probably I can say with confidence is the gold standard, considering the high survival rate. So if you're going to counsel patients now, what do we need to tell them? We have to be honest and tell them there will be no difference in quality of life at 1 month and beyond. There's no difference in intraoperative complications, no difference in short or long-term morbidities. But we need to tell them that 4 times more likely to recur with minimal invasive surgery or radical hysterectomy, and 6 times more likely to die after minimal invasive surgery, and we can leave it to the patient. So the statement is open surgery definitely offers a better oncological outcome, and that's the second setback to laparoscopy after the myomectomy. Many people now stop doing laparoscopic myomectomy, and now many people are stopping doing laparoscopic radical hysterectomy. What about fertility sparing surgery in early cervical cancer? In this part of the world, people like to preserve their fertility as much as possible. Many women whom I have treated in the past, they were preferring to die rather than to lose their uterus. The idea of fertility sparing was introduced in the 90s by Daniel Derja, where we remove a radical removal of the cervix and the parametria, and leave the top part of the uterus. It's not an easy surgery, especially it needs a lot of skills from the vaginal side. And that led to many people to think about doing the radical trachelectomy abdominal. So we do exactly what we do, radical hysterectomy abdominally with the preservation of ovarian vessels for blood supply of the uterus. This is how the specimen will look like on the left for radical hysterectomy and on the right for the vaginal trachelectomy, where you leave part of it. Recently, many people were questioning, why do you need to remove the whole cervix plus the parametria? Why don't you go and do simple trachelectomy? And some people were even suggesting aconization. To put things in perspective, if you're removing part of the cervix without removing any vagina, that's a cone. If you remove the cervix with some part of the vagina, that's a trachelectomy. If you remove the parametria with the cervix, that's a radical trachelectomy, whether it's abdominal or vaginal. But we cannot compare which is better, radical trachelectomy or simple conization. It all depends on the tumor itself. It depends on the shape of the tumor. It depends upon how much it's invading into the stroma. If you look at the images, the tumor in the red, if you're doing a cone, definitely you're going to get it all out with negative margins. Whereas the tumor in green, if you want to go through it with a cone, it won't happen. You have to go and do simple trachelectomy before getting it. And now people are overemphasizing about the importance of the ultrasound scan and the MRI scan. MRI scan is an amazing tool. An ultrasound scan in good hands, it offers a really good diagnostic criteria. Many centers I know for sure, they have not done MRI for a long time for cervical cancer, but it needs a lot of training and it needs a lot of expertise. So what do we do? The algorithm, first thing you have to check lymph node status. If they're negative, then we look at the shape of the tumor and decide whether we need to do a cone or trachelectomy, or we need to remove the parametria and do parametrectomy. The vaginal trachelectomy, whether vaginal or abdominal, it's a well-known method. We know the live birth is there between both. We know you can be more radical in the abdominal compared to the radical vaginal. Hence, the live birth is better with the vaginal, but still it depends on the expertise of the surgeon. In the start of the procedure, we used to do it for tumors more than 2 centimeters, but the recurrence rate was very high. So now we only do it for lesions less than 2 centimeters. This is how we do it through the abdominal approach. We do exactly the same as we do radical hysterectomy with the preservation of the ovarian blood vessels. The live birth worldwide has been acceptable. So the criteria should be strong fertility desire, age should be less than 40. It has to be an early stage, small tumor, limited in the cervical involvement, and no evidence of lymph node metastasis. And you have to exclude unfavorable histology. So to conclude my talk, really MRI or expert ultrasound should be used in clinical staging before we're doing fertility sparing surgery. Squamous or the usual type adenocarcinoma less than 2 centimeters are candidates for fertility sparing surgery. Lymph node staging should be the first step of surgery, and sentinel lymph node biopsy should be performed and sent for frozen section, proceed by ultrastaging, or you can do it as a two-stage surgery. If the lymph nodes are positive, it should be abandoned. And I'm very sorry to say that open surgery should be the preferred modality for the parametrectomy and not the endoscopic surgery. And thank you.
Thank you very much, Dr. Mazen, for a very nice lecture. As all the lectures in this session, maybe because it's my field of interest, they were really amazing. I will allow the time for some, if you allow us some time for discussions, and I can see in the for everyone, I can see some chats going on, and there was a question by Dr. Mahmoud Sarhan for everyone. He said, are there any current recent human papilloma antibody studies in Jordan or in the area looking into the current prevalence or seropositivity of human papilloma virus? Dr. Mazen,
I am not aware of any study, a population-based study done on the prevalence of HPV. We're still denying the fact that we do not need a cervical screening program. I think that is the first step. Dr. Mahmoud Sarhan, thank you very much for the question. First thing, we'll have to get a small budget for a population-based study about the prevalence of HPV in Jordan, and then we can decide whether we need it or not. But I am not aware. All the studies about HPV, we are doing it on women with an existing cervical abnormality. So if they have a pap smear abnormal, then we go and do HPV testing, but not as a primary tool on a subset of the population.
I think yeah ليه محمود كيف الحال thank you for staying this late يا أخي أهلين. I don't think there are any studies looking at HPV antibodies in the region. No, I don't think. I think the studies were done on vaccinated people, you know, in Europe, and you know,
would you consider one in Jordan to spearhead the discussion? Because if the prevalence is high and the virus is being transmitted, then you might argue that, you know, the number of cases that we see now reflective of, let's say, 30 years ago, and now with time the cases are going to be increased, and therefore you might justify vaccination, prediction of the cases, and then maybe vaccination, rather than just keep it for until it is progressed and become really a major problem. Just a thought, if somebody can have a small budget for that.
Yeah, it's worth doing, but I can guarantee you it's going to be very, very low, because if we have the antibodies in the population, that means there is a very high prevalence, and then we're going to see more cervical cancer cases.
Can you do it in blood donors? You know, those who come for donation, female, if there are any females who come for donation.
Yeah, it's worth
whatever samples that we collect for other reasons, we can do an RB on it, and maybe just a very low cost screening, let's say a random 100 or 200 samples.
Sure, it can be done, yes.
And Dr. Maher, I just took a screen picture of one of your slides, which is, I think, against not vaccinating women. You said low detection in Jordan, and actually very poor screening program, and that's the problem. I think, as Dr. Mahmoud Sarhan was saying, I really believe we should start with at least a very rigid screening program. After all these years, I remember the pap smear started maybe in 1970s, and we still don't have a rigid program of screening. Maybe we should fight for this now, especially with the presentation of a human papilloma virus.
Well, I agree with you 100%. If we are going to prevent cervical cancer, which we should, but in my opinion, not through the vaccination, it's through the screening. Screening is very simple, and you know, most women coming to get contraception, they can get vaginal exam, or they should, and then they should get a pap smear done. I mean, those جمعيات حماية الأسرة وتنظيم الأسرة والعيادات, they can do that easily. So yeah, we have to encourage the screening, the pap smears.
Yes, and Dr. Ihab Rayan, if you allow me, you are with us, Dr. Ihab?
Yes.
As some of the discussions on the chat, there was some debate about the cost effectiveness of a human papillomavirus, and from the knowledge and some of your presentation today, the human papillomavirus screening cost around 140 and pap smear cost around 20-25 JDs. What's your thoughts on that? And do you think that's cost effective to do human papillomavirus? Where is it available? The ease of doing the test and the ease of convincing women to do that test.
Yes, thank you, Dr. Mesa. Yes, I know that doing the screening with the pap smear is less costly, but it's though less effective and sensitive than the HPV. Actually, I don't mind which type of screening we should perform, but at least we need to do something. We need to do the screening, but we are neither doing the pap smear nor the HPV testing. We need a proper national screening program for the whole Jordanian woman. I think if we start with pap smear, but it needs to be proper for everyone, and then we can just go to the next step by doing the HPV. The problem with the HPV testing is that we need to look for the companies that providing the HPV testing, because it's not all of them are approved by the FDA. So it is important to look for the lab and which type of test is used, and if it is FDA approved or not. And if you allow me, I just need to add a comment for Dr. Maher. If you allow me, Dr. Maher.
تفضل. Go ahead.
Regarding the vaccination, just want to say something. The vaccination for the HPV, it doesn't prevent only cervical cancer. I know that the number of cervical cancer are low now, but the vaccine is important for another 6 types of HPV related cancers. That's the cervical, vaginal, vulva, anal, penile, and oropharyngeal cancer. All that cancers beside the genital warts. So the vaccination is not only for cervical cancer, it's for another 6 types plus warts. And we don't have a proper screening program in Jordan, so we are doing nothing. And I know we are oncologists here in Jordan, and we are facing more cases of vulva cancer caused mainly by HPV than cervical cancer. I'm seeing more vulva cancer cases than cervical cancer these days. I think it is important. I think though each life in Jordan is important, and the most important thing in cervical cancer, those patients are diagnosed at a late stage. So we are in cervical cancer cases very late that we can't treat, we can't perform surgery, and most of them, they die from cervical cancer, unfortunately. And even surgery, I think maybe less than 20 or 25% of the cases fitting the criteria for surgery treatment. And most of the cases they just underwent chemoradiotherapy.
Okay, I agree with you. Okay, it's true.
One final thought.
أولاً, they present late, that's true. But this is all types of cancer in Jordan they present late, not only cervical cancer. That's one. Second, do we want to prevent cervical cancer? Of course, yes. Which way is the most cost effective? This is not my saying, this is the world saying, this is the WHO saying. You have to look at your priorities. You have to do the right thing. Don't I want to vaccinate all women in Jordan وبعدين screening for breast cancer, which kills more women than cervical cancer. And by the way, زي ما سمعنا اليوم بعرف إذا حضرتوا other talks, now it used to be lung cancer, the #1 killer in the world from cancer. Now it's breast cancer. So
excuse me, بس ماهر, بس if we have a vaccine for breast cancer, definitely everybody will be having the vaccine. If you have any vaccine for any cancer, I am with the idea of vaccinating all the women at the age of 11 years. Now things with time will get cheaper.
I agree with you. If it gets cheaper,
with time things will get cheaper. It will not be.
Dr. Abir, Dr. Abir, can you tell us about the cost of the vaccine, if you are aware of them?
Yeah, الفاكسين 130 JD هلا راح ينزل ال 9 فالنت هلا عندنا. It will be the same of the old one. The old one اللي كان عندنا quadrivalent كان حقه 130 دينار. هلا اللي راح ينزل ال 9 فالنت it will be the same cost 130 JD 3 doses. بس هلا في عندنا
somebody have muted you, Abir.
I think the host has, I think, Dr. Suha, because there was echoes. I think Suha muted everyone.
Because it's not my side. I think it's from Mahmoud Sarhan side. It's not my side.
لا والله كأنه زالت على الجميع فسكرت الخط.
Suha كان في echo. Anyway, Dr. Maher, Mazen wants to have another final thought. Just one comment, Mazen, just to clear the idea. I think, Dr. Maher, we all agree that we should vaccinate. It might not be a national priority. I mean, the country should not at this time be, that's my thoughts actually, and I'll let you, Mazen, talk about it. Like, it should not be our priority as a country to vaccinate at the cost of the government, but it should be given to everyone the option to vaccinate and to have the vaccine if they want to and if they are educated about it. Mazen, it's your final thought.
My final thought is we need to have a dynamic mentality. Today, during my comment with Dr. Mahmoud, he said we did a study 10 years ago and we found that it's not cost effective. Now the programs around the world has changed completely. The pap smears are thrown out in the garbage. Most of them are moving for the PCR technology. I think the coronavirus made the wind in our favor. I think now the PCR technology is available wherever you go. Many countries I know for sure, one of them is Turkey, did not go for the Cobus, did not go for the Aptima, they went for a local PCR machine. I am aware that you can do a quick test, which has been studied extensively by the WHO, a $1 HPV testing, only a $1, and it was as good as a pap smear. When we talk about cost effectiveness,
excellent. You see, that's the talk, whether pap test or PCR. But when we get the $1 PCR, that's good. But until we get it, let's do something. Let's do the pap smears. Let's encourage women to do the pap smears.
المشكلة ماهر مش هيك. Sorry, we don't have a good cytologist in Jordan to read the pap smear.
That's very easy.
لا ماهر, مشكلتنا بالأردن ما عندنا proper good cytopathologist to read the pap smear. صدقني أنا متأكدة أنا I do a lot of pap smears. يعني كتير قليل يلقطوا ال changes. We need a proper cytopathologist in Jordan. Training.
Also, this we can discuss at a very, very, length, regarding the training for cytopathology. That's no problem. I mean, في المدينة عندهم good cytopathology, في المدينة الطبية, في مركز الحسين في الجامعات في الprivate في. I don't think this is an issue. The problem is you want something that is good for 90% of your population. You don't want something that's good for only 5% or 2% of the elite population. Okay, they can afford to get the vaccine at 130 JD. You want something that when women go to the, family planning clinic to get that test done, it's an opportunistic type of screening.
It will be cheap. I am pretty sure that it's going to be cheap in the future. Yes. I mean, now with all the countries are involved in vaccine manufacturing, things will be different, I hope.
Now, if I have the choice, I will get the $1 PCR test for HPV rather than get the pap test.
It was tested against pap smear. It was as good as, because we know the
of course, it's even better. It's even better.
And $1. And the good thing about it, it should be done every 5 years, not every 3 years.
That's
So she
good,
will
yeah. And however, there is one disadvantage, which is you cannot get other types of cancer that are not related to HPV testing, to HPV by etiology.
True. So a woman needs 9 testing lifetime, so $9 in all her life for the cervical cancer screening.
And it can be self-collected as well.
It can be self-collected, yeah.
Yes, thank you very much, Dr. Mazen, Dr. Abir, Dr. Maher, and Dr. Ihab. It was really a very nice scientific evening. You really educated me personally. Thank you very much. And I will leave the mic to, I don't know, Suha, if you are still with us, to conclude the evening. And thank you very much again, everyone.
Thank you.
شكرا كثير، شكرا. Thank you everybody على البرزنتيشن. رح احكي بالعربي لانه ما فيش حدا هلا بالدنيا اخر النهار. فبس شكرا كثير عن جد، يعني محاضرات ما بعرف شو بدي احكي، يعني كثير رائعه. واي ثينك انه ان شاء الله احنا يعني نقدر نعمل شيء بهاي البروسيدنجز تبع النقاش تبع اليوم. كثير في حكي، اكيد ما رح يكفي 5 أو 10 دقائق. احنا عم نحكي عن موضوع كثير صعب، واحنا الموضوع هذا حكينا فيه مش اول مره، يمكن هاي ثالث مره تقريبا بصير احنا على، في ناس موجودين وفي ناس لا، بس حكينا بهذا الموضوع. اي ثينك انه انا اللي حسيته هالمره انه هاي تقريبا ثالث مره بنحكي، انه انا حاسه لا بالعكس انه عم بتغير. I think انه في، ويمكن زي ما حكى دكتور مازن انه في agreement بسبب الكورونا على موضوع الفاكسين. بكل بساطه يعني انا as a radiologist واللي بشوفه، انتم بتحكوا معنا ارقام، بس بهالارقام الصغيره اللي حتى من هذا الرقم، الارقام اللي بتيجي على مركز الحسين، الادفانس كيسز، horrible cancers، يعني انا بسال حالي why would I let somebody يعني suffer in that way بشيء كان ممكن يكون preventable؟ يعني مش، ما في منطق بالموضوع انك تقول لا والله ما بدي لانه الرقم عندي قليل. هذا واحد. بعدين احنا we don't deal with numbers. يعني انا بستغرب ليش بس بموضوع السيرفيكال كانسر بيجي انه هذا الرقم قليل وهذا الرقم كبير. وحتى الكوست افكتفنس، يعني هو مش بس فند واحد احنا عم نقسم منه. يعني احنا عم نحكي عن السيرفيكال كانسر سكرينينج، انا ليش عم بفكر وين بده يجي الفند؟ يا I don't know، يعني ما هو موضوع كثير كبير. و I think tomorrow رح يكون في discussion على هاي المواضيع اذا بتقدروا. انا بعرف انه المعظم بيشتغل بالبرايفت سيكتور ويمكن صعب كثير انه بكره تجوين، بس anyhow احنا زي ما حكينا حنعمل proceedings ونفرغ المعلومات ونبعثها بويرد فايل، وممكن كل واحد يضيف اللي عليه ونشوف ايش بدنا نعمل فيها بعدين. We're gonna do this يعني ان شاء الله من هون ل8 أسابيع we'll circulate it ونشوف كيف بده يصير. بدنا نجرب نعمل هذا الشيء ان شاء الله انه يزبط، وانا متامله انه يزبط، وwe'll see يعني ان شاء الله انه هذا يقدر يقنع المسؤولين. احنا اليوم كنا محظوظين انه كان معنا دكتور عمر النمري، وانا متاكده انه هو راح يدعمنا بموضوع الريجستري ويكون عندنا عن جد شيء evidence based على الاردن. حتى the lack of يعني the lack of انه ما في عندنا داتا واضحه بالريجستري، هذا لحاله سبب بسيط انه نقدر نشتغل. وما بدي اعطلكم وتصبحوا على خير، ونشوفكم بكره للي بحب يجي. باي ذا واي الشات وكل الاشياء اللي صارت اليوم كلها مسجله، ما عدا المحاضره الوحيده، يعني ما بدي اضحككم، المحاضره الوحيده اللي ما تسجلت اليوم هي محاضره جوزي عن غير قصد. ف everything موجود، الشات موجود، وبشوفكم على خير بكره. تصبحوا على خير.
Good night. تصبحوا على خير. Good night everyone. تصبحوا على خير. شكرا.
يعطيك العافية.
يعطيكم العافية.